What is the evidence of pirfenidone? First two trials were done in 2020. Meher et al. And Relief. Relief trial was stopped prematurely because of low recruitment, probably due to COVID. But in this also, it showed significant improvement with pirfenidone in FVC % predicted and absolute FVC level. Now, the latest meta-analysis was done by Young et al. And they assess absolute change in FVC, all-cause mortality, and adverse event. So, they had 7 randomized control trial, around 1200 patients were there, 5 studies for pirfenidone and 2 studies for nintedanib, and 4 studies were low risk of bias. These groups are, above studies are low risk of bias, and here you can see that the absolute change in FVC favors antifibrotic drugs. So both antifibrotic drugs work. But here you can see that there is no benefit. It is in the center, or the points are in the center. So there is no advantage in all-cause mortality with antifibrotic, though it prevents the disease progression. Again, adverse events. 9 studies with around 1900 patients, meta-analysis of 5 trials showed similar serious adverse events around risk ratio 0.83, and 4 studies with progressive fibrosing phenotype, risk ratio is 0.90. So it is around 1. So it is like there are no significant adverse events in fibrotic group as compared to control group. So this is my presentation and finish. At last, I would like to have a question. Which one of the following statement is right about antifibrotics? Antifibrotic is indicated only in IPF. Antifibrotic can also be used in progressive pulmonary fibrosis. Antifibrotic can be started upfront in any ILD, and antifibrotic increases the incidence of serious adverse events. સત્તાવન ટકા લોકોનું focus is 57% people have good focus. So take home message is antifibrotic decreases the rate of progression of ILD even in non-IPF patients. Strength of evidence is moderate for nintedanib and low for pirfenidone. Upfront combination with immunosuppressant and antifibrotic is not much preferred. You can start antifibrotic once there is a progression. Unless primary diagnosis is idiopathic pulmonary fibrosis, then you can start upfront antifibrotics. However, antifibrotics may be administered sequentially if fibrosis is progressive, and antifibrotics can be given with other immunosuppressants with no major increase in adverse events. Thank you.
Dr. Amit, now I will invite Dr. Bhavesh Thakkar to give his talk on the MSLD.
Good morning all. Presentation waiting. I am going to talk on very common scenario that we all come across in day-to-day practice. To start with, there are no financial disclosures. MASLD, that is metabolic associated steatotic liver disease in day-to-day clinical practice. What a clinician should know. This I have kept because what questions patient asked me, based on that I have made a presentation. So prevalence of non-alcoholic fatty liver disease, the previous name was NAFLD, now MASLD in India. Among adults it is a 38.6% and among children it is 35.4%. It is very well rising globally also. What is the definition of MASLD? It is a hepatic steatosis associated with one or more of cardiometabolic risk factor. We all know what are cardiometabolic risk factors, and all the practicing physicians know this is as per guidelines. Why name change was needed? Name change reflects the metabolic dysfunction as a central driver, improves disease recognition because we have not to see only liver, we have to see a whole cardiometabolic risk factors, and it removes the confusion of alcohol and non-alcohol as a demarcation. What are the tests, basic tests that we need in a clinical evaluation? Basic parameters like CBC, liver function test, renal function test, metabolic profile like HbA1c, lipid profile, TSH, viral markers, hepatitis B and C. Ideally, in this scenario, if a patient has a fatty liver and with other factors, anti-HBC total code to rule out occult hepatitis B, and whether patient is vaccinated or not, anti-HBS, and ultrasound abdomen that will decide further. What are the risk stratification? Based on the parameters that we see here, every clinician should measure at least FIB-4 score. That is online available, that comprises AST, ALT, age, and platelet count that we commonly have as a parameters. If FIB-4 score is high, that is more than 1.3, then we need to consider for fibroscan. If it is less than 1.3, may not need further evaluation if other cardiometabolic risk factors are not there. And then if that value is more than 1.3 or more than 2.6, fibroscan is needed. When a patient should be sent for fibroscan, if a patient comes to you with fatty liver on ultrasound abdomen, when you should order for a fibroscan? Fatty liver with elevated liver enzymes, FIB-4 score of 1.3, diabetes, dyslipidemia with family history of liver disease in form of cirrhosis or hepatocellular cancer, fatty liver with low platelet count, that is a part of FIB-4 score. So platelet counts, if low on CBC, that raise an alarm. This patient should be sent for fibroscan. What are the day-to-day questions that patient ask me or what we usually come across? A patient with fatty liver asks a doctor, I am having fatty liver and due to that I am on only boiled diet. Is it correct? Questions you have to answer, yes, fat is the cause of fatty liver. No, fat doesn't matter at all. Yes, fat should be moderated and should not be eliminated. Opinion. Still, I wonder that 1 and 2 option is there. Yes, it should. Option 3 is correct. Yes, fat should be moderated, not eliminated. What are the facts? Fat doesn't mean fatty liver. The real culprit of MSLD is excess refined carbohydrates in form of sugar, white rice, white bread, ultra-processed foods. Sugary beverages should be big no. Soda, juices, sweetened beverages, tea, coffee that includes milk and sugar. Trans fat and excess saturated fats create trouble. Balanced fat intake is essential. Extreme fat restriction will worsen insulin resistance and we may develop fat-soluble vitamin deficiency. So we have to moderate that. These are the type of dietary fats we come across in day-to-day life, and we see that number of trans fat food intake is increasing. Saturated fat food intake is increasing because of fast culture. Fat should not be eliminated, but it should be moderated. 30% of total calorie has to be from fat. Saturated fat should be less than 7 to 10%. Trans fat should be ideally 0. Good fat, bad fat, ugly fat, that means mufa, wufa are good fat. Trans fat should be avoided. What about non-vegetarian diet that I come across in day-to-day practice? Patient asks, I eat biryani, butter chicken, fried fish. Is it okay? How will you respond? Number 1 is yes, because non-vegetarian food is a good source of protein. Number 2, yes, but only white meat in form of chicken, fish. Avoid red meat, that is mutton, lamb, pork, or as it can worsen metabolic health. Option 3 is yes, but avoid creamy gravies, fried preparations. Eat grilled, roasted, or steamed non-veg for healthier options. Opinion. option C. Lean, high-quality protein from chicken, fish, egg is beneficial for MSLD patients. Adequate protein intake helps to preserve muscle mass and improves insulin resistance. Red meat in form of mutton, beef, pork should be limited. It leads to insulin resistance and liver inflammation. Processed red meats are even worse due to preservatives, trans fats, and should be avoided. Cooking method also matters. Avoid deep frying, creamy gravies, overcooked or charred meat. Prefer grilled, roasted, or steamed proteins. Yogurt-based marinades are good, minimal oil. Now, next question we come across on data. Which oil should we use? Olive oil is best for MSLD. Sunflower oil is healthier for MSLD than mustard oil. Mustard oil is better suited for Indian cooking and healthier choice than refined oils like sunflower oil. A mix of oil is ideal. No single oil is a perfect. So rotating between mustard oil, olive oil, groundnut oil is best. Opinion. Yep. So for regular Indian cooking, I have mentioned here which oil where we should use. Like we use usually for tadka, sabzi, sorting, dal fry, shallow frying. Groundnut oil
5 minutes
is
remaining.
best all-rounder. I mentioned why. Rice bran oil is very good for heart. Sunflower oil refined, light in taste, good for sorting, but we have to rotate. Olive oil is good for light cooking and for salads. Mustard oil is high in MUFA and high omega-3. It is good for metabolic health. Avoid or limit refined oils because they are not good for health. Best practice, no single oil is best oil. Rotate oils monthly. Preferred approach is groundnut oil, mustard oil, and rice bran oil. We have to rotate serially. What about ghee? We Indians are fond of ghee. What is your opinion on ghee? One, ghee is good. Ghee clogs artery and bad for heart health as well as for MSLD. Should stop completely. Ghee is good for health and contains lot of MCT. Opinion. Yeah. Potential benefits of ghee are that it's rich in short-chain fatty acid like butyrate, which supports gut microbiome. It contains omega-3 and conjugated linoleic acid. But for ghee, my verdict will be moderation is the key because it is high in fats, so it will increase LDL. Verdict on ghee is it is not a poison, it is not a medicine. Moderation is the key. And we love butter also. We usually see, but butter is also high in saturated fat. It raises LDL. It should be used occasionally, not for cooking purpose. Exercise. Exercise is a non-negotiable therapy for any MSLD patient. It improves liver fat even without weight loss. Aerobic and resistance training both are effective. Prescription should be in form of 150 minutes of walking per week, aerobic exercise, resistance training 2 to 3 days per week, 8,000 to 10,000 steps per day is alternative. Yoga should be adjunct, it cannot be a replacement. Simple algorithm, sedentary lifestyle, start walking, metabolic syndrome, add aerobic exercise. If sarcopenia is there, you have to add resistance training, busy professional, 10 minutes of walking 3 times per day is also alternative. So my take-home message is MSLD is not a metabolic disease. It is total a metabolic disease. It is not only the liver disease. Risk stratification has to be done on the presentation. Dietary advice be there and it has to be practical advice. Exercise works even without weight loss. General practitioners are the front line for the diagnosis. Thank you.
Can I have one question, Anis bhai?
Forum open for questions and answers.
Anis bhai, two
We'll have 2, 3, 4 questions or comments.
I have not covered here management aspect because it is there tomorrow evening in symposium.
So, Bhai, the right from fatty liver to hepatocellular carcinoma, at which stage it is reversible?
At which it is reversible even at present even if there is F2, F3 fibrosis because we are going to have multiple medications. We have already multiple medications in pipeline that lectures are there today and tomorrow. So even if it is an early liver disease in form of F2, F3 fibrosis, it will be reversible if we modify the risk factors.
And from childhood to till 80, 90 years?
Yeah.
if there is a fatty liver or steatosis, would you refer patient to cardiologist because most common cause of death is cardiovascular?
Yeah. See, that's what I mentioned. As per the as per the definition, we have to see as a cardiometabolic risk factor with fatty liver. If patient is having only fatty liver, no other risk factors that are there in metabolic syndrome. If there are no risk factors, then only dietary and lifestyle changes are enough. We need not to refer. But if there are one or more cardiometabolic risk factor, depending on what is the risk factor, we have to decide and stratify.
To Dr. Bhavin Dalal, how does irregular sleep pattern, means irregular schedule or a night shift or means work shift if change, then it impacts sleep. How does it impact sleep?
The irregular, so there, I think the question, if I understand correctly, irregular sleep pattern and
No.
irregular lifestyle.
Shift means work shift. If it is
Oh,
night
work
shift, day
shift.
shift, yeah.
Okay.
If students and residents also they are doing means different shifts as well as for workers also, some employee also.
Definitely, I mean, there are multiple studies which shows that the people who are doing the shift work, their sleep is affected, and if the sleep is affected, their all other problems which I mentioned are affected. Fortunately, if for the residents and fellows or the trainees, like while they are students, it's a time bound, right? They do residency for 3 years, fellowship for 2 or 3 years. Then again, when the opportunity permits, usually they should go back to their normal sleep hours or a normal sleep pattern or normal sleep hygiene. But the people who don't have a choices, for example, fire workers or even the doctors, for example, emergency medicine doctors throughout their lifetime, they just do the shift work again and again, and their sleep is definitely affected. We do see a lot of shift work disorder patients. They have a more vigorous lifestyle modification. Like I used to work for the night shift for almost 1.5 years. So then during that time, I have to design or I have to disciplinize myself even more than what I'm doing currently in a routine work. But I mean, there's no choice.
My question to Dr.
Question
Amit
to Bhavin Bhai is related to sleep.
Hello.
Suppose the patient is sleeping 5 hours at night and then compensates the 2 hours at the daytime, or at the weekend if the patient tries to compensate, whether it is going to benefit or not.
Yes, if the patients are actually taking naps, in the study which I showed you, they have compared the people who are taking naps versus not taking naps during the daytime. There are less number of cancers. Although I will say that if you can maintain the sleep in a one block, it's better. For example, what you are saying is 5 plus 2 hours versus I will say a same 7 hours of a sleep. Because remember we learn in a physiology during the first year that the sleep goes from non-REM to REM sleep. So for example, the first 80 or 90 minutes of the sleep would be non-REM sleep. Then you will have a block of a 20 or 30 minutes of a REM sleep. Then you have a 60 minutes of a non-REM sleep and 40 minutes of the REM sleep. So when the night advances, your REM sleep goes up and up and up. REM sleep occupies only 20 to 25% of the total sleep, but it is more important for well-being and functioning. So if you break the sleep from 4 and 4 or 4 and 3, your REM sleep and a deep sleep component will go down.
My question to Dr. Amit Patel, is there any contribution, of course there is a contribution of air pollution in interstitial lung disease. So how much is the contribution and what can we do, because air pollution is becoming a big problem, especially in our country.
Nothing is documented, but as chronic hypersensitivity pneumonitis is the most common disorder in India, so it is plausible that there is some contribution of air pollution. Bhavin Bhai can add something, but it is possible, but it is not documented and it is not proven.
I agree with Amit. I think that as far as the ILD itself is considered, we don't have a great or a strong relationship of air pollution in a specific type of ILD. We definitely know that the lung health in general, for example, more asthma or COPD can happen due to air pollution, which we will put in a different bucket instead of the ILD. I am not aware of that specifically.
So we take the last comment from Dr. Siddharth
5
Mawani.
minutes
This is
remaining.
Dr. Siddharth Mawani. My question to Dr. Bhavindalal, sir. So, as per your talk, sleep deprivation can cause many problems except pregnancy. So, does that mean should we be more liberal on our prescription regarding its, say, sleeping pill parts? So, can we prescribe them more frequently? Like it happens quite frequently in middle of night. Say, 2 વાગે અમને ફોન આવે કે સાહેબ ઊંઘ નથી આવતી.
એમને ઊંઘ નથી આવતી, તમને નથી આવતી?
એ અમને અમારી ઊંઘ બગાડે.
Okay. I will comment in two parts. The first part, should we prescribe more sleeping pills? Absolutely not. More sleeping pills are actually causing more problems, especially after the age of 65. 1 in 5 patients are admitted in hospital just because of the side effect of the medications, and the sleeping pills are on a top of those things, top of those group of the medications which can cause more problems. Sleeping pills itself are actually associated with a more dementia, which I think Neil Bhai will probably agree. We have studies. They are associated with a more fractures. So I will not say the prescription for insomnia is a sleeping pill. We don't have a talk this time, but the last year we had a talk on insomnia. The first recommended treatment for a chronic insomnia lasting for more than 3 months is actually cognitive behavioral therapy, good sleep hygiene, and avoidance of the stimulant substance and alcohol. So for example, if the people are saying that I cannot sleep after 2 a.m., for example, and they're suddenly waking up, what should you do? So the simple, like just a 30-second prescription should be do not look at the phone, the cell phone, the TV, tablet, media, no screen time. American Academy of Sleep Medicine, or actually every single recommendation is that people should avoid the screen time at least an hour prior to the sleep time and throughout the night. So no phone, no cell phone, no tablet, nothing. You use the restroom, for example, you drink some water. If you are not able to sleep in the next 15 to 20 minutes, which is an educated guess, you don't have to see the time, which is another great mistake people do. Oh my God, it's like 2 a.m. in the morning and I cannot sleep. I have to work tomorrow. The moment you see the time, it will generate the anxiety about insomnia, which will cause more insomnia. So don't see the time, approximately 15 to 20 minutes of a time. You are in a bed. If you are not able to sleep, stand up, go to the living room, go to the kitchen. Don't turn on the big lights, the small lights, dim lights. Do something what you don't like. For example, if you don't like the chemistry book, read the chemistry book for 15 minutes, 20 minutes, whatever the time. If you don't like a mathematical puzzle, do that on pen and paper, no screen. The moment you start feeling sleepy, come back to the bed and then sleep. This is known as a sleep stimulus therapy, and
2
that
minutes
will
remaining.
actually work eventually.
ટાઈમ છે એક કે તો હા બસ કે નેપ one thing I want to ask about that daytime naps. If a person slept for 7 hours and if still daytime nap helps in increasing productivity. And another question is that there is some gene, like તમે કીધું મોદી સાહેબ તો 4 કલાક જ ઊંઘે છે effectively, but I have heard there is some gene, I don't remember that gene. લાઈક શાહરૂખ ખાન બધાને એવું થાય કે મોદી સાહેબ ઊંઘે છે તો હું 4 કલાક કરીને બધા જે સીઈઓ ને હાયર પોસ્ટ ઓફ હોય કે હું બી એમના જેવો પ્રોડક્ટિવ થઈ જાઉં, બટ દેટ ઇઝ જીનેટિક્સ, they came with that genes, right?
Possibly, I don't disagree. See, remember, whenever you
but I have heard some sleep specialist only told me that there is one gene and he also forgot that gene.
No, I think there is a possibility of a gene, and there is something known as a light sleepers or the less sleepers or a high amount of sleepers. Remember, if you take a population mean of 100,000 people or 200,000 people or 1,000,000 people, you will have a mean range. The mean range is between 7 to 8 hours. Then if you deviate 1 standard deviation on both the sides, then you will cover around 67 or 68% of the people. You go 2 standard deviation, then you will cover 78% of the people. 3 standard deviation, 95% of the people. So that means there are people like Narendra Modi in a whole world of 8 billion people. There may be 4,000 people across the world who can be okay with 4 hours of a sleep. Although I will also comment on that you don't know what Narendra Modi is facing. Does he have a cancer? Does he have a diabetes? Does he have a obesity? Does he have a MASLD, what Bhavesh was saying? He might have that. We don't know that. So I think that's why I said don't take this comparisons. Just not only the productivity matters, your health also matters. I could be a productive, but I could be productive for 30 years of my life and then I die. So what is the sense of that?
Thank you. Thank you very much, all the
Thank
speakers.
you very much, all the speakers. Yeah, Tejas.
All the chairpersons and moderators. For the next session, we need to move on for the next session, and I would like to invite Dr. Hiren Kevadia. He is cardiac electrophysiologist in our group, working in the Marengo Sims Hospital, arrhythmia and device expert, and he would lead the next session.
Good morning to all. A very good morning to all. So for the next session, I would like to invite as a chairperson Dr. Dilip Vyas, Dr. Harshad Patel, Dr. Neil Mehta, Dr. P.N. Acharya, Dr. Ramesh Gowda, and Dr. Vimal Prajapati. And as moderators, I would like to invite Dr. Bhavesh G. Patel, Dr. Darshak Salat, Dr. Jinesh Shah, Dr. Sheetal Patel, Dr. Vipul Kapoor, and myself, Dr. Hiren, as a panelist. And I would like to invite Dr. Dhaval Naik if he is there as a panelist.
Yeah. So by the time all the panelists and moderators and chairs come, I request Dr. Hiren Kevadia to please come on the dais here and talk about appropriate use of anti-arrhythmic drugs in emergency room. Dr. Hiren has been an excellent, young, very fast coming up electrophysiologist of the state and country, and he contributes a lot to the academics which we do at SIMS. Dr. Hiren.
A very good morning to all. So today's topic is appropriate use of anti-arrhythmic drugs, and I would like to keep it more of a case-based, and it's used in emergency room. I don't have any disclosure. So the question is that a young male with structurally normal heart with normal ejection fraction has present to emergency room with the history of palpitation and ECG is showing tachycardia, and which of the following is the drug of choice for acute management? So do we have timer here? All right, so I think there is no timer, but that's fine. We'll see this in the last slide. So so we know that we have anti-arrhythmic drug group of drugs, class 1, class 2, class 3, and class 4. Class 1 is divided into 1A, 1B, and 1C. So there is a list of drugs, almost 10, 15 drugs, which is available for us to use for the management of arrhythmias. But which drug should be used at what time to get the best result in a short duration? That's the reason I'm going for this presentation. So case number 1 is a young lady with recurrent palpitation, and ECG is showing this one. So it's a narrow complex tachycardia, and we can see that there is no P wave visible before QRS complex. And it is most likely a supraventricular tachycardia, and the possible mechanism here may be an AV nodal reentrant tachycardia, where there is a slow pathway into the AV node itself, and that leads to circuit mechanism and leads to AV nodal reentrant tachycardia. Case number 2 is a young boy with recurrent palpitation with baseline ECG showing pre-excitation. So very clear delta wave, it's a WPW syndrome. And the same patient can come with the palpitation in emergency room. Again, a narrow complex tachycardia, there is no visible P wave before QRS complex. The only difference between the previous ECG and this is there is significant STT changes. There are significant ST depressions in a young male with palpitation. So when there are significant ST depression and narrow complex tachycardia in a young patient, the most likely mechanism is atrioventricular reentrant tachycardia. It's an AVRT because of bypass tract, okay? And here a diagnosis is atrioventricular reentrant tachycardia. Now the question is that what should be our management strategy when the patient comes in emergency room? So what should be the first
approach. So definitely we should go for a vagal maneuver in form of carotid sinus massage as a first approach. But if it does not respond to that, what should be the next choice? So the next choice should always be injection adenosine 6 milligram IV bolus followed by a saline flush. So that should be the acute treatment of choice. And we should always, it does not end with the just giving adenosine. We should document the response to adenosine. And we should always get an ECG. So because ECG 12 channel will not work, you should always have a defibrillator with you, and a defibrillator rhythm strip should be on while you give adenosine to document the adenosine response. So without defibrillator, we should not give adenosine. So defibrillator should always be there. So when AVRT patient has been given injection adenosine, and the response rhythm strip will show like this. So we can see that narrow complex tachycardia is going on, then there is a transient AV block with some PVCs. There are non-conducted P waves, and then AV nodal conduction has started and sinus rhythm has been achieved. So that's how adenosine is going to terminate the AVRT by transient AV block, all right? And it is very important that we should document this response. It helps in diagnosis also, not only therapy, it helps in diagnosis, like in this case where there is narrow complex tachycardia, very rapid. And now it can be SVT also, very well we know that, but sometimes it can be some other arrhythmias, which are atrial arrhythmias, which are not AV nodal dependent arrhythmias, and we may not have diagnosis until we document the response. And when we give adenosine, there is a transient AV block, and during transient AV block, if there are waves visible, it may be P waves, it may be flutter waves, if they are visible during that time and the tachycardia resumes after adenosine effect is over, that helps us in getting diagnosis that this is not supraventricular tachycardia nodal dependent, this is AV nodal independent, atrial flutter with fast ventricular rate where it may be 1-to-1, 2-to-1 conduction, and P wave may not be clearly visible. And we might think that it's just a simple SVT, but it's not SVT, it's flutter with fast VR. So case number 3 is a lady with palpitation and easy fatigue. From the ECG, diagnosis is very clear. There are flutter waves visible into the inferior leads, and they are very typically sawtooth appearance. So it's a typical flutter, cavo-tricuspid isthmus dependent. It arises from right atrium. Okay, so the most common location of atrial flutter is right atrium, and usually it is a counterclockwise circuit moving, which we can see into the right figure, moving in a counterclockwise pattern. So it's a typical atrial flutter. Case number 4, elderly male paroxysmal palpitation. Again, it's a narrow complex tachycardia, and when we see the rhythm strip, there are multiple P waves than the QRS complex. So P waves are more than QRS complex, and if you see, there is isoelectric line between the P waves. So it is not like a continuous sawtooth pattern, there is isoelectric line. So whenever there is isoelectric line between the two P waves, it is atrial tachycardia. And when there is no isoelectric line between two P waves, and it is almost like a continuous sawtooth patterns, it's atrial flutter. That's the difference between atrial tachycardia and atrial flutter on ECG. And usually they are focal atrial tachycardias, can come from pulmonary vein, can come from appendages, can come from crista terminalis also. So it's a focal atrial tachycardia. Case number 5 is a 70-year lady with hypertension, diabetes, and palpitation, and ECG is showing irregular QRS complex, narrow complex. If we see here, we can see some P waves. Sometimes people tell it's a flutter or something, but we can see the P waves, and the P waves are not having a clear morphology. They are pleomorphic P waves. So whenever there is irregular rhythm, and the P wave morphology is not single and it is a pleomorphic, it is usually atrial fibrillation. So this should be told as atrial fibrillation with fast ventricular rate. So that's how. So we have three arrhythmia situation here. Either it is atrial flutter, or it is atrial tachycardia, or it is atrial fibrillation. The 2 treatment protocols we have for such patients in emergency room. Number 1, we just want to control the heart rate. That means ventricular rate. That is known as a rate control strategy. And rate control strategy is also a very good strategy. It gives immediate symptomatic relief to the patient, where arrhythmia is just going on, but we are just controlling the ventricular rate, and that works by blocking AV node. Obviously, we want to block AV node and get less ventricular rate, and usually our target heart rate at rest, we want to achieve less than 100 beats per minute. That will give significant symptomatic relief immediately. And the drug of choice we have 4 group of drugs. Number 1 is beta blocker. Number 2, digoxin. Number 3 is non-dihydropyridine calcium channel blocker like verapamil and diltiazem. And 4th is amiodarone. And we should remember the contraindication when there is severe COPD and asthma, we usually avoid beta blocker when we go to other medicines. And when patient is having heart failure with reduced ejection fraction, especially EF less than 40%, we usually avoid verapamil and diltiazem and go for other choices. And amiodarone is always a last choice for rate control therapy. And suppose if we want to go for a rhythm control strategy where we want a sinus rhythm back, especially in young patient with structurally abnormal heart, for getting sinus rhythm back, when the patient is having a structurally normal heart, the first drug of choice for injectable therapy is always injection ibutylite. So that should be the first drug of choice as an injectable therapy. It's a class 3 antiarrhythmic drug. And when there is prior MI or structural heart disease or heart failure with reduced ejection fraction, our first drug of choice should always be injection amiodarone for getting a rhythm control strategy. And sometimes we use pill in the pocket where patient is having paroxysmal arrhythmias. They can keep flecainide or propafenone tablet in their pocket and they can take 2 tablets of it whenever they get a palpitation. So that is known as a pill in the pocket therapy. Now, I just move to case number 6, 67 male, old interval MI with ejection fraction of 35%. And if patient comes to emergency room with this ECG, it's a very clear, wide, complex, regular tachycardia in an old interval MI. It's a monomorphic scar VT, correct? It's a very clear. And what should be the drug of choice for monomorphic scar VT? It should be injection amiodarone. Definitely, there is no doubt about it. But again, a 60-year male with acute anterior MI recently evolved. It is less than 48 hours duration with ejection fraction of 35% and is having this arrhythmia. It's a polymorphic VT. So it is known as ischemic VT. It is a polymorphic VT. There is no mature scar here to make it a reentrant circuit. And what should be the drug of choice for this patient? So polymorphic ischemic VT, the first drug of choice is always a Zylocard or a lignocaine injection for termination of arrhythmias. And amiodarone here should be the second drug of choice. Case number 8 is a 25 male with structurally normal heart. This was that first question ECG. It's a wide complex tachycardia but relatively narrow with a right bundle and left axis tachycardia. So we should know the morphology of tachycardia. It should not be just that it's a wide complex tachycardia. It's a wide complex tachycardia with right bundle and a left axis, but it is a relatively narrow complex tachycardia in a young male with structurally normal heart. It is usually idiopathic left ventricular tachycardia. And what should be the drug of choice here? That was the question. And the drug of choice is verapamil, nothing else. It is also known as a verapamil sensitive tachycardia. So this is only one ventricular tachycardia where the drug of choice is verapamil, which we usually use for the supraventricular tachycardia. And if you give verapamil here, the tachycardia will terminate within 5 to 10 minutes. If you try amiodarone here, VT will terminate slowly within 1 or 2 hours. So if you want to get rapid control of arrhythmia, verapamil should be used for this patient. Case number 9 is a 40-year lady with structurally normal heart, again with ejection fraction of 55%, and is having such a non-sustained VT, repetitive monomorphic VT. It is known as RMVT. And if you again look at the VT morphology, it's a left bundle morphology with inferior axis. You can see the tall R wave in the inferior leads, and this is known as outflow tract ventricular tachycardia, and the drug of choice for outflow tract ventricular tachycardia is always a beta blocker. If you give beta blocker, patient will respond immediately to the arrhythmia. Case number 10 is a 35 lady with structurally normal heart with ejection fraction 60%, GERD on multiple drugs like prochlorperazone, domperidone, etopride, ondansetron. She was on multiple drugs because of that persistent GERD and significant vomiting and nausea. She was prescribed a lot of drugs to control it, but then what happened? She had a recurrent loss of consciousness, short episodes of seizures. A short CPR was also given by the husband when patient was on the way, and when patient came to the hospital, this was happening. So patient was developing recurrent torsades de pointis. And when the cardioversion was done, this was the rhythm strip where the QT was significantly prolonged. So what is this basically? It's a polymorphic VT with long QT syndrome. This is nothing but this is torsades de pointis, and the most common reason is usually acquired long QT because of drugs like antacids, and a lot of drugs were given which has prolonged QT. And because of vomiting, she had hypokalemia also. So long QT prolonging drugs plus hypokalemia, And sometimes females can have, anybody can have a congenital long QT syndrome which was unmasked, and it can be congenital long QT syndrome also together. So for this patient, when I went for genetic testing, this patient had a KCNH2 mutation. So she had an autosomal dominant congenital long QT syndrome type 2 also. So she had a long QT syndrome 2, she had multiple drugs for GERD, over and above she had a hypokalemia and ultimately led to polymorphic VT storm, and the drug of choice here is injection magnesium sulfate, nothing else. It should be magnesium sulfate followed by Xylocard, and amiodarone is actually absolutely contraindicated in this patient. So if we give amiodarone in this patient with a long QT and polymorphic VT, this patient is going to deteriorate and will not be able to control her arrhythmia. So this is one VT where amiodarone is absolutely contraindicated. You should always remember when you should not use amiodarone. Thank you.
Okay, thank you. Good morning. We'll go to the next speaker, the Dr. Siddharth Mavani. The topic is matching pair, unlocking the power of combination use of finerenone and SGLT in cardiac renal protection.
Yeah, good morning to all. No financial disclosure for this lecture. So according to me, second most world-known triangle is Bermuda Triangle, now which is led by this triangle, that is a triangle of diabetes causing heart and kidney dysfunction. And it is a global problem and most commonly talked. As it is now very well established, type 2 diabetes is leading risk factor for onset as well as progression of cardiovascular dysfunction as well as kidney dysfunction. So as can be seen, 2 to 3 times higher risk of cardiovascular disease as well as hospitalization and reduced survival in type 2 diabetes patient. And as we can see in CKD, almost 4 individuals out of 10 of type 2 diabetes are having albuminuria and 10 times higher risk of kidney failure. And that is why we are talking about this triangle quite oftenly, and we try to come up with different solutions. And one such kind of solution that I'm going to talk today is combination use of finerenone and SGLT2 receptor inhibitor in cardiorenal protection, unlocking the power of combination. So we are knowing individually both of these molecules are cardiorenal protective, but what would happen if we use them as a combination, as a de novo therapy? So let us start with a case. Mr. C.K. Shah is a 60-year-old gentleman suffering from type 2 diabetes since last 6 years with hypertension, who came to my OPD. He is complaining of mild fatigue and swelling on the legs. His creatinine was 1.6 and UACR was 352 milligram per gram. So he was asking me how bad it is. It is mild, moderate, or severe. So as a spinal reflex, I told him this is a mild dysfunction. So whether I'm right or wrong, I would like to take your opinion. So which is ideal investigation for quantifying kidney function in your clinical practice? A, serum creatinine, B, GFR estimation, C, cystatin C, or GFR and UACR? Your opinion? Okay, I will give the answer of a few slides. So the patient, coming back to the patient, his creatinine is 1.6. I did his GFR calculation, and that was 64 ml per minute. So this 64 I kept in this staging system, and it came to stage 2, that was 60 to 90, so it was mild. So I was right. Really, I was right. Let us check again. So this is a heat map given by WHO, and if we put this 64 GFR, he is falling in this low risk zone. But this is a complete picture. eGFR value measures kidney function. But what about kidney damage? In typical diabetic kidney disease, risk of CKD as well as CVD progression is underestimated if we use estimated GFR alone. So what we are missing here is UACR, urinary albumin create ratio. If we put that 352 milligram figure here, then he is falling in orange zone, so he is at high risk. My diagnosis or my telling him that you are having mild risk was wrong. So USER is an important surrogate marker of kidney disease progression as well as predictor of cardiovascular outcome. And as can be seen, if you reduce USER by 30%, you can reduce 27% risk of kidney composite outcome as well as cardiovascular end outcome. So that is why guidelines recommend eGFR as well as USER testing at least annually in all patients with type 2 diabetes, and you can do it in single voided spot urine sample. So all of you were right. Correct answer is eGFR as well as USER estimation for clinical evaluation of kidney function. So now it has been very well proved that it is not a single method or single pathology which is causing progression of kidney disease or heart dysfunction in diabetes. It is multiple factor. There are multiple factors including hemodynamic perturbations, metabolic dysregulation, inflammation, and fibrosis, and that is why we are requiring different kind of medication starting from RAS inhibition, SGLT2 receptor inhibitor, finerenone, and potentially GLP-1 receptor antagonist. So multiple pathway means multiple therapeutic approach. So what our current guidelines are suggesting, apart from lifestyle modification, that is smoking cessation, nutritional care, regular exercise, there should be multi-dimensional approach of medication, and that should be in combination. So standard of care as of now is RAS inhibition followed by SGLT2 receptor inhibitor, and now newly added finerenone. So Fidelity and EMPA kidney, both finerenone and empagliflozin led to decrease in UACR as an individual component. So Fidelity data showed there was 32% reduction in UACR at the end of 4 months compared to placebo, and EMPA kidney showed 19% reduction at the end of 2 years compared to placebo. So individually, both of them are reducing UACR, but what happens if we use them in combination? So there is no significant amount of data. There is a Fidelity subgroup analysis which showed some population, that was around 7% of population, was on SGLT2 receptor inhibitor before we started finerenone. So they showed there was a significant reduction of proteinuria compared to finerenone alone, that was from 31 to 37%, and that was also proved in real world analysis. So guidelines currently are saying you can add finerenone to existing ACE inhibitor and SGLT2 receptor inhibitor. So all guidelines are suggesting sequential addition of SGLT2 receptor inhibitor and finerenone, but is there any data for their combined use as a de novo therapy at start of this therapeutic approach? So can we look beyond current guidelines? That is what our question is. Because the risk of progression to kidney failure, heart failure, and death can be dramatically reduced by combination of therapy, that we can see by this blue bar. If we use combination of therapy, then you can reduce hospitalization by heart failure by 3 years, all-cause death by 2 years, kidney failure by almost 5 years, and composite kidney outcome by 6.7 years. So combination definitely can be of use. So that is why more rapid approach to initiate combination therapy has been proposed. So this is a traditional conservative approach where you are starting ACE inhibitor, wait for 3 months for UACR reduction. If there is no improvement, you add SGLT2 receptor inhibitor, and then after 6 months, you are adding finerenone. But instead of that, you can have accelerated or rapid sequence approach where you can start combination and then subsequently add or titrate the dose. So in whom you would do this? Those who are at risk of high risk or very high risk, and that you can stratify by using heat map that we have seen early. So any evidence for using combination? So is there any evidence that can say this combination is effective as well as safe? So yes, there is recent published data in NEJM 2025 confidence trial, which was led by Dr. Rajiv Agarwal, where combination of SGLT2 receptor inhibitor with finerenone was used. This was randomized, double-blind, double-dummy, multicentric, 3-armed parallel group study. After randomization, that was 1 gem, 1 gem, 1 randomization. 3 groups were there, finerenone, 10 or 20 milligram with EMPA 10, finerenone with placebo, EMPA with placebo. Study duration was of 6 months and followed by 1 month of observational period. Primary efficacy endpoint studied were change in UACR from baseline to 180 days in combination versus EMPA group, combination versus finerenone group, secondary safety endpoint, eGFR changes, and adverse event. Eligibility criteria, all type 2 diabetic with HbA1c less than 11, eGFR between 30 to 90, proteinuria more than 100 and less than 5,000, and well-controlled potassium. So these are diverse range of patient, high comorbidity burden. Most important part of this slide is 47% population were Asian, and out of them, highest recruitment was from India, that was 16.6. So we can say this is adequate Indian data. So what happened to UACR? There was 30% reduction in UACR after starting on 14th day. If we continue the therapy, 35% reduction at 30 days, 49% reduction in UACR at 90 days, and 52% at the end of 180 days. And when we stopped the therapy, there was a rise of UACR to baseline. What happened to blood pressure? There was a dip in blood pressure, 6 to 8 millimeter fall in blood pressure at the end of 14 days in combination group. Then it was stabilized throughout the study period, and when we stopped the therapy, there was again rise of blood pressure. The most feared complication or possible side effect was fall in GFR, and that was more marked in combination group. At the end of 14 days, there was fall of GFR by 7 ml. Then there was a mild rise up to 30 days, and then subsequent stability was there. And when we stopped the therapy, there was again rise of GFR. So that suggests this is a hemodynamic effect. If this would be a nephrotoxicity, there would be continuous drop in GFR, and there would not be rise in GFR after stopping the medication. So it is more of hemodynamic change. Safety aspect, hyperkalemia, which was more marked in combination compared to EMPA, but lesser than finerenone. It might be because of caliuretic effect of empagliflozin. No cases of hyperkalemia led to hospitalization, severe adverse event, or death in any treatment group.
2 minutes remaining.
So what we have seen in confidence trial, GFR decline was hemodynamic effect with no serious AKI, overall AE profile similar to that other agent alone, and hyperkalemia with no hospitalization, SAE, or death due to hyperkalemia. So in conclusion, finerenone is an essential treatment pillar for diabetic kidney disease. Its early combination with SGLT2 receptor inhibitor should be considered as an optimal approach to rapidly reduce proteinuria, which is otherwise surrogate marker for progression of chronic kidney disease as well as cardiovascular outcome in type 2 diabetic CKD patient. So at end, I wish to conclude my session with Sanskrit slok, that is a Sarve Bhavantu Sukhinah, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kashit Dukh Bhag Bhavet, Om Shanti, Shanti, Shanti. Thank you.
Yeah, in the interest of time, we move on. The next speaker is Dr. Ankit Jidani. He's going to be speaking on when to suspect myeloma and related paraprotein disorder, and a physician's guide.
A very good morning. Thank you for giving me this opportunity to the organizing committee of JIC. So in the next 10 minutes or so, I will just give an overview on when to suspect myeloma and the related paraprotein disorders. So to begin, these are my disclosures there, nothing to disclose. So I'll begin with what are paraproteins. In our human body, there are different types of plasma cells, each producing one specific type of protein, which is a combination of a heavy and a light chain. In some individuals, because of some genetic abnormality, usually there is disproportionate proliferation of one particular type of plasma cell, and they produce one particular type of immunoglobulin, which is again a combination of heavy and a light chain or a light chain only. This particular protein is called paraprotein or M protein or M band. These proteins can be produced by plasma cells within the bone marrow as well as by lymphoid tissue. The B lymphocytes present in our body can also produce paraprotein or M band. Now, how do we identify them? Serum protein electrophoresis is one test which we all know about. This is a quantitative test. It can give us the value of the M band, M protein present in our body. Serum immunofixation is a qualitative test which tells us about the type of paraprotein present in our body, and it is more sensitive than protein electrophoresis. Serum free light chain assay is a very sensitive test in picking up the free light chain, the kappa and the lambda. It is so sensitive that it has taken away the importance of Benz-Jones protein, which we traditionally used to perform in urine. The prototype plasma cell disorder is multiple myeloma, and it usually passes through 3 stages. MGUS is the precursor condition, and the incidence which is estimated in general population is around 3 to 4% of the individuals beyond 50 years of age will have MGUS if we look for it. MGUS is an asymptomatic condition. There is just presence of silent paraprotein in MGUS. Smoldering myeloma is one condition in which the proportion of this paraprotein increases. However, the patient still remains asymptomatic. The risk of progression of MGUS to multiple myeloma is around 1% per year, whereas the risk of progression of smoldering myeloma to multiple myeloma ranges between 10 to 60% per year. Multiple myeloma is the end stage in which the patient actually ends up developing multiple symptoms. With this background, I will discuss a few cases. So, a 58-year gentleman presented with easy fatigue, weakness, on and off fever, and recent onset back pain. Clinical examination was grossly unremarkable except for symptoms of anemia. There was high ESR, derangement in renal function, LDH, uric acid were also raised. Serum protein electrophoresis is one common test which we all order and do. However, in this particular patient, it was negative. When we ended up doing a free light chain, the lambda chain was exponentially high and the free light chain assay was deranged. Which brings us to the point that if we look at the right side, each of these tests that are discussed, if they are done in isolation, the probability of picking up a positive paraprotein is close to 75-80%. However, if these tests are combined, it increases to beyond 95%. So whenever the index of suspicion of a paraproteinemia is high, the test should be used in combination, which is now offered by most of the labs in the city. So when a paraprotein is found, we do a bone marrow to quantify the proportion of plasma cells. However, just doing a quantification is not enough in the current era. These plasma cells are also subjected to some molecular and cytogenetic test, which helps us in risk stratifying the patient, which is extremely important for better prognosis and outcome these days. These plasma cells are very labile, they degenerate very quickly. So whenever we do a bone marrow, we should always cater for the cytogenetic tests. Treatment of myeloma usually uses combination of all these drugs. So steroid is the backbone along with immunomodulator and proteasome inhibitor. All these drugs are available in generic formulations and are widely used across the nation. These are the newer molecules which have become available. These are all monoclonal antibodies and bispecifics. Daratumumab is with us for almost a decade now, and they are changing the outcome of the patient. So if we look into the traditional drug which are used, the triple drug combination of a bortezomib, lenalidomide, and dexamethasone, followed by an autologous bone marrow transplant, which is the standard of care in multiple myeloma, the progression-free survival is beyond 5 years and the overall survival is beyond 10 years in the current era. And if this is combined with monoclonal antibodies, it further improves. So autologous transplant in myeloma is actually a very cost-effective treatment because all the monoclonal antibody which end up costing around 15 to 18 lakh rupees for 4 months. CAR T-cell therapy is the new advance which is happening, and it is soon going to be available for multiple myeloma in our country, and this probably will lead to a possible cure in multiple myeloma, which is until now only a controllable disease. So we have an ongoing clinical trial in which we will be soon recruiting patients. This is a trial of generic daratumumab in newly diagnosed patient of multiple myeloma. So the cost benefit in this trial, the patient is going to have a benefit close to 18-20 lakh rupees. So if there is an eligible patient, you may kindly end up referring the patient to us. How else can myeloma present? Almost 50% of myeloma patients have renal insufficiency, 70% odd patients have anemia and bone issues. Along with that, fatigue, bone pain, symptoms of hyperkalemia, calcemia, neuropathies, repeated infection are all symptoms of myeloma. Coming to the second case, a 62-year female, symptomatic since 1 month. She actually had symptoms of recurrent urinary and upper respiratory infection along with fatigue and weight loss. So she was so symptomatic that every 2 months she needed some form of antibiotic or hospitalization for her infective episodes. On examination, there was cervical and axillary lymphadenopathy and some sensory motor peripheral neuropathy. So what we noticed here was that the WBC count was elevated and the lymphocyte was disproportionately high. When such thing happens, we think about CLL. But a high lymphocyte count goes much beyond CLL. And when we get such a picture, we end up doing a test called flow cytometry, which gives us the immunophenotype of the lymphocytes. So when we performed this test, we got an immunophenotype which was CD5 and CD10 negative going against the diagnosis of CLL. And when such immunophenotype is found, we again end up doing a paraprotein test. In this particular patient, there was presence of a paraprotein, which on immunofixation was IgM kappa type. So, and this free light chain was also deranged. So, IgM kappa raises a suspicion of Waldenström macroglobulinemia. The name seems alien, but then in this particular year, I have diagnosed 5 patients of Waldenström. So, it's not a very uncommon test. When we find such phenotype and presence of IgM kappa, we think beyond myeloma, we end up performing some molecular tests, and in this particular patient, MYD88 type of mutation was present, confirming the diagnosis of WM. Treatment of such condition is chemoimmunotherapy. Nowadays, we also have an oral therapy available, giving excellent outcome. The reason of recurrent infection in such patient is because of the abnormal protein. The normal protein suffers, making the patient very fragile to recurrent infection. So WM can present in multiple ways. Along with recurrent infection, the patient may have lymphadenopathies, symptomatic anemia. There could be cold agglutination. Raynaud's phenomena can happen, peripheral neuropathy, splenomegaly, and lots of constitutional symptoms. Not all patients of WM need treatment. There are a set of patients who can just be closely monitored. Coming to my last case, 66-year female, symptomatic since 2 months with fatigue, shortness of breath, and pedal edema. Ejection fraction was 50%, and there was raised NT-proBNP, raised urine ACR. So patient actually presented with heart failure with preserved ejection fraction. There was no anemia, renal function seemed to be okay, but the urine ACR was significantly high. She was losing a lot of protein. M-band was present in this patient, which was IgG lambda type, free light chain was also deranged. So tissue diagnosis was done because the cause of urine ACR was not apparent. Renal biopsy was done, which showed deposition of this amorphous material. This is polarized microscopy in Congoroid stain, which shows this beautiful apple green birefringence. And this is the immunofixation test, which showed presence of lambda deposit in the kidney biopsy. We also performed a bone marrow, which showed increase in plasma cells, and the bone marrow biopsy also showed presence of this amorphous deposit. So this was a patient of amyloidosis. It is a primary amyloidosis with involvement of cardiac and renal system. Again, this is not a very uncommon test in our center. Because of a very vigilant cardiology team, we end up diagnosing close to 10 to 12 cases each year. Amyloid is also treated in a way which is pretty similar to myeloma. We use combination of all these drugs, steroids, proteasome inhibitors, and traditional chemotherapy. So daratumumab here as well has found a lot of importance. It actually can cause reversibility of the deposited protein. 40% of the deposited protein can get reversed if we use daratumumab upfront in the treatment of amyloid. Remaining. Those who are eligible, these patients are also taken up for autologous transplant. But right now, with the availability of daratumumab, those who are treated with this drug may possibly avoid transplant with equally good outcome. Amyloid can involve a lot of organ system. Cardiac and renal are the most common organ systems that are involved. GI system, hepatomegaly, various levels of transaminitis, peripheral neuropathies, periorbital purpura because of fragility of blood vessels, macroglossia are all other symptoms that can happen in amyloid. So this brings us to the point that when should we actually look for paraprotein? Anybody beyond 40 years of age with symptoms of anemia, fatigue, weight loss, unexplained bone issues, recurrent unexplained infections, unexplained cardiac issues, mainly heart failure with preserved ejection fraction. This is very important because if we end up picking the patient early, the outcome is definitely different than what happens when the patient presents to us late. Undiagnosed renal problems, neuropathies, easy bruising, purpuras, symptoms of hypercalcemia, macroglossia. So basically, any organ system may be affected, and paraprotein tests, which are not very expensive and available these days, should be very easily suspected and tested so that we don't miss a diagnosis. This is where I'll end. Thank you.
Thank you. So the next topic is primary aldosteronism, primary hyperaldosteronism, recent updates in evaluation and management. Dr. Vivek Patel.
So good morning, everyone. Today I'm going to discuss about the primary hyperaldosteronism, the recent updates in management and evaluation. So if we see in past decade, there is a huge evolution in the data and all the recommendation regarding the primary aldosteronism, and this is what I'm going to discuss today. This is the guideline published in 2025 in JCEM, and my main focus would be highlighting these guidelines. So hypertension has a huge iceberg, and we are missing majority of the problem, because if we see, there are almost 5 to 14% of cases who are having primary hyperaldosteronism even at the early stages of hypertension, and we are missing those cases. And if we consider the patients who are having resistant or uncontrolled hypertension, the prevalence increases to almost 30%, and this is very huge burden of primary aldosteronism in a hypertensive patients. Why we need to screen patients for hyperaldosteronism, or why we need to identify these cases of hyperaldosteronism? Because apart from just having uncontrolled hypertension, it also causes multiple morbidities and mortalities related to the hyperaldosteronism. Like it increases the risk of coronary artery disease, atrial fibrillation, stroke, left ventricular hypertrophy, which is independent of hypertension. It increases the risk of renal dysfunction, decline in the EGFR and the albuminuria. It increases the risk of metabolic syndrome. So all these conditions which are associated with hyperaldosteronism, which require early identification, and when we identify and treat with the targeted therapy, we can prevent these kind of complications. So the core problem is that despite being common, dangerous, and treatable, primary aldosteronism remains largely undiagnosed, and we are missing an opportunity to prevent the harm or even cure hypertension. And there is a huge shift of understanding. There is a conceptual change in the primary hyperaldosteronism in the past decade. So previously it was considered as a rare entity, but now we know that it is a very common disorder. Around 5 to 14% in the primary care and around 30% in the referral centers of hypertensive patients are having primary aldosteronism. Previously it was hypertension with hypokalemia when we consider primary hyperaldosteronism, but now we know that even in those patients who are having primary aldosteronism, around only 14 to 50% of patients are having hypokalemia. Rest of the patients are normokalemic, and we are missing those patients. The diagnosis, previously it was binary, now it is considered as a spectrum of continuous disorder in which there is a renin-independent aldosterone secretion which is there. And previously it was thought that it is caused by aldosterone-producing adenoma. Now it is a continuous process in which there is more common is a bilateral adrenal disease. So this is the continuous process of renin-independent aldosterone secretion. In a very early spectrum of disease, there is a normal blood pressure, normal potassium, and there is mild PA. There is some hyperaldosteronism, some aldosterone secretion which is independent of renin. Then the second stage, there is biochemically overt primary aldosteronism. In those patients, there is stage 1 and stage 2 hypertension can come. Hypokalemia may or may not be present. Most patients are normokalemic. And the last stage is the severe primary hyperaldosteronism, in which there is a resistant hypertension along with hypokalemia, and the previous guidelines are suggesting that we are screening only those patients who are having severe primary hyperaldosteronism. We are missing all the previous stages of primary aldosteronism. So what are the changes which are happening in the screening protocol of primary hyperaldosteronism? So now the guidelines suggest that all hypertensive patients should be screened for primary hyperaldosteronism at least once in the lifetime, especially when they are diagnosed first. Those patients who are having resistant hypertension, hypokalemia, those patients who are having adrenal adenoma, sleep apnea, those are the patients who are having high yield result. Those patients are having more chance of having primary aldosteronism. However, all the patients should be screened for primary aldosteronism at least once. How to screen? The screening protocol is very specific. We need to go for a aldosterone-renin ratio along with the potassium. And the key consideration for a positive screen, that any aldosterone secretion in the presence of suppressed renin activity. Renin activity should be less than 1. Any aldosterone secretion which is there is considered primary aldosteronism, and the ratio should be more than 20. The potassium measurement should be only to see that whether there is a falsely low aldosterone or not, because sometimes even in presence of hypokalemia, if the screen is positive, it is a true positive, and we should go further for the test. The major hurdle for screening right now is the withdrawal of medications, because many times patients on multiple medications, those patients who are on multiple antihypertensive, it is very difficult to hold all the medications and screen for the aldosterone-renin ratio. So now the strategy has been divided into ideal withdrawal, minimal withdrawal, and the no withdrawal. So even guidelines suggest that even without any medication withdrawal, you can go for aldosterone-renin ratio. You just need to see that which medications affect the aldosterone-renin ratio how. Even if patient is on mineralocorticoid receptor antagonist, you go for a ARR. And if the aldosterone is elevated and renin is suppressed, even in patients who are taking spironolactone, we can consider is a positive screen. And these strategies are balanced diagnostic accuracy of aldosterone-renin ratio with patient safety as well as the feasibility. In a positive screen, how to proceed further? Whenever the screen is positive, the previous guidelines suggest we should go for a confirmatory testing followed by the localization. But now the guidelines are changing very, very recently, that in a positive screen, if patient is willing for surgery or is a candidate for surgery, then only you can consider further testing. If patient is not desired for surgery or patient is not a candidate for surgery, then you can directly initiate a mineralocorticoid receptor antagonist. If patient is surgery is an option, then the further testing with a localization. Even in a positive screen without confirmation, you can go for a localization, especially if there is a high probability of you are finding the lateralized disease, that is presence of hypokalemia and the aldosterone level more than 20. You can directly go ahead with the CT and the adrenal vein sampling. If there is a low probability of finding a unilateral disease, you can start mineralocorticoid receptor antagonist. So the confirmation is needed only in those patients, confirmatory test is required, those patients who desired for surgery in which lateralization is required, and there is an intermediate probability of lateralizing disease. Localization should be done either with the imaging, that is CT, or the adrenal venous sampling. The adrenal venous samplings are the gold standard for the disease. So what is the problem with the CT? Because as the age increases, there is a chances that you may find adrenal incidentaloma, which is not actually a problem. And in those kind of cases, adrenal venous sampling by lateralizing that which adrenal is secreting aldosterone more rigorously, we can identify those cases. However, there are few exceptions in which adrenal venous sampling is not required. If a patient is less than 45 years of age, there is a clear-cut presence of florid primary aldosteronism with hypokalemia. There is a unilateral CT imaging of adrenal adenoma more than 1 centimeter, and the contralateral adrenal is absolutely normal. In those patients, the adrenal venous sampling is not required. Patient can directly go ahead with the surgery. The treatment outcome, especially when the disease is lateralized, the unilateral disease, the surgery is the best possible option because it provides a better result as compared to the mineralocorticoid receptor antagonist in terms of blood pressure improvement, medication required, and the cardiovascular events. So in a unilateral disease, surgery should be always the first choice of the therapy. If patient is having a bilateral disease or the disease is not lateralized, then the medical therapy is advised. The choice of the therapy is mineralocorticoid receptor antagonist. The spironolactone should be preferred. The previous guidelines also suggest that INEC inhibitors can be used, but the current guidelines suggest that the spironolactone or the mineralocorticoid receptor antagonists are the best for the therapy. The available agents are spironolactone, eplerenone with fewer anti-androgenic side effects, and the finerenone, which is the newer non-steroidal MRA. The problem of mineralocorticoid receptor antagonist is the dose-dependent adverse effects like hyperkalemia and the anti-androgenic side effects with the spironolactone. Also, there is a pathophysiological escape mechanism because we are blocking the receptors. There is increase in the aldosterone level, which bypass the mechanism, and there is some non-genomic effects which are not mediated by the aldosterone receptor are still happening, increasing the inflammation and the fibrosis. And therefore, the novel mechanism, the newer drug which is coming to the picture, that is the aldosterone synthase inhibitor, which directly blocks the aldosterone synthesis, that Baxdrostat. The recent study which is published, Bex hypertension study, which has shown in a resistant hypertension cases significantly improved blood pressure, around 40% of patients achieving the target blood pressure with the use of Baxdrostat with minimal risk of hyperkalemia and reversible decline in the eGFR. The goal of the therapy is also changing. That starting with the mineralocorticoid receptor antagonist, the goal of therapy should not be targeting just blood pressure or the potassium. The target should be the raising the renin level. So each and every patient in which PA is diagnosed, we are monitoring.
2 minutes remaining.
The renin level should be targeted. It should be normalized with the therapy, and the dose of the mineralocorticoid receptor antagonist should be targeted to raise the renin level. So the take-home message, it is the common, dangerous and treatable condition. It is a continuous spectrum of renin-independent aldosterone secretion rather than a binary disease. You need to screen all the hypertensive patients at the time of diagnosis to permit the early targeted therapy. The screening with the aldosterone-renin ratio with minimal or no drug withdrawal. The subtyping with CT or the AVS for the guiding the therapy. Choice of therapy for unilateral disease, surgery for bilateral disease, mineralocorticoid receptor antagonist should be preferred. The newer agents like aldosterone synthase inhibitors are in the pipeline. The goal of the therapy is normalization of renin level rather than just normalization of BP and the potassium. Thank you.
Thank you, Dr. Patel. The last speaker for this session is Dr. Shivang Patel. He's going to be talking on beating the heat, practical strategies for hyperthermia management.
Good morning, friends. So, today my speak is on decreasing the temperature. So, after all the medical advances, to decrease the temperature, what we have is paracetamol and NSAIDs. And for the most part, we do use only paracetamol in in-house patients, right? And the other part we will do with the physical maneuver. So we will delve into the physiology and physics of reducing the temperature. And most of these things are done by our staff. But we will look into the physiology and we see that what can we improve and what are the pitfalls for the temperature management. Okay. So I do not have any financial interest. So first question is, if your patient has a heat stroke and high fever, what is the best way to decrease the temperature? Timer, please. Okay. So I will not give the answer. So we will look it in the presentation and we will come to the conclusion. So first, physics of the heat loss. So first way we will lose heat from the body is radiation. That happens naturally. We don't have to do anything. The second way is conduction. Whenever any cool surface is in close contact with the skin, we transfer the heat to the other surface. The third way is convection. That is when there is a airflow across the skin, it will take away the warm, thin air layer from the skin and it will take away the heat. And the fourth way is evaporation. When there is a fluid on the skin and it converts to the vapor, it will take away the heat from the skin. And evaporation is the most effective way of removal of the heat from our body. And that is why we perspire and we lose heat from the body, right? The next physiology is peripheral pipeline. So whenever we have fever, we have tachycardia and our cardiac output increases. So what happens is our blood moves from the core to the periphery and then we lose heat from the periphery, correct? Now, we will look into the individual method of losing heat. So first thing is ice packs. So what ice packs do is, it's a conduction method. It will transfer the heat from the body to the ice pack. Now, the fallacy of this ice pack is it also vasoconstricts the peripheral vessels and it transforms the blood from the periphery to the inner core. So it may fail at many levels. And we do not achieve our goal by just using ice packs. The next thing is wet sheet, which is very commonly used method in all the hospitals to reduce the body temperature. Now, wet sheets are effective. That acts by first conduction, but there are some pitfalls. What is the pitfall? If the wet sheet is not touching the body directly, it will not be very effective. The second thing is wet sheet should not be very dripping wet. If it does not touch the body directly, it will trap the hot air below the wet sheet and it will create a sauna effect and we will not lose the heat from the body. So what is the best way to use the wet sheet? The best way is we must use a very thin bed sheet which should be damped and not dripping wet. And we should use it with the fans so that we will create a wick effect. So that will absorb the water from body, water or perspiration from body to the wet sheet, and the fan will evaporate that thing and it will accelerate the heat loss from our body. The next thing is the internal cooling. So we use very cold saline, IV, but the limitation of the internal cooling is that we have to give a lot of fluids and most of our patients cannot tolerate that amount of fluid and it may cause pulmonary edema. So what is the gold standard? So the gold standard is misting and fan. So that will combine two methods. One is evaporation and the second is convection. These both are the most powerful method to lose heat from the body. We must use tepid water and not cold water because cold water will cause shivering and shivering will increase heat generation which is a counterproductive. So we must use a lukewarm water. We have to spray that water on the body and we must start the fan. So this will create a vapor. This will convert the water in the vapor and we lose heat the highest in the best way. The main thing here is we have to expose as much surface as possible because the more the surface is involved, the better way is, the better the heat is lost. So at the end of my talk, we come to the conclusion that if a person has a heat stroke or if a person has a higher temperature because of any reason, be it a heat stroke or a fever or a central fever, the best way to lose heat is tepid misting with high velocity of the fan. So at the end of my talk, I will give you three things. First, evaporation is the best way. Convection, fan is must. If you do not use fan with wet sheet, it is not going to work in its best way. And vasodilation is must. If you are using ice packs and it creates a vasoconstrictions of vessels, if you are not going to lose heat from the body. Okay, thank you.
Thank you. You can open for question and answers.
Yeah, so I understood the question. It's SVT with aberrancy versus VT. So whenever
5 minutes remaining.
So whenever we approach a wide complex tachycardia, we have always doubt whether it is really VT. Because SVT with aberrancy also looks like a VT only because it's a wide complex tachycardia. So if we already know that patient had a structural heart disease in form of cardiomyopathy or something, then we can consider it as a VT only and treat as VT. But when we don't know the situation and patient has presented to us for the first time with a wide complex tachycardia, we should always look at the morphology of QRS complex. Whether it is looking a typical left bundle morphology or whether typical right bundle morphology. So typical right bundle morphology is R, small r, S, R dash. So that small r, S, R dash is a typical right bundle morphology, and right bundle with right axis tachycardia is usually SVT with aberrancy. And a typical left bundle morphology with a left axis tachycardia is usually SVT with aberrancy. But when there is discordant axis, that means a right bundle morphology tachycardia with left axis, or left bundle morphology tachycardia with right axis, that should be always treated as a ventricular tachycardia and treat as a VT.
In case of whenever there is cortisone is indicated in ventricular tachycardia, if there is hypotension, say systolic blood pressure is 80 or 90, then how should we proceed with vasopressor or what should we do?
I mean, during tachycardia patient is in hypotension.
Hypotension, yes.
If during tachycardia patient is hypotension, if it is symptomatic hypotension, we should directly go for a cardioversion, electrical cardioversion, get the rhythm back. Once the rhythm is back, BP will improve. But like, it is not like a 100 systolic BP patient is in hypotension. There should be signs of hypotension in form of shock, in form of dyspnea or chest pain or respiratory, in form of unconsciousness or altered sensorium. That's the symptom of hemodynamic instability, not just a BP reading.
Okay.
Hello. Sir, you presented the case, beautiful manner. Fineron, and it was only EMPA. So it should be the same as DAPA and Fineron? Results should be same because study was only on that.
Thanks for the question. So it is more of a class effect rather than drug effect. So say it would be same. Finerenone with EMPA or finerenone with DAPA. It is basically class SGLT2 receptor inhibitor rather than any specific one. Yeah, absolutely.
My question is to Hiren sir. So there was a slide of a 25-year-old healthy male with tachycardia. Was that patient having Wolff-Parkinson-White syndrome? Or so if that is the case, should the management change from drug to ablation?
So you are right. So whenever a patient has WPW syndrome in form of pre-excitation, there are multiple reasons for getting arrhythmia in that patient. The most common is orthodromic AVRT, where the circuit goes down via the AV node and goes back via the bypass tract. So that is classical orthodromic AVRT. And for any orthodromic AVRT, whether we know the status whether the patient has pre-excitation or not, for acute termination, adenosine is the drug of choice. But you should always have a defibrillator with you, because a patient after adenosine can develop atrial fibrillation. And if the atrial fibrillation develops in the setting of WPW, it can become AF with WPW, and which needs immediate cardioversion. So you should always have a defibrillator with you when you give adenosine. Another mechanism of tachycardia is antidromic AVRT, where it goes down via the bypass tract and goes up via the AV node. And it looks wide complex tachycardia, not a narrow complex tachycardia. There the drug of choice is not adenosine. The drug of choice is usually the class 1C antiarrhythmic drugs, that is flecainide, propofenone, or it can be injection amiodarone also.
One question regarding multiple myeloma. After completion of that 4 drugs course, if patient is all right, how much interval we should go for bone marrow and PET scan?
So usually, sir, if the patient have completed 4 months of therapy, we monitor by using the peripheral blood paraprotein assays.
4 drugs of therapy for 4 years.
For 4 months.
Yeah.
For 4 months.
4 years.
Okay. So usually,
Including DARA.
So if the patient have achieved a reasonable response, and if the response is being maintained, we shift the patient to a low therapy maintenance kind of a treatment, which is nowadays usually continued until disease progression. So only one drug should be continued until the disease progresses. Progression is again picked up by paraprotein tests and by the end organ damage in terms of anemia and all those things that happens.
But electrophoresis, all that should be done at which interval, ideally?
Yes, so 3 monthly, 4 monthly, we should be monitoring the patient.
And
during-
PET scan, PET scan?
PET scan is not indicated in monitoring. Unless we have an evidence of a progression, we will not gain anything by doing a PET scan.
Thank you.
Dr. Ankit, this is Dr. Pradnya Digekar from Pune. My excellent lecture, all speakers, can't you? Okay, okay. So the speakers are excellent, their experience, their management, it is really excellent. Just as a teacher, when patients are coming with the backache, with the shoulder pain, so this is all the resident students and general practitioners are there. So don't miss multiple myeloma, because you advise ESR, and ESR is also missed by the practitioners. So whatever you are telling, it is all beyond, it comes afterwards. So the basic, when you are sitting in the OPD or your consultation, these things are because the orthopedic has operated fracture neck femur. The shoulder pain is missed by, so the radiological features are there, patient's investigations are there. So before going to Ankit, so you can diagnose at
5 minutes
OPD
remaining.
level. Thank you so much. Thank you.
A good look at the peripheral smear for roulet.
Yeah.
And other thing is because of the paraprotein, there are lab interference. Common tests like bilirubin, electrolyte will give erroneous result. So this erroneous test result should not be just ignored and should be explored, because the patient could have a paraproteinemia.
Thank you, sir. Yes, yes, sir. Yes, sir. They have operated fracture neck femur, and shoulder pain patient was referred back with the pain. So just I want to aware the audience, so you should not miss it.
So we can have last question before we close down this session. Last question, if anybody has, or I shall welcome Dr. Milan Chugh and Dr. Umil Shah to take over for the next session. Thank you.
Thank you, all the speakers. Let's go to the next session. I invite as chairperson Dr. Ashok Jain, Dr. Bal Mukund Shah, Dr. Jitendra Deliwala, Dr. Prakash B. Patel, Dr. Praveen Gupta, Dr. Subhash Patel. As moderators, I would invite Dr. Deep Mala, Dr. Mahesh Shukla, Dr. Seema Balodia, Dr. Shailesh Dubbal, Dr. Shailesh Kothari, and as panelists, Dr. Milan Chugh and Dr. Umil Shah. Over to you, Dr. Milan Chugh and Dr. Umil.
Good morning, everyone. Let's start with the first talk. I think I will invite Dr. Jitendra Patel for his talk. On multimodality care in the elderly adults.
Good morning, everyone. First of all, I would like to heartily congratulate our core committee for organizing wonderful JIC 2026, Dr. Anish, Dr. Milan Bhai, Dr. Keyur Bhai, and Dr. Tejas Patel. It's really a covering of almost every topic of the medicines and the best topic cover in the next couple of days. So without taking much time, I am going to speak on the very difficult subject on touching the comorbidities in the elderly group of patients. I will try to finish as early as possible because it's a very vast subject. I don't have to disclose for any financial interest. So healthcare of elderly, this India recorded a significant improvement in life expectancy. And it was around 49 years in the year 1970-75 to 69 years in 2013 to 17. So the burden of morbidity in old age is enormous. And according to the United Nations latest data, the Indian aged 60 and up is expected to reach 319 millions by 2050. So it is up significantly from 100 millions in 2011. So we know that aging is an incremental and universal phenomena which comprising the gradual loss of cells and leading to the deteriorations of the organ functions in the human body.
There is no typical older persons, and it is basically irreversible, unstoppable, and time-dependent process. So depression, loneliness, and dementia is not a part of normal aging. So what are the changes we are expecting in any elderly healthy person? So we can say that temperature regulation is a big issue because of the loss of the subcutaneous fat, decreased sweatings, and the thinning of the skin, and also coexisting comorbidity like hypothyroidism, malnutrition, and the extrinsic factor like having the poverty and poor. These may more prone to get the hypothermia or the heat stroke. Similarly, in the cardiovascular changes because of the degenerative changes, dilatation of the aorta, calcifications of the valves, and degenerative changes in the conduction system. So this may invite the lots of widening of the pulse pressure, postural hypotension, tachybrady and also reduced exercise tolerance. In respiratory systems, because of the reduced lung elasticity, stiffness of the chest wall, and the VQ mismatch, these patients are more prone to get because of the reduced respiratory reserves and the reduced volume, they are more prone to get the risk of infections also. And in oral cavity is a big issue because of the atrophic changes, dryness of the mouth, loss of the teeth, and the poor mastications. This will also, and also alterations of the taste, and these may cause further difficulties in the eatings and everything. GI system is very heavily affected. Most of the older patients, they come to us with lots of complaint related to GI system because of the decrease in the secretions, weakening of the mastications, reduced esophageal tones, and the decreased gastric size, and more prone to get GERD or because of the digestion issues and the cancers and the constipation, dyspepsia. These are the common problems. GI urinary systems, we used to get because of the less production of the hormone in female, osteoporosis, menopausal issues, loss of sex, libido in female patients because of the enlargement of the prostate, obstructive uropathy systems, and the reduced renal perfusions may lead to the decreased EGFRs, and these patients are more prone to get the frequent UTI, and urinary incontinence is a big issue in elderly group of patients. Sense organs, of course, vision, hearing, and the taste is also affected because of the age, and that may leads to the frequent fall is a big challenging task in the elderly group of patients. Nervous system, because of the generalized degenerations of the brain as well as the spinal cord, these may patients having the more chances of taking the increased risk of deliriums, and also loss of sense because of that, the increased risk of the fall. And also sleep is a big issue, insomnia is a big issue. In the blood, because of the dryness of bone marrow, anemia, cytopenia, and immune system is also affected and more prone to get the infections and the cancers. So approach to the evaluations of elderly is multidimensional, usually interdisciplinary. It's a comprehensive geriatric assessment. So whenever you manage any elderly patients with any comorbidity, you have to keep this geriatric giant, 4I you have to keep in mind. Whether what is the patient's mobility, whether patient is stable or not, whether patient having incontinence or not. So very important point is impairments of the intellectual. So that you have to keep in mind. Besides that, other factors like socioeconomical status, existing comorbidity, functional status, medications, that is the biggest. Polypharmacy is a big problem, and the nutritional assessment has to be done. So managing common elderly population, it's like iceberg phenomena. What you see is the tip of the iceberg, often hides the underlying clinical condition, multiple pathology, multiple missing symptoms, and the masking of the systems. So disease presentation, most of the times in elderly population is always atypical. So small intervention may produce a dramatic results. And this 4M framework was developed by the John Hartford Foundations and American Hospital Associations. So if you remember this 4M framework, what matters, what medication patient is taking, what is the mental status and mobility. So that will always keep in mind for any type of disease patient having. So these are the common chronic condition we come across in elderly group of patient was a stroke, coronary artery disease, diabetes, visual loss, hearing visual, visual impairments, and the falls. And this may lead to further comorbidity like we all are aware about it. So collaborative care is very much essential, and in the course of one illness, elderly person will receive the care from multiple physicians, nurses, and therapy team in multiple healthcare settings. The problem of physicians and nursing discontinuity and medical errors and adverse event and delirium is very susceptible in elderly group patient from the multiple transfers. So that is a big challenge is when the patient transfer from one side to this. And this slide showing that over 30% of the elderly women and nearly 28% of the men suffer from one chronic morbid condition, and nearly 1/4 across suffering from more than two morbid conditions. So dementia, touching to the first common problem in elderly group is a dementia. It's basically it requires a detailed evaluation. And most of the times you have to look for the cause of the reversible dementia like delirium, depression, electrolyte imbalance, hypothyroidism, and so many other causes. And what are the stages of dementia? The early stage, most of the times we miss because it's the first 2 years of the dementia. In mostly we overlook the common feature in that group: language difficulty or getting lost in familiar places, mood changes, depression or loss of interest in the hobbies. And second stage in 2 to 5 years, there is some pronoun limitation, become restricted and begins to lose the activity of daily livings and become dependent for the, and later stage, 5th years onwards, the patient is totally dependent or maybe bedridden or wheelchair bound, and in that case, lots of bedridden complication will arise. So management of dementia is require educating caregivers and providing long-term supports and rule out prescribing factors for delirium and fecal impairment, encourage the person and recall the past events, and also frequent outdoor walk and bright light exposure. Depression is also rising with the increasing age, and you can see all the 70 plus 8 to 10% are very commonly we have observed 8 to 15% is a normally percentage suffering from the depressions, and it's a counseling is usually effective in mild to moderate depression. But when you refer to the higher center, when there is a patient develops suicidal or homicidal tendency or not responding to standard antidepressant care of 8 to 12 weeks and uncertain diagnosis, in that case you have to depress. Incontinence is also another challenging. The reversible condition associated with urinary incontinence. Diaper is a mnemonic that you have to remember. D is delirium, I infection, A is atrophic vaginitis, P pharmaceuticals, psychological disorder, endocrine disorder, restricted mobility and stool impact. So these are the reversible factors. If you can find it out, it can help to the patients. And medication causing incontinence like diuretics, anticholinergics, sedatives, alcohol, narcotic, alpha-adrenergic agonists, and calcium channel blockers. Incontinence management require behavioral therapies, patient pelvic floor exercise, and the frequent bathroom trainings, and all these things required, we can help into that. Then the third most important challenge is a frequent fall. So you have to look for the cause, whether patient is suffering from any acute illness or not, whether patient having some blackout like syncopal or seizure. Mechanical recurrent fall may be because of multiple comorbidity. Risk factors for fall like gait balance abnormality, visual impairments. Environmentals like slippery floor, poor lighting, and clusters. So you have to assess in clinical. It's very easy to assess by tuck test, where the patient you have to ask to sit up, made to sit in the chair without arms and then get up from the chair and walk a distance for 3 meters, like 6 meters in total, or you have to simple ask for the 10-meter distance walk, and you have calculate if the TUs is more than 15 seconds and gait speed is for 10 meters is more than 30 seconds, you can suspect that this patient may have high risk for falls. So for that, again, medication optimization, so drugs which are causing orthostatic hypotension or sedation, you have to avoid. Less stringent criteria for blood pressure and diabetes control, and educate the patient and supplement with good vitamins and calciums, and home environment like reduce the slippery floors and everything you have to keep in mind for that. Stroke is also very predisposing factors. I'm not touching what are the causes for that. Aging and respiratory illness, again, that because of the age, they are more prone to get the respiration pneumonitis, ARDS, because of the loss of elasticities and the stiffness and the respiration. We are knowing that respiration pneumonitis is very, very common in elderly group patient. In that case, you have to properly take care for the prevention part. These are the common elderly pneumonias, in particularly when it is because of the aging and frailty comorbidity or dysphagia. In that case, you have to vaccinate the patient, oral care, proper training for the foods, and swallowing rehabilitations. These are the GI disorder. I'm not going to take detail. Hiatus hernia is very common, gastropathy, non-ulcer dyspepsia, GI disorder, constipation, malignancy, upper GI like dyspepsia, GERDs, H. pylori infections, peptic disease, gastric cancers, small bowel like celiac, mesenteric ischemia. SIBO is very common in elderly group of patients. Diverticular disease, IBD, colitis, infection, colorectal cancer, constipation is a big challenging for elderly and fecal incontinence. Then the cardiovascular risk factor is also very, you have to look for the classical CV risk factor, other risk factor, and manage accordingly. And important clinical trial for primary prevention. This is very important for elderly people. And these are lots of trials showing that hypertension, proven benefit in older patient, more than 75 years of the age, when it is only prevent the MI and the cardiovascular risk, but there is no benefit in the lifespan. Similarly, for the dyslipidemia, statin appropriate for most of the healthy elderly patients. patients for prevention of MI stroke and less evidence for mortality benefit. And these algorithms very clearly showing that primary prevention should be considered only when the when the patient having the LDL more than 160 and the calcium score is more than 100. Otherwise, when there is a life expectancy less than 1 year, you have to be avoid the statins. And secondary prevention, we are aware about it. I'm not touching that part. In diabetes, metformin, SGLT2, and GLP-1 are the recommended for the elderly group of patients. In aspirin, minimal or no clinical benefit has been reported. Risk of bleeding versus MACE, smoking, diet, and exercise are always encouraged for the patient. So this slide is summarizing the primary prevention in older groups: quit smoking, manage dyslipidemia, and with the shared decision making, aspiration may have poor benefit. Increase the physical activity, eat healthy diet, and treat hypertension, individualized target BP controls, and multidisciplinary team approach. Acute coronary syndrome is a big challenging in older group of patients, classically evaluates, and these are the risk factors we have to keep in mind. And this slide showing that whenever you consider oral anticoagulant, that is always big challenge. Because of lack of time, I will skip this slide, but you have to look for the whether patient having high bleeding risk or ischemic bleeding. According to that, you have to follow the standard guidelines advice. Similarly, for the revascularization, optimum medical therapy is the best answer, but if with that patient, okay, thank you. So it's a basically team approach, and in that case, you have to remember the 4M, always mobility, patient high mental status, and nutritional status, and comorbidity you have to keep in mind for it. It's a really very big subject to cover in 12 minutes. For me, it's very difficult. So multiple systems related challenging are coming for any patient of above age of 75. So always look for the life expectancy and what the patient's relatives and family wants in that. Then you have to follow your guidelines. Thank you.
Thank you, Dr. Jitendra Bhai. We all know that more and more geriatric patients will be coming across, and he has nicely covered the whole scenario, how to manage an elderly patient. Now I request Dr. Keval Changadia, Senior Neurophysician from Marengo Sims Hospital. This topic is hypokalemic periodic paralysis and other channelopathy. Dr. Keval, please.
Good morning, everyone. So we'll see the common thing which we see in our clinical practice. So ion channel is a channel which have which are the transmembrane glycoproteins, which can be voltage gated, which respond according to the change in the membrane potential, or it could be ligand gated, like acetylcholine. So sodium channel, calcium channel, chloride channel, potassium channel. Sodium channel is for excitability, calcium channel is for excitation, contraction, coupling, and chloride and potassium is for the repolarization. So these are the common channelopathy which we are going to discuss. So general characteristic for all the channelopathy, which are they all are autosomal dominant. They have episodic weakness or myotonia, which are commonly present as a myalgia. They return to asymptomatic state, and they exacerbate by the environmental factors like fasting, fatigue, carbohydrate-rich diet, etc. And they respond to carbonic anhydrase inhibitors. So channelopathy can present as periodic paralysis like hypokalemic periodic paralysis, Anderson-Tawil syndrome. They might have both like hyperkalemic periodic paralysis, and they might have only myotonia like myotonia congenita and post-mortem. We are not going to discuss those things regarding myotonia. So hypokalemic, which is the most common periodic paralysis, which has episodic limb weakness, which generally begin during the adolescent period. History is very important of exertion followed by carbohydrate-rich diet and rest. That will increase the insulin level, that will cause hypokalemia. So they might have reduced tendon reflexes, but they will never have facial and respiratory facial muscle and respiratory muscles involvement. They have frequency of this periodic paralysis in weeks to months. The attacks last typically for hours to days and recovers to full normal strength. And they might have in later life mild myopathy. So most of the hypokalemic periodic paralysis is related to calcium channelopathy. Okay, and 10 to 20% of the patient of hypokalemic periodic paralysis, which is not named as type 2 hypokalemic periodic paralysis, which is a sodium channelopathy. They have history of myalgia. This patient, sodium channelopathy patient, will have the history of myalgia. You have to ask for the calf pain and those things in these patients. And the duration is very shorter, of often less than hours. And they sometimes worsen with acetazolamides. For the diagnosis, more than test, medical history is very essential. You have to ask for the previous history of this type of weakness and family history, and also the previous day history of food and exertion. And it generally begins during the sleep. So once a patient is waking up, they will have weakness. And if the potassium level is less than 2, then you will have to see for the secondary form of the periodic paralysis. ECG, as you know, that changes of the hypokalemia we'll have to see, and along with that QT interval is very important to see. Provocative test with glucose and insulin is not recommended because it might cause arrhythmias. NCS might show reduced CMAP during the attack, but in between the attack it will be normal. Prolonged exercise test is also NCS test which we can perform. Important thing is to rule out the thyrotoxic periodic paralysis, because the key finding is that they will have no history in families, and the potassium will be less than 2.5, lower than the hypokalemic periodic paralysis, and it is a sodium channelopathy, and treatment is to treat the thyroid disease. And secondary causes like renal, adrenal hyperaldosteronism and GI loss, thiazide, diuretic use are also important, and they will have lower potassium between the attack also. So if the patient is having hypokalemic periodic paralysis, before giving potassium, you will have to see the urine potassium and ABGA, two things. If the urine excretion is low, then definitely you will have to ask for the family history and previous attack history. If it is there, it is hypokalemic periodic paralysis. If it is not there, it is thyrotoxic related. If the potassium excretion is high and ABGA is abnormal, definitely it could be related to kidney like distal RT and Sjogren's syndrome, or it could be related to the secondary causes like aldosteronism or thiazide diuretics. So in treatment is very simple, that you have to ask to avoid high carbohydrate meals and strenuous exercises. Oral potassium or KCl injection is helpful. Prophylaxis, you can use acetazolamide. If person is not tolerating that, spironolactone is also helpful, or dichlorphenamide is also another carbonic anhydrase inhibitor. Hyperkalemic periodic paralysis generally precipitated by the hyperkalemia, and the attacks are very milder and short, so you will not see the patient in the attack most of the time. They will have a history of myotonia that begins in the childhood time and triggers by the foods high in potassium and stress on fatigue. Autosomal dominant sodium channelopathy, and here also the family history and physical examination is the best important thing. Sometimes genetic test might be helpful, but most of the time it comes inconclusive. So myotonia might present in many of the patients, and ECG will show the changes of hyperkalemia. NCS might show the myotonia sometimes between the attacks also. And most of the patients don't require any treatment. You just ask patient to take carbohydrate meals and do some exercise that will reduce insulin, raise the insulin level, that will reduce the potassium level. That is enough for the attack part. And for the prevention, you can ask the patient to avoid high potassium diet. And if the patient have myalgia and those symptoms, then you can give mexiletine, which is sodium channel stabilizer. So these are the channelopathy which we already discussed. The important differential from the hypokalemic periodic paralysis and GBS is that GBS patient will have history of ascending pattern of weakness. They might have facial muscle involvement, bulbar muscle involvement, and respiratory involvement, which is not there in the periodic paralysis. They might have history of viral-like illness or GI symptoms in many of the cases, and GBS will not have history of previous attack or not have history of familial history, and it doesn't recover in hours. It takes weeks to months for recovery. Another important congenital disorder is Anderson-Tawil syndrome, which characterized by triad of periodic paralysis, cardiac arrhythmias with long QT, and dysmorphic features. It is same triggered by the just like hypokalemia and like rest, followed by the carbohydrate diet. and it is a potassium channelopathy. So these are the features, dysmorphic features, low setting airs, hypertelorism, and synodactyly, and they might have bidirectional ventricular tachycardia. So ATS should be suspect if the patient is having proven long QT, and if the patient is also presenting with periodic paralysis, we'll have to see for the long QT. Because it could be ATS, and otherwise for the diagnosis part, provocation tests are not recommended. Treatment is the same like carbonic anhydrase inhibitor, and maintaining the high potassium more than 4.5 helps in narrowing the QT also, along with the preventing the periodic paralysis recurrence. So the normal simple question I would ask that if the patient is having presented with periodic paralysis, all of the following tests are important except. So can we have the timer? If the patient is having periodic paralysis, then what would be the test you recommend? Okay, so most of the people are right. Right? Okay. So if the person is having presented with weakness, quadriparesis, then flaccid quadriparesis, you have to see ECG, take urine sample for the potassium, and ABG and thyroid. These are the 4 tests which is very important. Imaging, don't delay time in imaging. Okay, that's absolutely correct. So if the person is having acute flaccid paralysis and potassium, you will have to see the potassium. If it is low, you will have to see ABGA, urine potassium, TSH, and replace. If it is low, then you have to replace the potassium, and you have to rule out the other causes of hypokalemia like GI losses, RT, and tubulopathy with these tests. Okay, and if it is normal, and you have, then also you will have to ask history of in families and recurrent past history of the similar attack. Then you have to go for the EMG and other tests. If it is high, then you have to, hyperkalemic periodic paralysis, then you have to just ask the patient to take some sugars, do some exercise, and for the prophylaxis, you can give thiazide diuretics. Otherwise, these myotonia congenita and other channelopathy, we are not going to discuss. It is not for the physician purpose, but myotonia patient will have history of myalgia, and they will have typically history of warm-up phenomenon, like it is prominent in the legs. So the patient will say that going upstairs 2-3 stairs. Remaining. 2-3 stairs are the problem. After that, I walk normally. So these are the typical history of myotonia in these patients. And there are 2 types of myotonia congenita, which is Thompson's and Becker's. And these are the colloid channelopathy that will increase the excitability of the muscle membrane. And the diagnosis is generally in history-wise and EMG-wise also. And sodium channel blocking agent like mexiletine is the only treatment you can give. Most of the patient doesn't need any treatment. Paramyotonia congenita is a cold-induced myotonia. Patient will have history of myotonia in the winter times, and it will have paramyotonia. That asking the patient, closing the eyes repeatedly. Initially, they will able to do that, and gradually it will worsen the weakness. Thank you so much.
Question is lastly we will ask question. Now next speaker is Dr. Ayushi. Topic is sugar rush to sugar crush, emergency edition.
Working in a high-stakes environment like the emergency department, we often find ourselves at the either extremes of the sugar spectrum. Knowing how to navigate these extremes while balancing life is our ultimate goal. On that note, a very good morning to all of you. I'm Dr. Ayushi Choksi Parekh, and today I'm here to talk about the topic, Sugar Rush to Sugar Crash, the Emergency Edition. We see this on a daily basis from navigating the severe lows of hypoglycemia to the critical highs of diabetic ketoacidosis. Let us try and improvise our current clinical practice. Going with the tradition of JIC, let's begin with a question. So say you are treating a 75-year-old patient with impaired consciousness with a blood glucose of 38. You have a peripheral IV line. What is the best initial management to achieve a rapid return to consciousness while minimizing patient risk? Timer, please. Options are 50 ml of D50, 100 ml of D10, 1 mg of glucagon, and 10 units of insulin. All right, we'll get back to this at the end of the lecture. Next question. You're managing a severe DKA patient. The first liter of fluid is in. The lab results return. The glucose is 550. Potassium is low at 3.1. pH is 7. What is your immediate next move? Start an insulin drip. Give 10 units insulin bolus. 2 ampules of soda bicarb. Or hold the insulin and start with the potassium replacement. All right, we'll again get back. So let's begin with the first extreme, that is the sugar crash, which we know as hypoglycemia. We all know that it is a sugar level below 70, but internationally it is divided into 3 categories. Level 1, which is the alert level, less than 70 or 3.9 millimoles, wherein the patient is conscious and alert. Level 2, where the glucose is less than 54 or 3 millimoles and it is critically low and neuroglycopenic symptoms may begin to appear. Level 3 is the functional level, wherein the numerical threshold does not hold, but there should be an altered sensorium or hemodynamic instability. The difference is in the management. Level 1, we can give an oral glucose and monitor. Level 2 needs urgent IV dextrose, and level 3 requires emergency stabilization. What to suspect in the ED? The most common culprits are generally medication errors like a double dosing of insulin or a long-acting sulfonylurea, an intake output mismatch like a skipped meal or increased physical activity, or an alcohol intake, and sometimes dangerous mimics like an underlying sepsis, adrenal insufficiency, renal or liver failure, or a drug overdose. So the molecules that are available are the oral glucose. In the form of IV, we have our dextrose, we have glucagon, and adjunctive and refractive agents like the octreotide and diazoxide. So for the level 1 and level 2 patients who are conscious and alert, we can give a trial of the rule of 15, which is giving 15 grams of fast-acting carbohydrate, waiting for 15 minutes, rechecking the levels and repeating the entire cycle if the sugar is still below 70. The minute you stop is when the patient enters the level 3, where it is contraindicated and you need immediate indication. It's an immediate indication for IV dextrose. Glucagon, people say that it can help increase the glucose stores by releasing the stored glucose from the liver. So it can be used as an emergency rescue medication, but generally not in the ED. It is a pre-ED EMS medication or when IV line is difficult. But for the ED, we always go for IV. So the mainstay of hypoglycemia management, we all know it is dextrose. But when we say dextrose, what comes to our mind is D25 and D50. But now we are seeing a shift. The shift is from D25 and D50 towards the D10. Why? Because D25 and D50 are hyperosmolar. They have an extravasation risk and cause tissue necrosis. D10 is vein friendly and it's a safer choice. Main clinical advantage, it helps prevent the glucose roller coaster. What happens with D50 is that there is a sudden sugar spike which causes an excessive insulin release, which causes a sudden crash causing a rebound hypoglycemia, which is taken care of with D10 because it has a gradual and sustained rise. And lastly, there is an ease of titration because D50 will have a post-treatment hyperglycemia, whereas D10 will remain stable. And the time to recovery is same in both, so it's obviously better to choose the safer option. So the learning lesson here is, let's stop pushing the D50 like a lightning bolt and go towards D10, which is the safer and more physiological gentle nudge, which can fix the brain without scarring the veins or causing a rebound crash. This was for the insulin thing, but now if your patient is on sulfonylurea, in those cases the insulin is constantly being released, so giving extra dextrose will only cause the sugar insulin crash. So here we use octreotide, which is the metabolic brake which acts against that and causes stoppage of the insulin release and thus helps set the metabolism. The dose would be 50 to 100 mcg subcutaneously. Only thing here, we need to make sure that the patient is admitted for monitoring to observe for the crash that might happen up to 24 hours. What we do is we just give dextrose and let the patient go, but if it's a sulfonylurea, we need to make sure we are giving octreotide and admitting the patient. So giving dextrose to a sulfonylurea overdose is like throwing wood on fire. It just keeps the insulin burning. Octreotide here is the fire extinguisher. So these are all the agents for hypoglycemia, and just a little clinical pearl, remember hypoglycemia is a stroke mimic, so always check the glucose levels before proceeding. Now we move on to the other extreme, that is the sugar rush or the diabetic ketoacidosis. How does it happen? So basically there's an insulin deficiency which leads to a fat breakdown which leads to ketoacidosis. Why it happens? Multiple causes, but let's remember the main important 5 I's: infection, insulin omission, infarction, inflammation, and iatrogenic like steroids and SGLT2 inhibitors. High index of suspicion, whenever there is an unexplained tachycardia or tachypnea, there is abdominal pain, vomiting, altered sensorium, refractory hypotension, or normal sugar levels but a sick patient on SGLT2 inhibitors. So remember that DKA always does not look like a diabetes problem. It sometimes looks like an abdominal problem or a breathing problem. So if your patient is breathing fast and vomiting, always remember to check the anion gap. Red flags for the ED: volume depletion in the form of tachycardia, fruity breath which is characteristic, Kussmaul respiration which is the deep, rapid, labored breathing, altered sensorium. All of these are basically compensatory mechanisms for the metabolic acidosis. So they should raise a red flag and we need to send a blood gas analysis. Now, how do we diagnose the DKA? So it's a classical triad: hyperglycemia, ketosis, and metabolic acidosis. Sugar levels greater than 250 or 13.9. Ketosis, positive ketones in the blood or urine, and metabolic acidosis with a pH of less than 7.3 or a bicarb of less than 18. You need all 3 of these criteria for the diagnosis to be confirmed. Now, depending upon that, there can be categories: mild, moderate, and severe, where the pH keeps reducing, bicarb keeps reducing, anion gap keeps increasing, and the mental status keeps deteriorating. So those are the 3 levels. The management algorithm, this is an overview flowchart which we'll see in detail. So the 2025 consensus tells us that we are dealing with 4 steps in the management. Step 1 is your fluid resuscitation, the first 60 minutes. Step 2 is not insulin, but it is the potassium. It is the hard stop. Step 3 is your insulin, which is the main metabolic engine. And step 4 is the D5 switch, which helps prevent the hypoglycemia. So when we look at the first step, which is obviously the fluid resuscitation, we always rely upon our normal saline, but it has a risk of causing hyperchloremic metabolic acidosis, which will only worsen your DKA. So now we are seeing a shift from the NS to more balanced crystalloids in the form of RL and plasma light. How is it given? Initial 1 hour, 1 to 1.5 liters bolus, and then followed by 250 to 500 ml as a maintenance depending on the hydration and cardiac reserves. Second step is the potassium. That is the main hard stop. If your potassium level is less than 3.3, do not start with your insulin drips. It has to be above 3.3, then you can start a parallel drip. More than 5.3, you can begin, but you need to monitor your potassium. Only after your potassium is secure comes your third step, which is the insulin therapy. Avoid the IV bolus as it can cause cerebral edema or a rapid hypokalemia. Start with the infusion, 0.1 units per kg per hour. Goal is a steady drop in the glucose at 50 to 70 per hour. Lastly, we don't want to prevent the hypoglycemia, so you start with a D5 switch as soon as your sugar levels fall beyond 250. Reduce the insulin rate and add dextrose D5, because the crucial point is that insulin needs to continue until your anion gap is closed, so you need to add the dextrose to keep the drip running. Resolution checklist. Please focus that there is no mention of sugar on where to stop the drip. Resolution is only when anion gap is closed, less than 12, bicarb is greater than 18, and pH is greater than 7.3. Only then can you stop the drip. A common pitfall is that we stop the insulin when the sugar is normal, but as I said, gap isn't closed, so you need to continue by adding the dextrose. Another important thing, we always think that acidosis, treat with sodium bicarbonate. That is a very common practice. But we need to know that in this case, bicarb is not only unnecessary, it might be potentially harmful as it causes cerebral edema and might precipitate hypokalemia. So bicarb is only indicated when there is critical acidemia with pH less than 6.9 or life-threatening hyperkalemia. Other than that, avoid your bicarb. Another
2
important
minutes
thing,
remaining.
euglycemic DKA. Nowadays, patients are on glyphosins like the dapagliflozin, empagliflozin a lot. So in those cases, sugar is normal, but there would be metabolic acidosis with ketosis. So in such cases, the sugar is already low because it is being excreted via the renal route. So the treatment is same as DKA, but the difference is that you add dextrose from the beginning to prevent the rebound hypoglycemia. So a take-home point is, in the era of SGLT2 inhibitors, a normal finger stick glucose does not rule out DKA. If the patient is on a glyphosine and looks sick, you need to order a VBG and check the ketones. So the learning lesson here is, the most dangerous thing you can do in DKA is to focus on the sugar. You fix the volume first, protect the potassium second, and use the insulin to clear the ketones. We don't stop when the sugar is normal, we stop when the gap is closed. So in a nutshell, in the crash, you use IV dextrose D10. In sulfonylureas, you add octreotide, and glucagon is only pre-EMS. In the rush, fluids first, potassium second, insulin later. And in euglycemia, glyphosins plus anion gap, you need to treat as DKA. So coming back to our questions, here the answer would not be 50 ml of D50, but it would be 100 ml of D10. We are going towards a more physiological, safe practice. And in this case, it would be holding the insulin and starting the potassium replacement, because potassium is always over insulin. So my take-home message here is, the goal isn't just to normalize the number on the glucometer. In the crash, we prevent the rebound. In the rush, we clear the ketones while protecting the potassium. You master the gap and you master the metabolic storm. On that note, thank you so much for a very patient hearing.
Thank you, Dr. Ayushi. We will keep the questions to the last. Next talk is by our doyen cardiologist, Dr. Milan Chhag. He is going to talk about a case of recurrent cardiac events in spite of treatments. And he is going to bring out the various thoughts regarding this. Thank you.
Okay, good morning, everybody. Thank you, Subhas bhai, for kind words. So it's an important topic and it's slightly long. I'll try to finish in 15 minutes. See, it's a case, just think about it. There are no question answers, but just think over it and just note down. And at the end, we'll discuss. So he's a 60-year-old male presented with NTS STEMI, underwent primary PCI of LAD with drug-eluting stent. Now ejection fraction is 40%. He's hypertensive, mildly obese, diabetic since 15 years, HbA1c is 7, EGFR is 70. Recent lipids are like this: total cholesterol 130, LDL 45, HDL 30, triglyceride 150. He was on aspirin because he had past history of MI in past and stroke also, so he was already on good medication. So he was on aspirin even prior to this admission of STEMI. So he was on aspirin 75, clopidogrel 75, bisoprolol 5, enalapril 5, BID, atorvastatin 80, spironolactone 25, metformin 500 BD. And this was modified after this primary PCI. Clopidogrel was switched over to ticagrelor 90 BD, and dapagliflozin 10 mg was added. He had family history. Father had PTC at age of 50, and his past medical history had 8 years back. He had acute inferior MI, successfully thrombolized. He had recanalized RCA, and he was left on optimum medical therapy. At that time was 55% plaque in LCA was there, LAD was there, but now that has actually ruptured and caused anterior MI, and that's why he had come to us this time. 3 years back, he had ischemic stroke, recovered. 2 years back, angioplasty of common iliac artery, critically symptomatic lesion, and that was also treated with stent. So do you have suggestions? Do you have any tests? Any tests you want for the tests, or do you want any treatment change? Note down, we'll discuss at the end. So in in the initial area, when moderate intensity statin were used, still, residual risk was around 60% with moderate dose of statin. And with high dose of statin, and even with addition of ezetimibe, PCSK9 inhibitors, and with bempedoic acid, you reduce your LDL to even up to 85%, but still residual risk is 44%. So why is it so? This residual risk is beyond LDL. We are targeting LDL vigorously, but still risk is almost nearly 50%. What is due to that? Why it is so? So it can be inflammatory risk, marker of that is HSCRP more than 3. It can be thrombotic risk, there is no simple marker for that. There is triglyceride risk, marker is TG more than 150. There can be risk because of high LPA, cut point is more than 50. There can be residual diabetic risk like HbA1c, we know BMI, obesity is also now risk factor. And there can be heart failure and renal risk where markers are NT-proBNP, USCR and EGFR. So we'll discuss what that. So to this, assess this, additional tests were done. His HSCRP was 4.1, his UACR was 1200, LPA was 55, NT-proBNP was 700. So let us discuss. What is the evidence that inflammation increases MACE? Pointer is there, okay. So here is a HSCRP less than 1 and more than 3, and this is the LDL level. At any LDL level, even at the LDL of less than 20, as HSCRP increases to 3, risk is almost double at any level of LDL. So clear cut, and that was in 27,000 patients in this Fourier trial. So it was clearly mentioned that inflammation is the cause. And colchicine, which is interleukin-1B inhibitor, reduces inflammation and CV risk. And we have got now meta-analysis of 5 randomized control trial on colchicine, more than 11,000 patients. MACE was reduced, colchicine 0.5 mg per day was compared with placebo. MI was reduced by 22%, stroke by 46%. Need for repeat revascularization was reduced by 23%. Although there was 18% reduction in mortality also, but that was not statistically significant. And you should keep in mind that EGFR should be more than 60 when you want to start colchicine. So our patient had HSCRP of 4.1, EGFR was 70, so in this patient colchicine 0.5 mg was added. What about residual thrombotic risk? What is the evidence beyond DAPT? He was already on aspirin and ticagrelor. See, we got COMPASS trial, more than 27,000 patients with stable ASCVD, where rivaroxaban 2.5 mg twice a day plus aspirin 100 per day was added, and there was further 24% risk reduction in death, MI, and stroke. So it is a useful molecule as a third, as an additional molecule to aspirin. So in our patient, TIMI risk score for recurrent event was high. Should we add rivaroxaban 2.5 BD? It may be added, but we have to be careful about bleeding risk because there is no data for triple antithrombotic therapy of this regimen in sinus rhythm if a patient is receiving ticagrelor on long term also. So we can add, but you should be very careful. It should be a shared decision with patient that bleeding risk may increase. What about triglyceride risk? We know that as triglyceride goes beyond 100, your CV risk is increased. And not only that, triglyceride actually induces inflammation also. So as your LDL is increased by 1 millimole, that is 38 milligram, your CRP is increased by almost 6%. Every millimole increase in LDL, CRP increases by 6%. But more than that, VLDL and IDL, which are triglyceride-rich lipoproteins, there every millimole increase causes 36% rise in CRP. So triglyceride itself not only is a risk factor for ASCVD, it actually induces inflammation also. And if you see triglyceride treatment era, pre-statin era, there was gemfibrozil, there was bezafibrate, there was fenofibrate. There was some benefit when statins were not there. Individually, when they were given for high triglyceride, there was some reduction in MACE, but as soon as statin came and people started using statin, in ECHO trial, very large trial, fenofibrate plus simvastatin, risk reduction was just 6%. And after that, almost all trials have shown that when you combine fibrate with statin, there is no additional benefit. So fibrates are actually out.
And last hope was with the prominent trial where more than 10,000 patients were very effective pemafibrate, and that was a fibrate which is reduced triglyceride level by almost 26%, but there was no clinically beneficial outcome. No non-fatal MI, ischemic stroke, or need for coronary vascularization or death was not reduced at all by this pemafibrate. So fibrate reduces triglyceride, but somehow clinical outcome is not there. But reduced trial with icosapent ethyl was positive. 2 gram BD was given in patients with established ASCVD with or without diabetes or with risk factors where triglyceride was 135 and above, and LDL was reasonably okay, 40 to 100. So LDL was not very high, triglyceride was high, and when icosapent inside 2 gram BD was given, everything was better. 25% risk reduction in maize and 26% risk reduction in 3-point maize. So in this patient, triglyceride was reduced by just 19%, but ApoB was reduced by 10% and HSCRP by almost 40%. So although triglyceride was not reduced much, there was still huge clinical benefit, and possibly that was because of reduction in HSCRP of almost 40%. If you see about omega-3 fatty acids, people take pill of fish oil and over the counter is available, but that fish oil contains both. It contains EPA and DHA, and almost all first 5 trials where DHA was there with EPA, there was no clinical benefit. But when pure EPA was used in last 3 trials, jellies, respect EPA and reduce it, there was clear-cut beneficial effect in CV outcome. So when you want to use omega-3 fatty acids, it should be only EPA. Icosapent ethyl is available in India also now in a purified version, and that may be used. So in our patient, TG was 150, LDL was 45, and still he gets recurrent events. So icosapent ethyl 2 gram BD was added, or maybe added. What about LPA risk? See, we know that LPA is a risk marker. As LPA increases, your CV event rate increases. And we have got many molecules in pipeline actually. So in next 3 to 5 years, we will have all these molecules, but they are all very expensive molecules. We have now PCSK9 inhibitor available. Evolocumab reduces LPA by 30%. Inclisiran reduces by 15 to 25%. And many trials are going on with antisense oligonucleotides, small interfering RNA, and even lipid apheresis. This around 30 or so. Then independent influence of LPA is minimal. So I personally believe, time will tell, that pharma industry is making hype about LPA as if it is a very dangerous molecule. It is dangerous, but independent risk beyond the LDL is yet to be proven. And if you keep your LDL to this level, around 30, 40, then LPA risk enhancer effect is minuscule actually. It is just minuscule, not more. So it is pharma industry which is now coming out with so many monoclonal antibodies and siRNA, so they are creating a hype. That is my personal belief. Let us see, time will tell. What about diabetic risk? We know that when we give SCLT2 inhibitors in EMPARAGE and even GLP-1 like leader, liraglutide, they reduce CV death and heart failure hospitalization. And GLP-1 receptor agonists have even anti-atherosclerotic effect, and that was shown in leader as well as in SUSTAIN 6 with liraglutide and semaglutide respectively, that if you give this GLP-1 receptor agonist, it is not only helping to reduce MI, it reduces stroke also. So, and even in select trial, semaglutide, 17,000 patients with established ASCVD with BMI more than 27, with or without diabetes, you can give that. Semaglutide in slightly higher dose, 2.5 milligrams sub-Q weekly, clear-cut risk reduction in MACE and death also, 20% and 19% respectively. See, in our patient who has polyvascular atherosclerotic cardiovascular disease, he had stroke, he had MI, he had peripheral vascular disease, diabetic, obese, already on dapagliflozin, we can add semaglutide for anti-atherosclerotic, CV and renal benefit as well as weight reduction benefit. What about, lastly, about heart failure and renal risk? See, should should we further optimize heart failure and DKD therapy
minutes
in our
remaining.
patient? His ejection fraction is 40%, NT-proBNP is 700, EGFR 70, USCR 1200. What is about his renal risk? Dr. Mawani discussed in the morning that not only GFR, you have to see about albuminuria. So in our patient, his GFR is 70, so he comes in the G2 category, but he has a huge albuminuria. USCR is 1200, so he comes here, that is moderately high risk category, orange, and CV risk is increased by almost 2.5 to 4-fold. So that is very, very significant. And Finerenone is the trial which was discussed, Fidelio DKD trial, effect of Finerenone on chronic CKD outcome in type 2 diabetes, 5,700 patients. Primary endpoint, kidney endpoint was significantly reduced, and even secondary endpoint like CV death, non-fatal MI, non-fatal stroke, and hospitalization for heart failure was also significantly reduced by Finerenone. So this drug should be added. Spinal electron should be switched over to Finerenone in our patient because he is having CKD stage G2A3, very high risk category. And about what about heart failure? His EF is 40%. We know about paradigm heart failure trial. ARNI is there, which was tried in more than 8,000 patients, 40% or less EF, class 2 to 4 heart failure. Our patient has EF of 40. Enalapril should be replaced by ARNI, and that may benefit him further because his NT-proBNP is 700. So, and what about LDL? Is it optimal? Is lipid profile is like this, 45. Do you want to change? You want to reduce further? What guidelines says Lipid Association of India, even in 2020, 5 years back, it has clearly showed that LDL should be less than 30 if patient has polyvascular disease. Our patient has everything, coronary, stroke, and peripheral vascular disease. And he has recurrent event also. So his LDL goal should be less than 30, not even that 45 is not acceptable for him. And we know that when we add bempedoic acid or ezetimibe over statin, you can further reduce LDL by 36%. You can reduce the HSCRP by almost 35%. So it is very, very significant effect of triple therapy. So in our patient, LDL goal is less than 30. We should add bempedoic acid 180 milligram, ezetimibe 10 milligram, and still if he is not reaching to less than 30, PCSK9 inhibitor or inclisiran or evolocumab are still an open option. So this is the final slide. Our patient, we have seen this. Now cholesterol risk is high.
2 minutes
He
remaining.
is on atorvastatin 80, but I'll add ezetimibe and bempedoic acid and wait for the response. If it is reaching to less than 30, he should be fine. PCSK9 inhibitors are not required. What is about inflammatory risk? I'll add colchicine 0.5 milligram per day. Monitor his liver and kidney. Thrombotic risk is there. Aspirin 75, Tika 90. I will add now rivaroxaban 2.5 BD and keep bleeding risk in mind and inform the patient also about any kind of GI bleed, which is there, melena or even drop in hemoglobin should be monitored. Triglyceridic, I will add icosapent ethyl 2 gram BD over statin. He has LPA risk, but will wait for outcome trial, will not start evolocumab for just LPA reduction. He has diabetic, metabolic, and obesity risk. He is on dapagliflozin, but LS oral semaglutide, which was available in India, but now even sub-Q is available, so we can give 2.4 milligram sub-Q semaglutide once a week. That will definitely help his. It has anti-atherosclerotic effect also, apart from the kidney benefit and CV benefit. And is for heart failure and renal risk, I'll add ARNI and Finerenone from enalapril and spironolactone. I will switch over to this. Thank you.
Thank you, Dr. Millen. We can take the questions at the end. Now, a very extensive and very good analysis. The next talk is Less is More, the Future of Cardiac Surgery by Dr. Amit Chandan.
Good morning, everyone. I'm glad to be here and I welcome you all.
So my name is Dr. Amit Chandan. I am a minimal invasive and robotic cardiac surgeon at Meringo Sims Hospital. And my topic is less is more, the future of cardiac surgery. So I have no financial disclosures. So with the advance of technology, everything is getting smaller and smaller. You know, the earphones have become smaller, the cameras and mobile phones. Our mobile phones have practically become our laptops. And this influences cardiac surgeons as well. So why do a long sternotomy when you can do a surgery through a small thoracotomy? So these are the 4 levels of minimal invasive surgery. The first is the direct vision. The second is video assisted. The third is through port incision, that is endoscopic cardiac surgery. The fourth is robotic cardiac surgery. So this is a typical picture of where we do a sternotomy, and after sternotomy, everything is right in front of your eyes. But when you know which part of the heart to operate, why do open the full chest when you can look at the specific portion of the heart, and with the small thoracotomy you can operate on that. So if you want to go for mitral valve replacement, ASD or LA myxoma, you can go for right thoracotomy. If you want to do a mixed CABG, you can go for left thoracotomy. And if you want to go for aortic valve replacement, Bental, or even ascending aorta replacement surgery, you can go for right anterior thoracotomy or an upper mini sternotomy. So here again we have started a robotic cardiac program 2 years ago, and we do surgeries through 3 port incisions where we place the camera port and the 2 instrument ports using a robotic instruments. So this is again the pictures of what we discussed in this earlier slide: the left anterior thoracotomy, the right anterior thoracotomy incisions, and these are the hemisternotomy and the right anterior thoracotomy incisions. The advantages of minimal invasive and robotic cardiac surgeries are they are least traumatic, and this reduces the blood loss, again causing less transfusion of the blood. The post-operative pain is minimal. The wound infection chances are close to nil. Patients are mobilized early, and there is shorter hospital stay and ICU stay. Thus, the recovery is quick, and if at all patients require second operation few years down the line, the second operation is quite safer. As far as patients are concerned, they're happy with small cosmetic scars, and they're happy to return to their normal lifestyle and normal activities as early as possible.
ये साउंड का लफड़ा होगा। अच्छा, बढ़िया किया। और रहना किधर? अच्छा, घर के बाजू में ही गोडाउन है। नगर में ही है रहने का। फैमिली में कौन? साथ में वही करते हैं, यही करते हैं। एलईडी का वो संभालता है। एडिटिंग में उसने किया मुझसे पहले।
तो उसका ये था ना, ये क्या
तो क्या करना है?
ये आपका नहीं पड़ेगा?
हाँ हाँ हाँ, कर दो अभी कर दो ना। नहीं, मेरा क्यों बंद हो गया ये? नहीं नहीं, ऐसा तो नहीं होता। पावर ऑन करो जरा। ऑन है, ऑन दिखा रहा है आपको? मॉनिटर चला गया। अरे બધી થઈ ગઈ સિસ્ટમ. હા ઓન કરી દો. વાયર જોઈ લો. પાછો પાવર સપ્લાય કાઢીને કરો. ઓન કરો. ઓન જ નથી થતું. શું વાત? હા બરાબર. અને હવે બટન દબાવો આગળ. ફાયરિંગ આવ્યું, હમિંગ આવે પછી પછી બધું નીચે ના હોય, નીચે ના હોય, ફરી ઉપર ના હોય. તો બુદ્ધિ તો કઈ નહીં છો. મને એક કેબલ બહાર આવ્યો છે ત્યાંથી જે આવે છે. તો પછી આખો ડબ્બો જ ચેન્જ કરવો પડે. ફરીથી વાળું કરે કે વાળું કરીએ વાળામાં કરવું નથી. લેપટોપ કોપી નથી મૂક્યું. છે ને ખાલી જો વાયર અહીંથી આમ રહી સાચી વાત હા વાયર કાઢ નાખો પાછળથી લેપટોપમાં હા 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 થઈ ગયું તમારું તો તમારે કીધું કેટલા કલાક ચા વાગે ચા ટાઈમ સુધી તમે लेक्चर चालू लेक्चर ये लेक्चर आपका लाइव में जा रहा है। हाँ कैसे डाल मैंने वो डायरेक्ट उसमें डालना है लाइव जा रहा है उसमें इसका स्पीकर का दे दो ना, जो स्पीकर में जैसे इसका मास्टर दिया ना, इसका दूसरा मास्टर नहीं दिया।
ये भी मास्टर ऊपर छीछे रही है। अभी आपको क्या लगता है?
तो स्पीकर मारा ना मास्टर। हाँ, इसका ये सेपरेट रिकॉर्डिंग, वो जो हो रहा है वो मिक्सिंग हो रहा है, सेपरेट होके एडिटिंग के लिए ये चाहिए।
केबल है छोटा,
ये यहाँ पे इनपुट दे दो तो आ जाएगा।
केबल ठीक, मैं बस ब्लैक में ये उसमें चला जाना। रुको रुको, आपने भी उधर डाला ना, ठीक है। इसमें एक काम करो, ये इन आउट वाला ना, इसमें HDMI आउट निकलता है। माइक लाया, ये क्या निकलता है जी? ये देखिए ना
हैं? हाँ, अपना मन भाई चालू कर एक बार।
चालू किया
एडिटिंग में यही चाहिए, एडिटर नहीं चाहिए, ये तो टेम्पररी दिखाने के लिए है। रीडिंग में तो पूरा एडिट होता है इसमें।
ये जो आपको डी है ना, अभी ये आउटपुट निकलता है इसमें।
तीन इनपुट है,
तीनों के इनपुट
आउटपुट यूएसबी का
कैसे कार्ड है आउटपुट वाला, वो तो आपका खराब है।
आपको क्या चाहिए?
मैंने आपको एक आउट दे दिया, आपका मैसेज कर ले, तो व्हाट्सएप पर एक आउट दूसरा अब तो रिकॉर्ड ही कर रहे हैं।
HDMI केबल
मिल जाएगा,
तो HDMI हाथ से देखो, इसमें से आउट निकल जाएगा।
इसमें से आपको निकाल
इधर
से निकालना होगा।
देखो ये था।
Hello. Hello. JIC.
Hi, good afternoon. It's 2:25, post-prandial session will start right on time, and I'll invite the chairpersons. Dr. Mayur Bhai is here, Dr. Akhil Mukim, Dr. Deepak Chaudhary, Dr. Jitendra Anand, Dr. Kishore Seth, Dr. Pradnya, if they are around, and Dr. Ashok Khatri, Dr. Bhavesh Virani, Dr. Rakesh Chajed, Dr. Suresh Khatod. Dr. Mayur Bhai is already here. And Dr. Satya, if he's around, he can just join me. We have 5 talks in this session, and we will start off with landmark trials in cabbage, CABG. Dr. Nikunj Vyas. As you start speaking, people will come. Speak loudly.
Good afternoon, everyone. Welcome to JIC 2026. It's been a sweet and warm welcome. Myself, Dr. Nikunj Prakash Vyas. I'm a cardiothoracic surgeon. So today we'll be discussing about landmark trials in CABG. I have no conflicts of interest, and in no context I have any issues with this. Do we demand a trial? Then and now, people, cardiologists, surgeons, even physicians, everyone demands trial for proving their point. So let's see ahead. Landmark trials in cardiac surgery are clinical studies that fundamentally changed practice. It reshaped guidelines and established new standards of care. So first of all, does CABG actually improve survival compared to only medical line of management? Multiple theories, multiple trials done from 1977 onwards to 1988 like VA cooperative study, European coronary surgery study, CASH study, even one of the trial of 10-year study where effect of coronary bypass surgery on survival was performed, out of which more than 1,000 patients enrolled for early CABG and almost equivalent number of patients enrolled for medical line of management. 93.7% of patients underwent CABG actually, while there were CABG crossover rates at 5 years 25%, 7 years 33%, and at 10 years 41%. As we see, patients undergoing CABG had less mortality at 5 years, 7 years, and 10 years as compared to only medical line of management. They survived well in cases of left main diseases, abnormal left ventricular function, as well as in class 3, class 4 angina. Second trial was performed to discuss whether CABG, not only CABG, along with that, initial invasive strategy, that is percutaneous coronary intervention, do these symbiotically actually improve survival as compared to only medical line of management. So in one study, similarly, it showed that CABG shows better outcomes than only medical line of management, whereas ischemia trial, which came upon, showed that ischemia trial suggested that PCI or any invasive intervention like CABG are beneficial to medical line of management or equivalent to medical line of management. What did this suggest, or what does this trial, ischemia trial, in stable coronary artery disease suggested? That at 6 months and 5 years, 6 months, there were less chances of rehospitalization or recurrent MI in cases of invasive treatment, whereas at 5 years, the mortality rates are almost same if the patient underwent for an invasive treatment or only medical line of management. But contrasting point is, for CABG, was it helpful? No, because only 398 patients received CABG out of around 2.5K patients. And this pre-surgery or pre-invasive treatment was beneficial only in cases of left main disease followed by triple vessel disease. Next came up with trial involving CABG compared to medical line of management in severe LV dysfunction. This led to trial of stitches and stitch trial, comparing 5-year data and 10 years data down the line in cases of severe LV dysfunction. So what happened was, at 5 years, there was no difference, no short-term benefit or mortality benefit of cardiovascular deaths or recurrent hospitalization from cardiovascular events. Whereas Stitches trial came up with, no, wait, 16% reduction in all-cause mortality was found in cases of patients undergoing CABG in previous stable coronary artery diseases with left ventricular dysfunction. This led to one more trial comparing bilateral internal mammary artery. Is it better than single internal mammary artery? Is it fancier? Is it glamorous thing? Just bilateral mammary is being harvested or single mammary? The most cited article and most well-published article is this, in which it stated that there is almost similar survival rate with bilateral mammary arteries as well as single internal mammary arteries being used for coronary artery bypass surgery. But the significant factor was reoperation. Patients down the line, you can see at 4 years or 5 years down the line, the rate of reoperations were less or mere zero in cases of bilateral mammary arteries being used as compared to single internal mammary arteries. So what did it came to conclusion that beta versus theta, beta is not superior to theta, but in first decade of life, as it progresses, bilateral mammaries are being found to be useful for the patients. As compared to that, multiple arterial grafts like mammaries, radial arteries, gastroepiploic arteries in conjunction compared to single arterial graft, multiple arterial grafting found to be very, very useful as well as satisfactory. But the confounding factor was patient used with Bilateral memories have risk of developing sternal wound infections as well as sternal wound dehiscence. Apart from that, the results are found to be wonderful. Next came up with trials comparing PCI versus CABG. With the evolution of stents, PCI was found to be more or equivalent to CABGs. But they came up with syntax trial. What does syntax trial suggest? All-cause mortality, triple vessel disease, left main diseases, and syntax score more than or equal to 33. But what happened is, there was no difference in mortality or in cases of left main diseases. But triple vessel disease, as well as syntax score or equivalent to 33, were found to be beneficial in cases of CABG as compared to PCI. Later came up with FFR-guided angioplasties with CABG. And FAME 1, FAME 2, FAME 3, three trials came up. First one compared angiography with CABG. Was found to be patients had mortality rates were higher because cardiologists may be using more stents at FAME 1 trial was introduced. But gradually, as medical line of management improvised with FFR-guided PCIs, the rate of mortality reduced. And as trials improvised, there was no statistical significant difference between PCI versus CABG in FAME 3. Then further, coming in diabetic patients, what was it found? That Freedom trial, the most commonly used trial, CABG was found to be superior as compared to PCI. What did we found? That primary endpoint, all-cause mortality, myocardial infarctions, recurrent myocardial MI, stroke rates were less as compared to percutaneous coronary interventions. As well as in left main diseases, two main studies, Nobel trial as well as Excel trial. Those trials also stated that CABG was better, complications rate like death were higher with PCI, and there were re-intervention rates were lesser with CABG as compared to PCI. Now it came up with surgery. Okay, chalo, we'll start with comparing CABGs. Can we do CABG on pump or off pump? Which were found to be suitable for patients or best results. You can see there were no statistically significant difference between MI, stroke rates, or recurrent revascularizations. So these were the studies being performed, and mind you, these were the studies, they helped us guide whether CABG was found to be useful in all patients. And still the question arises, do we still need a trial to compare or suggest a point? I think that would be enough to say that CABG was found to be useful in case of left main diseases as well as in left LV dysfunction in suitable patients. Thank you. Thank you, sir.
Thanks, Nikunj. I think everybody can just compile their questions together and we can have all the questions during the panel discussion. Dr. Anish, I'd like to invite Dr. Anish to his talk on very clinically relevant issue. Critically ill patient with pneumonia in ICU has high HS troponin with minimal ST changes. How to approach?
Good afternoon, everyone, and thank you, Dr. Ajay Naik, the chairpersons, the moderators. I'm very sure those who are keen to learn things have completed their lunch timely, little less, keeping some space in stomach so that they have attentiveness to attend to the lecture. So this is a very common topic which a physician come across. You have a patient who is critically ill, maybe hypotension, tachycardia, desaturation, you are working on sepsis, UTI, respiratory infection, and then maybe because a patient has got some kind of chest pain or uneasiness, or maybe because for the sake of routine, or maybe there is an enthusiastic fellow like what we have, they send a panel of tests without sometimes thinking. And the problem starts when in such a patient troponin comes up. What to do? So this is the case which I am going to present, no conflict of interest. This is a gentleman, 72 years, diabetes for last 3 to 4 years, well controlled with a single pill, mild CKD, no history of ischemic heart disease, and patient has not been on any cardiac treatment, even he was not on statin or aspirin. On day 1, he is admitted to ICU with pneumonia and hypotension, sinus tachycardia, rate 128, noradrenal infusion was started by the intensivist, antibiotics on board, creatinine 1.9, EGFR 3540, SGPT 76, hemoglobin very low, platelet count quite low, total count high. So mind well, every patient whom you look or start looking from cardiovascular perspective, from the history itself, and from various tests, your brain has to start separating them into whether he is a normal bleeding risk patient or whether he or she is a high bleeding risk patient. Because once you have to use cardiac molecules, you have to have this judgment. And this gentleman has got extremely high risk of bleeding based on whatever history is so far. He has been on oxygen, saturation is 94. He was treated for 1 day, day 2, when as a physician you went for round. Patient complained of little mild chest discomfort, not very specific, little diffuse on left side. ECG was taken. Unfortunately, there was no ECG taken on day 1. It showed mild STT changes, global, all the leads minimum changes. Echo was done, ejection fraction 50%, as it is done in emergency, in ICU with patient on so many other issues. Most of the times, unfortunately, echocardiographer does mention there is mild RWMA. So, kutta na dhobi ka na ghat ka, they just keep, there is mild lateral wall hypokinesia. So, sometimes you have to take this finding with a pinch of salt. Mild sclerotic aortic stenosis with a gradient of 25 millimeter of mercury. So, troponin which was done came and it was 0.032. So, in our lab at SIMS, the normal value is 14. So, it was 32, more than 2 times upper limit of normal. So again, the physician was little confused that what to do. Patient has got high bleeding risk, whether it is really acute MI or not, he was not sure. But he started one molecule which I believe was good, that fondaparinux 2.5 milligram, which can help to prevent DVT, which can help in even unstable angina and acute coronary syndrome, and a relatively low bleeding risk. So he started 2.5 milligram fonda, which was a good decision according to me. Day 3, they just kept on treating patient the same way. Day 3, troponin was repeated. It went further up. Now it is 48. So it is 3 times upper limit of normal. And if you look to the deviation, the first value which was 32, the second is 48. So it is almost 40% increase in the pre-existing troponin. So that's very, very important. You are dealing with a patient whose troponin is acutely changing. That is something which is so important. ECG was done, which was same, hemodynamic same. So let me read question for you. What is your diagnosis in this patient? Is it myocardial infarction? Is it myocardial injury? There is no infarction. It is just myocardium is damaged. Third, no injury, no infarction. Elevated troponin is because of CKD and sepsis. And 4, I am a cardiologist, so I cannot opine before angiography is done. So maybe your time starts now. We can have the timer. So most of the people say it is no injury, no infarctions. I'm very sure that there is a huge role of understanding what I talk in next 7-8 minutes. So what is myocardial injury? Anytime when you get troponin elevated, it is injury because of any reason. May it be CKD, may it be sepsis, may it be rheumatic heart disease, may it be rheumatoid arthritis, systemic sclerosis, acute MI, myocardial, whatever reason, if troponin has gone up, even it can go up after a long marathon run. It goes up for 80% of the people who run marathon. So even whatever happens, when troponin has gone up, it means there is myocardial injury. So myocardial injury is a broad term. It can be acute or chronic. What is chronic? CKD will lead to chronic myocardial injury. Maybe other so many conditions, say for example, severe rheumatic heart disease, severe cardiomyopathies, severe chronic coronary syndromes. All these patients will run troponin little higher than normal, and they will have that same level of troponin with less than 20% variation persistent for life if they are not treated well. So that is called as chronic myocardial injury. While there are people who have got troponin normal, but now because of some acute insult, may it be again trauma to heart, may it be acute myocardial infarction, may it be acute sepsis, may it be hypotension, sepsis, tachyarrhythmias, and troponin is up. So that is acute injury. So whenever you see troponin high, you have to stamp it as myocardial injury, and then you have to define whether it is acute. So is there a troponin which is showing deviation of more than 20%, or is it chronic? Now what is myocardial infarction? Myocardial infarction is a part of injury. Injury is a very, very broad term. There can be variety of reasons of injury. One reason, which is quite common and which we are interested is acute myocardial infarction. That's where there is issue with the blood supply need, demand, and supply given. So that is called as infarction. And in infarction, there are various types. 2 types are very important for the physicians to understand. Type 1, that is typical what you know, there is an atherosclerotic plaque. It gets disrupted. there is superadded thrombus formation and a patient gets acute MI. If the thrombus is fully occlusive, it is ST elevation MI. If thrombus is non-occlusive, it is non-ST. That is called as type 1. So what is type 1 is, there is atherosclerosis and there is thrombosis. While in type 2, there is no thrombosis. It's pure demand-supply mismatch. Say, for example, there is a 50% block in the coronary artery of a gentleman of 72 years. It was silent. It was not causing ischemia. It was not giving symptoms. But now there is increased demand. Heart has to work at a rate of 130 per minute. There is hypotension. There is sepsis. So now heart is not able to meet the supply which is needed. And that's why there is infarction. So that is called as type 2 myocardial infarction. So as I discussed, injury is a broad term. Within injury, there comes myocardial infarction. Injury can be there because of variety of reasons.
5 minutes
But once
remaining.
troponin is high, you have to stamp it as injury. What are the reasons? See, as I discussed, non-ischemic myocardial injury. There can be cardiac cause, there can be non-cardiac cause. Sepsis, chronic kidney disease, stroke, pulmonary embolism, infiltrative disease, chemotherapeutic agents, critical ill patients, they all can have myocardial injury. Even when we operate patients, say for example, we do TAVI, we do mitral valve surgery, a cardiac surgeon does open heart surgery, troponin will go up. That is myocardial injury. While myocardial infarction is, as I discussed, type 1, there is atherothrombosis. Type 2, there is no atherothrombosis. It can be coronary artery spasm and patient might have chest pain. It can be microvascular dysfunction. It can be spontaneous coronary artery dissection. It can be coronary embolism. Or it can be because of non-cardiac conditions, say for example, anemia, tachyarrhythmias, bradycardias, hypotension, hypertension. But believe me, it's very difficult to differentiate between these two. Look at our patient. Our patient has got 3 features from here. Has got sepsis and infectious disease, has got CKD, and is critically ill. So there are features to suggest that patient would have myocardial injury without ischemia. And he has also features to say that he might have type 2 myocardial infarction. He might have ischemia because he has hypotension, he has severe anemia, he has tachyarrhythmias. So it's difficult at times to differentiate between a myocardial injury because of other reasons versus type 2 myocardial infarction happening in such people. So this is just diagram. This is type 1 myocardial infarction. This is type 2. Patient might have blocks, but they were not significant clinically, but now with increased demand, they are significant. And there are so many other causes. So how to deal with this? If it is type 1 MI, which is typical, you know that ST elevation MI, send a patient for primary PCI. If there is no PCI center, send a patient for thrombolytic therapy. And if it is non-ST elevation MI, you treat as per the risk. If patient's risk is very high, you take patient on table early. Patient risk is low, you take a cool decision. While in type 2 MI, when you suspect type 2 MI, you have to be very careful and you have to treat patient by patient. You cannot have a blanket line that every patient is to be given LMWH, every patient is to be given DAPT, every patient is to be this, no. Because look at our patient. I believe he has type 2 myocardial infarction. He has troponin going up. He has troponin which has shifted by more than 40%. He has chest pain. He has ECG changes. So I will not take it as injury. I will consider it as ischemia. But patient is a high bleeding risk. So I will be very careful to select variety of drugs which I have to give to this patient. How to differentiate between injury and infarct? Very difficult. Because most of the times you cannot take such patients for angiography. Say for example, our patient in ICU, he's on the verge of going on ventilator. If you push him for CT coronary angiography, he would have very high calcium score. So CT angiography will not work. If you want to take him on table for routine angiography, CKD, AKI, sepsis, hypotension, again, what is the yield? A patient who has got non-elevation myocardial infarction, what will be the yield? So sometimes it's the MRI which becomes useful. So in a patient who has got ischemia, it is transmural fibrosis or subendocardial, while a patient who has got injury, it will be subpericardial or in the mid-wall. So MRI does give you some indications. So in this patient, what as I discuss is you have to treat etiology by etiology. But the most important point is you have to take care in terms of hemodynamics. So ladies and gentlemen, coming to conclusion about this patient whom I believe has got type 2 myocardial infarction and how I am going to approach. This is MI due to demand-supply mismatch, not because of the plaque disruption and thrombus formation. Our patient has got tachyarrhythmias, anemia, hypotension, hypoxia, and shock. That's why he has got type 2 MI. Such patients may present to you in emergency room or they may develop when you are treating them for other reasons. Angiography, IVUs, OCTs, pressure wires, provocative tests, they all can be done. But believe me, in such seriously ill patients, it's difficult to take them on table and do all these tests. And that's why many times you have to have a working clinical diagnosis based on your experience. And my working diagnosis in this patient is he has got acute coronary syndrome. He has got type 2 myocardial infarction. Treatment is based on ECG changes. So if such people get ST elevation, even a patient who is critically ill in your ICU gets ST elevation, atherothrombotic MI, better to take for PAMI, because in that situation, out of all, the best treatment is PAMI. But otherwise, treat as per the risk. Restoration of balance between oxygen demand and supply is the key. So correct hemodynamics, correct metabolism. Any patient in ICU should be treated to optimum hemodynamics and optimum metabolism. And prevention is very important. If you want to prevent such MIs, it's very important to give flu vaccines, pneumonia vaccines to senior citizens who need it. And all those who have got variety of chronic comorbid conditions, they should be treated extremely well. Thank you very much for your kind attention. This is the magic of 12 minutes. I always finish on the 12th minute.
Dr. Anish bhai, your lecture has opened up more questions than you have answered. So I'm sure we are going to have a good time during the panel discussion.
Thank you.
You can come here on the stage only. You can join us. And there's a switch. Dr. Pradnya has to go later for judging posters. So let me invite her for her talk on geriatric giants. Dr. Pradnya Digikar. Welcome, ma'am.
Hello. Hello. Good afternoon. Thank you very much for the organizers, Maringo and JIC 2026 for inviting me. Thank you, Dr. Urmil, Dr. Manisha. So, I am a physician and geriatrician. So, geriatric is the science of old people, diseases of the old people. And everybody is having Dadaji, Nanaji, even Chachaji, all are there in our house. And they are having so many complaints, but we ignore them. So ये तो old age का होता ही है, भूल जाते हैं तो होता ही है, बार-बार यूरिन जाते हैं होता ही है, नींद कम होती है. That is taken to be a normal, but as a geriatrician, we have to focus on it. So these are the giants. So what are they? So coming to more than 50 years ago, Isaac defined the geriatric giants as immobility, instability, incontinence, impaired intelligence, and memory. In few years ago, Morley, 2017, reported the 4 new syndromes: frailty, sarcopenia, anorexia of aging, and cognitive impairment. Now the geriatric nursing perspective, how will you treat, how will you diagnose, what are the problems? So nursing perspective, geriatric syndromes have been identified as falls. Old people get frequent falls, frailty because of muscle weakness, malnutrition, they are not eating, dental problems, multiple illness, then urinary incontinence, functional decline, pressure ulcers due to immobility, cognitive impairment. The care of older adults is a complex process because of age-related changes and the conditions that run together during the process of aging. Now fall. So fall is a result of a person coming to rest on a ground or another lower level freely under the influence of gravity. So sometimes there are recurrent falls, there are clustering problems, you are multiple tasks in your mind and there is a fall. So exclude all falls occurring from seizure, stroke and syncope. Fall rates and risk of injury for falls increase with age, 30% after 65, 50% after 85. So risk of fall, regulation of BP, central processing, gait, postural and neuromotor function, hearing and visual impairment, if it is there, then there is the risk of fall. Some drugs are there which can cause fall. So what are the external environmental? So the surface should be, if it is uneven, mats, rugs, some wires are there, water is there, dim light is there, furniture low height, so patient will have fall. Footwear should be proper. If it is loose, high, then patient will have developed fall. So situation which increase the risk of falling, like rushing for washroom, dim light is there. So type of multitasking, then there will be fall. So management, exercise, so strengthening exercise is very important. Whatever you are going in the morning in the garden and laughing exercises and that all strenuous exercise, it is not for old people. It is only strengthening. You can watch, those are going for 65 and for 50. The exercises are strengthening. You have to increase the strength of your limbs. Walking, leg exercise. Even in sitting position also you can do it. And there is no need to go for the gym and garden. If you are in the house, you can do this exercise. For strengthening is important. 1 or 2 kg you can hold in the hands and in the feet also. And I will advise the audience, because whenever you say you should have a lawyer friend, so she will help you in the legally. You should have a police. So the youngster are troubling to the geriatric patient. We have seen it. Then the third person is the physiotherapist. Of course, your physician is there, but physiotherapist is very important after 60. He will advise you and advise you the proper exercises, and he will make you do your all daily activities, going to bank or market or shopping or whatever you can cook, or your daily activities. So the physiotherapist will be the very important person for the geriatric population. Then supplementation, vitamin D is very important, shell cal and multivitamins. So these are the safety measures which I have already discussed. So I will not raise that. Now coming to the frailty and sarcopenia. So what muscle strength is decreased. So they are not eating, they are not doing exercises. They are bedridden or retired person playing cards and going for little shopping. So this decreases your muscular strength. Then mental weakness is also there. So how it occurs, you are going chronic undernutrition, then sarcopenia, muscle weakness will be there, reduced energy expenditure and decreased metabolic rate. So this will all cause frailty. Then frailty people may develop functional decline and disability following exposure to stressor like infection, fall, death, and addition to the new drugs. So these are the criteria. Linda Fried criteria is there. Unintentional weight loss of more than 4 kg in 1 year. Physical exhaustion by self-support. Muscle weakness evidenced by grip strength. Decline in walking speed and low physical activity. So the score is 3 out of 5. Now coming to the sarcopenia. So what is frailty and sarcopenia? You know menopause. What about the male patient? So there is adrenopause and andropause. So it causes your muscle strength weakness. It is not old age and not eating. So it is the hormonal decline in the male patients. So frailty may exhibit the following. Weight loss should be more than 4.5 kg or poor endurance presenting the feeling of exhaustion. Weakness, poor hand grip. So in OPD we keep the hand grip of patient. So you can make out how much it is decreased. Slow walking with short steps and decreased physical activity. Management, no specific management. Treatment, elderly person, he should, multi-prolonged management means necessary musculoskeletal function, you have to give nutritional support. Physical activity and diet is more readily modifiable. These are the exercise, food, adequate food intake should be there. Protein supplementation and supplemental vitamin D should be there. Now coming to the urinary incontinence, in the morning session, he discussed this thing, urinary incontinence. So I will not go into depression in elderly. Depression has its largest share leading to the decrease in quality of life, dependence on others. So it will cause suicidal tendency, medical illness and healthcare cost. So risk factor, demographic factors, psychological factors, loneliness, poor social, family support is not there, dependency, lack of family, bereavement, loss of partner, irregular dietary habits, lack of exercise and low spirituality. Depression associated with specific drugs like amidron, vitamin B12 deficiency. So clinical feature we know, memory loss and weight loss, dizziness, agitation. Treatment, non-pharmacological, they advise pranayama, music therapy, cognitive behavioral therapy in depression. So social One, I would like to, you should have a, if person is sitting lonely in the house, you should have friends, all types of relatives, friends of all age groups, even younger children and those who are 50 plus. Because you will lose your friends. When you will become 70, 75, your social circle will be decreased. So you should have a communication. And if I am not having any friend, my neighbor will give his bank of friends. So social 5 friends he will share, and she can talk with them. She should develop. So this will very helpful in the case of depression. Pharmacologically, we know all the drugs. I will not go into detail. Start low and go. So you have to judge how can he sitting in the chair, going, coming back, and again sitting with no hands of the chairs. So that is important. So that time will be delayed. Now coming to the dementia. So problems with language, loss of initiative, memory loss, disorientation, poor judgment, problems with abstract thinking, misplacing things, personality changes, difficulty in performing familiar tasks. Sometimes they keep the soap in the fridge, spoon somewhere. So these are the things, and he will forget his own house. So that is the initial stage. He will forget, he will keep the things somewhere, and he will ask, even the specs, it is not a joke, but the specs is over his forehead, and he will whole house he will search, where is my specs. So these are the initial things. So I will skip this. There are treatment, we in so many conferences, Alzheimer is very well discussed. I will concentrate with this pressure source. So bedridden patient is there in the house, and because of no movement, no exercise, no nutrition. So wherever in the patient is sitting in that position, she or he will develop bed sores. So these are the these factors. Then you have to, the stages: intact skin, partial thickness, and full thickness. So pressure relief, you have to keep the air bag, water bag, or keep ice in gloves and keep over below the ankle joint or sacrum. That is, you can do it. Cleaning, debridement, dressing is important. Now coming to the nutrition, this is very important part. Loss of teeth, loss of taste, loss of taste buds, and even GI tracts. So this patient will have a serious problem with morbidity and mortality. Unintentional weight loss will be there. So routine part of care. So malnutrition is an inadequate food intake, food choices that lead to dietary deficiency. हमने नमक डाला है, फिर भी patient बोलता है इसमें नमक नहीं है. That is because of loss of taste. So that's why he is not eating or she is not eating. Increased nutrient loss, poor nutrient absorption, or combination of other factors. So these are the taste loss, smell loss, satiety, gastric emptying. These all are decreased in old people. So modify dietary restriction, use of flavor enhancers, offer liquid nutritional supplement. Protein intake is very important. People are not eating, अंडा नहीं खाना है, chicken नहीं, fish नहीं खाना है, मगर protein का requirement you have to make it. Okay. Thank you so much. Just identify, address, diagnose, and manage these health issues and help in prevention. Okay, thank you so much. Thank you so much. Thank you.
Thank you so much, madam. Geriatric population is increasing worldwide and in India also. So I think geriatric physician had good future, I believe. Yes, sir. Yeah. So. Sir,
and there will be conference upcoming, Urmil sir.
Yeah, geriatric conference. Yeah. Geriatric. Yeah. So now the next session will be by Dr. Mukesh Sharma. I'll be inviting Dr. Mukesh Sharma for the next session, endovascular treatment of the brain aneurysm. Dr. Mukesh Sharma, please.
Thank you, Dr. Satyagupta, for invitation. Good afternoon, everybody. First of all, I would like to thank JIC organizing committee for this opportunity. Brain aneurysm is nothing than the just outpouching from the normal vessels of the brain. As it's grow, is thinned out. And at some point of the time, it's rupture. That is devastating, actually. And you all know, it's common in the female, usually appear during the productive years of our age. Okay, it's common in a very young age, actually. And most of the aneurysm which rupture, they are less than 1 centimeter in the size. So in the next few slides, we are going to discuss how to treat these aneurysm. It's not uncommon. It's out of 100%, 2 is having aneurysm, but not all aneurysms are rupturing. So all doesn't require treatment, but somebody is coming in your emergency with a worst headache of life, or you can the thunderclap headache, with nausea, vomiting, or LOC. 99% it's either it's a aneurysm is growing or it's ruptured. Okay, it's really devastating. 25% of patient after its rupture, which produces the SH, doesn't reach to the hospital, they die before it. Even those who reach to the hospital, 25% again they die in the next 2-3 days. And next 25%, if you treat, they end up in submorbidity. So it's really devastating disease. And I'm going to show the one case, young lady, medical by profession, MBBS, preparing for the MD actually. And you can see there is aneurysm over here. So this is a terminal IC aneurysm. So what we did, we placed a microcatheter from the femoral artery to the carotid, then up, and place the coil. It's so simple, like placing a catheter in a carotid, then a microcatheter in an aneurysm, and fill up with this aneurysm with the coils, and thing is done. And the aneurysm, which looks like this, disappear completely after fill up with the coils. And aneurysm is cured. So really all aneurysms require the treatment or not. If we compare from the developed world, from India, the most of the aneurysm in the developed world is treated before its rupture, 80%. While in India, we are treating 80% once it is ruptured. Okay, and most of the paper which are coming in last 10 years is for the unruptured aneurysm from the Western worlds. But from India, we are treating once it is ruptured. Once it is ruptured, the prognosis not only depend on the what procedure you are doing, actually how much bleed is there, and so many things. The chances of rupture not only depend on the size, depend on few more things, but directly with the size. If it is more than 8, is around 25%. If it is more than 12, is 83%. So larger the aneurysm, more chances of rupture. So which aneurysm actually need a treatment? So any rupture aneurysm need a treatment. Any posterior circulation, whatever the size, need a treatment. Any size beyond 7 millimeter require the treatment, even it's not ruptured. Even if it is a less than 7 millimeter, but multilobulated. If having the daughter's sake, okay, having the sentinel headaches, or having the polycystic kidney disease, or the family have the history of the SH, they all patient, even the size is less than 7 millimeter, require the treatment. So treatment is the 2 types, clipping and coil. Clippings to open up the skull, place a clip around the neck of aneurysm, thing is done, but it's a surgery, open up the skull, and all the complication can happen with all the skull surgeries. And in the endovascular treatment, you just place a microcatheter inside the aneurysm, fill up with the coils, thing is done. Okay, there are many aneurysms, different location, ACOM, DACA, PCOM, posterior circulation, MC aneurysm, treated with a simple coiling. Okay, the treatment of aneurysm depend on the size of the neck. Okay, if it is a narrow neck, you can just place a catheter and coil it. If the aneurysm is large, then you have to place a something like use a balloon to fill up the coils first, or you may need a stent to cover the neck so you can fill up the coil inside. Like this case, she's the wife of a neurosurgeon. Unfortunately, before it's ruptured, he is diagnosed because he himself is a neurosurgeon. And you can see that there is a wide neck aneurysm. Somehow it's not coming all the slides. So this is the aneurysm. You can see there is a wide neck and multilobatal aneurysm. So what we did, we place a stent. You can see there's a net across the aneurysm neck and fill up with the coils. So that aneurysm, the coils should not come out from the aneurysm and block the parent artery. In the DynaCT, you can see there's the stent across in the parent vessels and the aneurysm filled with the coils. So that is called the stent-assisted coiling. Another patient, the ACOM aneurysm. So again, the wide neck, like here. Again, we have placed the stent from one ACA to the A1 segment and fill up this. So that is called the stent-assisted coiling. Now coming to the flow diverters. So the flow diverter which we are using, particularly for the larger aneurysm, it's difficult to treat even with the surgery. Like in this case, who presented with a 6th nerve palsy. So this is the big aneurysm, difficult to reach there at the cavernous segment. No need, nobody can actually surgically resect that aneurysm. So even you fill up this aneurysm with the coils,
5 minutes
ultimately
remaining.
is going to recur because the size of aneurysm is large, and with the flow is going to push the coils, whatever the coils you are going to place inside. And in this case, because this patient presented with a 6th nerve palsy, here our aim to regress the aneurysm size. Okay, so what we can do for that? So we place a stent across the neck of aneurysm. The function of this stent is it's divert the flow. Before the placement, the blood is going inside the aneurysm and coming out. And this stent actually is a flow diverter. It's divert the flow to going to the aneurysm. It's directly flow to the vessels only. And over the period of time, this aneurysm is going to regress. Like in this case, if you see here, there is a big aneurysm. Okay, we place the stent across the neck of aneurysm. You can see the C-safe stent. And over the period of 6 months, this aneurysm will totally disappear and patient improved completely. Now coming to the intrasec device. So sometime the vessels branches are arising from the aneurysm itself. So you cannot fill up with the coils. Once you fill up these coils, aneurysm branches, the branches is rising from the aneurysm is going to block. Okay, so then either you have to use the stent to preserve these branches, or you can use the intrasec devices. Like in this case, okay, 2 branches are arising near to the aneurysm, and the neck of aneurysm is big. So what we did in this case, we place a intrasec device that is actually a reverse umbrella shape. Okay, so you place this reverse umbrella shape device inside the aneurysm. The side branch which is arising near or from the aneurysm going to be flow continuously. Like in this case, the MC aneurysm, big aneurysm, we place this intrasec device, and over the period of time, the aneurysm gone and the branches are still flowing. So now with the advancement of the science, new materials, and these materials are very delicate, and the machine which we are using, the cath lab, is improved like anything. We can do the CT scan on table when we are doing the procedure. So made our life very easy, and that's why we are able to give the better results. So in the Western world, most of the aneurysm, more than 95% of the aneurysm treated by the endovascular treatment, but in India, still it's clipped. Okay, but this method, if compared with the clipping, is more safer,
2 minutes remaining.
have less chances of complication, and patient is going to stay less in the hospital, going to discharge early. So clipping and coiling is better, have a less intra and post-operative complications. You can do the, treat almost all kind of the aneurysm wherever it is located. And the second, even something is happened, you are able to see what, there is something is happening during the procedure, and you can take the action accordingly. And again, the chances of recurrence is slightly higher than the clipping in endovascular treatment. But again, you can retreat those recurrences. So the for the larger aneurysm, we have the both intrasec as well as the extrasec flow diverter, which can be placed even the size of aneurysm 1 centimeter, 2 centimeter, or 2.5 centimeter. Thank you so much.
Thank you, Dr. Mukesh. Very nice presentation of the aneurysm coiling. And now I invite Dr. Sanjeev Phatak for comprehensive management of diabetic using Blue Index. Dr. Sanjeev Phatak, please.
Good afternoon, and thank you, chairpersons. Thank you, organizers of JIC, for giving me this opportunity. And after excellent talks by the previous speakers, I'm going to talk about the comprehensive management of diabetes, because we know that diabetes, well, I do not have any disclosures for this talk. We know diabetes is a multi-system disorder affecting right from brain to your toes. Every system is affected. I am reminded of one of the famous saying by one of very senior professors of diabetes and endocrinology from Chennai, that diabetes, like malaria, can cause anything. So someone asked him, sir, can it cause pregnancy also? No, it can't cause pregnancy, but it can very well complicate the pregnancy. And how true he was at that time. So I'm talking about 20-25 years back. So we now know that diabetes is responsible for many of the complications, and because of which the hospitals remain full. There have been several guidelines to treat diabetes, right from year 2000 and now 2026. The Endocrine Society guidelines, the ADA guidelines, the AHA guidelines even, the IDF guidelines, our own RSSDI guidelines. But none of these guidelines, though they are including diabetes comprehensively to be treated, but they do not specify how we all can remember this so that it can be incorporated in our day-to-day practice. Similarly, for risk assessment also, we know that most of the diabetes patients, they die due to cardiovascular disease. So for cardiovascular risk assessment, there are several risk indicators, but none of these are patient-centric. So what we did about 8-9 years back, some of us, including myself, Dr. Panchi, and some other endocrinologists and diabetologists across the country, we developed an index which is patient-centric. And I'm going to discuss about that in the next 10 minutes or so. We termed it as Blue Index because blue color is inspired by the IDF logo, which gives the diabetes the color of blue. So what actually the Blue Index is? Well, the Blue Index consists of two parts. This is basically for the comprehensive management of diabetes. One is the diabetic health score. The second is complication K, that is complication score. Why it is important? Because it is patient-centric. It improves the patient education, it improves the patient motivation and patient's engagement into their own management. It is a strong tool for holistic evaluation of the disease status, and it comprehensively covers not only glucose control, but vascular, metabolic, and renal health. We know now this diabetes being a cardio-renal metabolic disease. And it also takes care of the general health of the patient. It is respectful of the WHO definition of health, which means not only absence of disease, but if you have a disease, you should be happy with the disease, managing the disease very well. It has 10 parameters, starting alphabetically with A, of course, the A1C or the glucose control. B is the blood pressure control. These are not in the order of importance, these are in the order of alphabetical.
C is the cholesterol or the lipid control. D is the dietary modification. E is exercise importance. F is follow-up. G is for general health, because for diabetes patient, not only glucose, not only blood pressure or lipids, their overall health also plays very important role in improving the quality of life. H is habit avoidance. I is infection prevention. In J is jeopardy. We'll talk about it a little later. If you improve all this, if you include all this in your day-to-day management, you can definitely reduce the complication rate. Starting from A, I'm not going to have a deep dive into that because all of you know the glucose control is very important in type 2 diabetes patients. We need to assess the A1C every 3 to 6 months, fasting and postprandial very periodically, and now the days have come when we rely more on the time in range from CGMS rather than just the HbA1c or the self-monitored blood glucose. The blood pressure control, systolic, diastolic, the heart rate, preventing the postural hypotension, measuring the blood pressure in both the limbs, also assumes great importance in diabetes patients compared to the other patients. We know that one of the most important modifiable risk factors in diabetes patients is the lipid modification. How many of you will agree that lipid modification is more important than blood pressure or A1C control? So I think most of us believe that lipid control probably plays even major role in reducing the cardiovascular complications compared to even glucose control. And in the lipid, we have 3 parameters that need to be controlled in the Indian population. Of course, the LDL, non-HDL, and to some extent triglyceride, though the triglyceride lowering and its cardiovascular risk reduction is debatable, but still practiced in our country. Of course, ApoB and role of lipoprotein small a are coming up, and we have several discussions around this in this conference. So I'm not going to discuss about ABC, all of you know that. I'll have a little deeper dive in the diet, exercise, follow-up, and general health. In diet, we all talk about reduction of the carbohydrate. But in our diet, increment of the protein plays even major role compared to reduction in the carbohydrate. Of course, we need to reduce the carbohydrate, but we need to include protein in every meal. 20 to 30 gram protein in every meal not only improves the glycemic control, also has positive influence on muscle health and overall quality of life. So the composition, meal pattern, as well as the overall calorie plays important role as far as the dietary modification is concerned. When we talk about exercise, સાહેબ રોજ ચાલવા જઉં છું. Dr. Anish will strongly disagree that ફક્ત ચાલવા જવાથી કોઈ ફાયદો થતો નથી. You need aerobic as well as some weight resistance exercises, because the resistance training will not only improve the insulin resistance, will also improve your cardiovascular health. And that is why this is one of the most important exercise which all of us should advise as people will live longer with less muscle mass. Similarly, work-related activity also plays very important role as far as your overall health is concerned. Yes. And then comes the importance of follow-up. Nowhere in the world there are papers on follow-up, and that's why we took little more time in seeing whether regular follow-up can improve the diabetes control. And what we found out in our study that yes, regular follow-up not only improves the glycemic control, it also improves the blood pressure control, it also improves the lipid control, it also has, we also get an opportunity to look at patients' medication adherence, the socio-economic status, everything, and that would obviously translate into reduction in the complications. G is for general health, and in diabetes patients, this is even more important. Anemia may be due to several reasons, and it is not uncommon to have anemia in diabetes patients. Maybe due to aspirin therapy the patient may be taking, maybe due to chronic kidney disease, or sometimes due to vitamin B12 or iron deficiency. Bone and muscle health, as the people age, are going to become very, very important. You don't need tools like BCA every time. Simple muscle grip and the chair test may suffice to know whether the patient has enough muscle strength or not. Cancer screening when appropriate, because as the people live longer, more and more diabetes patients are going to develop some of the cancers which are diabetes as well as obesity related. So you need to have an eye on that. Diabetes distress and sleep deprivation is again becoming more and more common. Some endocrine diseases are also common in diabetes patients, especially hypo and hyperthyroidism and cortisol excess. That is also one of the important markers for patient not getting good glycemic control. And finally, but most importantly, the fatty liver disease, which is present in more than 50% of the people with type 2 diabetes. And simple FIB4 scoring using SGPT, SGOT, and platelets is absolutely mandatory in every diabetes patients. Habit avoidance, all of you know, is very, very important, more so in diabetes patients because diabetes patients are at more risk of cardiovascular as well as the peripheral arterial disease. Infection prevention. Never before COVID came, we realized that infections in diabetes patients can be much more complicated and fatal. And that is why infection prevention may be dental infection, genitourinary infection in the era of the SGLT2, or respiratory infection prevention by simple hygienes as well as vaccinations like flu and pneumococcal play an important role in overall management, improving the quality and improving the survival and reducing the hospitalization rate in type 2 diabetes patients. Finally, the jeopardy, that is the side effect of the drugs. Very rarely we explain the side effect of the drugs to the patients. We know that we are living in an era where SGLT2, GLP, all these drugs, which are having very good effects on the cardiovascular health, but are associated with some of the side effects which can be minimized or identified early if you have counseled the patient regarding the side effect of these drugs. Of course, this being said, this is all done to prevent the cardio-cerebral complications, to prevent the renal and retinal complications, and very importantly, to prevent the foot-related complications, which are again very common in diabetes patients. I'll discuss this in the next presentation, which is on Sunday. Our experience on our Blue Index, we have enrolled more than 3,000 patients by now. 1,750 patients, we have now complete data available. We have also done publications in some of the national as well as international journals. And we have seen a remarkable improvement in the scores in the patients who are following this. Compared to those patients who are not following this, you can see that the score from 34 baseline improved to 40 in the intakes following patients, compared to 35 to 36 in the patients who are not following this. So relative improvement of almost 15% in this. To sum up, we know diabetes is a multi-system disease. Comprehensive workup and management is the key, but we need some assessment tool like Blue Index so that it is very easy to remember and very easy to practice in our day-to-day outdoor busy OPDs. We need to change from our glucose-centric approach to the caramelic approach, which is cardio, renal, metabolic, liver, and infection prevention-centric approach. With this, I'll stop here. Thank you very much for your very kind audience.
Thank you, Dr. Sanjeev Bhai. Why don't you join us there on the dais itself? Your blue score has included, I think, the entire book of diabetes. So, so I think we've got good 10 minutes for discussion. I'll invite Dr. Mayur Bhai, Dr. Ashok Bhai, Dr. Bhavesh, Dr. Kishore Bhai. Any questions? Let me, I think Dr. Mukesh Sharma is left. He's gone there. So let me start with Dr. Nikunj if he's around. I'll start off with a question. Is he around? जिसको क्वेश्चन पूछना था सब भाग गए. Madam, your talk was excellent and very relevant. And this is what I've been generally telling. I just told Dr. Kishore Bhai. Those senior physicians who are planning to slow down, getting into geriatrics is going to be the next big thing. The Indian population, everyone is getting older. They continue to live long, they want to live longer, and the expectations are very high. So, and everybody has 1 or 2 children, most of them are not here. So they need to be taken care of in more ways than one. So those who are thinking of slowing down, geriatrics is the way to go. I've been telling for the last few years. Madam, any other points you would like to say? Microphone.
Hello.
Yeah, it's working. Just
working?
keep it
Okay,
closer.
yeah, okay. So I am a geriatrician. Since 20 years, I am taking a health camp there. It was my passion to take my undergrad PGs to health camp. So my interest is in vaccination, adult vaccination, and organ donation. So whatever the disease, kidney disease, liver disease, malignancy, diabetes, hypertension, your bronchial asthma, they need vaccination. So it is a good chapter in PSM, and it is included in Harrison also. So when I came, this is my fourth time I am visiting Ahmedabad. But what I mean to say, you start the geriatric subject practice. There is a course in our. I'm a member of the Geriatric Society of India, New Delhi, and I am West Zone in charge. So we are planning the certificate course for postgraduate. They can join it. So it is the awareness. You have to awareness of the geriatric subjects. So geriatric population is increasing, and we don't have the geriatrician. So the presentation is totally different. Pneumonia patient will come to you with disorientation because of hyponatremia. So there are so many atypical presentation of the geriatrics. And one thing, geriatric, there is no geriatric.
DM geriatrics.
No, DM geriatrics. So,
really?
Yes,
okay, I didn't know that.
So very few seats are all over the India, but we are active in Delhi, in Calcutta, in Kerala, and in Karnataka, in Maharashtra also. We have. So my interest was there. Something should be happen to in Gujarat, Ahmedabad. So sir, Urmil sir and Manisha ma'am came to Pune, and we are planning for that. So you will get more and more knowledge. You all are invited for the geriatric conference.
Thank you. Yeah, there's a question from the floor. Yes.
There is additional remark also. I'm also a physician. I'm also running old age home. So need of the hour is old age home. हम तो pulse बीपी में आपके छोड़ देते हैं. ये करो वो करो. There is nobody to do it.
Yeah.
There is smaller family units and everything, and you require to have a lot of interactions with them. So this is need of hour. We can call it as a geriatric home. We can change the name so that more and more people can come and involve, and they don't feel bad about staying there. So we must stress this part also as part of our practice, medical practice.
Sure, absolutely. Dr. Anish bhai, your lecture was excellent, but it has opened up a lot of ambiguity. Okay, what did you do for that patient, and what would you otherwise advise for a given patient? You left the door open for anything and everything that could be done.
So good. So when such a critically ill patient who is hypotensive, septic, in shock, needs vasopressors, maybe on the verge of intubation. So when they develop elevation of troponin and there is no ST elevation, things are
5
easier.
minutes remaining.
If he gets ST elevation, that's where even in such situation, primary PCI is better than thrombolytic therapy. So when patient gets ST elevation, however sick he or she is, the best chance comes through primary PCI. Obviously, in that case, it will not be as rewarding as it is in other case. So when there is no ST elevation, STT changes, mild depression, that's little easy. Now it's very difficult to differentiate between type 1 and type 2 MI, especially when it is ST depression. But generally, when patient has got multiple features which can suggest demand-supply mismatch, tachycardia, bradycardia, hypotension, shock, kidney injury, etc. That's where I tend to diagnose, especially in patient who has been asymptomatic and not having ischemic heart disease so far. So this gentleman who's 72 had never ischemic heart disease, never any such kind of symptoms of angina or breathlessness. So I believed that he would have those silent 30, 40, 50, 60% atherosclerotic block inside, and now because the heart demands more oxygen, which is not supplied, myocytes are dying, and that is what is called as type 2 myocardial infarction. So in this patient, since platelet count were close to 1 lakh, HB was 7.5, I treated only with one antiplatelet, statin. His SGPT was 72, so I gave atorvastatin 40 plus 10 ezetimibe. I give also bempedoic acid, clopidogrel, and low dose of fondaparinux, that was 2.5. Kept working on oxygenations, controlling heart rate by ivabradine, maintaining proper blood pressure with the help of noradrenaline, etc. So it's all keep maintaining metabolism and select whatever you can out of all cardiac drugs which are not very hurting in a given situation.
So, in my opinion, if I may say so, when such clinical situations arise, I think it is your wealth of clinical experience and maybe talking to a couple of your colleagues, which will help in getting the right path towards what should be done for an individual patient.
So absolutely, yes. So my purpose was to let you know that two things. Number one, see, there are many patients who have got cardiomyopathies, chronic coronary syndrome. See, they have got multivessel disease on medical management. Maybe they have multivessel disease and 1 or 2 stents have been there, but they have chronic coronary syndrome, chronic rheumatic heart disease with bad valves. So they all would have some elevation of troponin. Please do not consider that they are acute coronary syndrome. So many physicians call me from periphery that, doctor, we have a patient, has come for severe rheumatic heart disease, resident sent troponin, and it is 1.5 times elevated. Is it acute MI? And many cardiologists in those centers are starting acute MI treatment. So it's very important to understand there is something called as chronic myocardial injury because of variety of cardiac and non-cardiac situations. So if there are injuries, there will not be acute deviation of troponin. Troponin will be high, but it will be maintained at that level little bit 5 or 10% up and down. To say that it is acute injury,
2 minutes
you have to
remaining.
have 20% going up troponin, then only you can say that. So in your practice, you'll get many patients with subtle elevation of troponin. Don't jump to diagnosis of SES, number one. And second, if you want to prove acute ischemia, you have to have 2 or 3 troponins serially going up or going down by more than 20%. And then when you have troponin such values, you have to come to whether it is acute myocardial injury because of overall situation, or is it really coronary insufficiency. It's a very, very tough area. It's difficult for me also talking to all my colleagues, my intensivists, but then we make our way through in a given situation.
So question from the floor, and then I'll invite Dr. Mayur Bhai, Dr. Kishore Bhai to ask questions to Dr. Sanjeev Bhai regarding the blue index.
Anish Bhai, my question. Suppose this patient, hypothetically, platelet is 50 to 70,000, classical ST elevation in this patient, then how will you manage, sir?
A good point. Again, see, all said and done, first talk to the patient and relatives that prognosis is very bad. If they want the best prognosis, still acute MI primary PCI is the way. Because with this HB and this platelet, if you thrombolize the patient, bleeding risk is very, very high in this scenario. While when you take patient for primary PCI, you don't give thrombolytic therapy. You have to use heparin and antiplatelets. They are anyway less risky. So yes, give single antiplatelet, which may be ticagrelor, no aspirin, statin. If it is escalation, I might take the patient on table.
Dr. Mayur Bhai, Dr. Jitin.
Sanjeev Bhai, as with the new oral anti-diabetic drugs, we are seeing that midnight hypoglycemia is occurring less commonly, phenomenon is also occurring less commonly. What are your views?
Yes, and the question is whether the new agents are associated with less hypoglycemia risk, right? Yes, overall hypoglycemia risk is much lower with the newer agents like GLP, DPP4, SGLT2 inhibitors, or even pioglitazone. Compared to sulfonylureas and insulin, not only nocturnal, but the daytime hypoglycemia is much, much lower, and the severe hypoglycemia is practically unknown with these agents, unless there is an SU or insulin on board.
Sanjay Bhai, you're sitting next to me in the consulting on the 14th floor nowadays. Yes. I have never heard about this blue index. So are there any numbers or something you assign to it and you're calculating a score and deciding high risk, low risk, anything like that?
Yes, absolutely. So we have been doing that, not regularly in all the patients, but whenever there is, whenever time permits or whenever the patient is a little bit aware, we discuss all these aspects with the patient. We grade them. We enter in our special software we have for the blue index, and then assess how the things are going in the follow-up.
I think you
Most
need,
of the times
you need to create an app for it.
Yes, we do have.
Oh, great.
We do have.
Coming to maybe last point, Sanjeev Bhai, in really how many percentage of patients you see, there is a compelling indication to stop SGLT2 inhibitors because of the genitourinary and local infection issues?
Well, it's a great question, great practical question. In our clinical practice, and we are also publishing one of the study we already published, The other study, which is Genius, which is into an international publication now. So some of the things I can discuss about that. The overall prevalence is about 6 to 10%, depending upon the population and depending upon the gender. In females, the genital infections are more common, but most of the females tolerate it well and they are ready to accept it even if it is recurrent. Compared to that, in males, the genital infections, they tolerate it less commonly, and we have to stop time and again. So roughly in 5 to 10% of the people who are given SGLT2, we have to stop it. We can restart it if there is no other contraindication, but still in 5% we cannot continue in spite of the strong indication for heart failure. Yes.
Thank you.
Okay, any other question? Otherwise, we'll wind up.
The actual urinary tract infection, Anish, if you ask, is comparable to what you see with the other drugs also.
Sir, I am having a question. I am working in medical college. We are having a huge number of pyelonephritis patients, especially case of diabetes with patient is on SGLT2 inhibitors. Once or twice we have tried second time, but immediately after a few days only, the patient similarly came with the acute pyelonephritis or pyelonephrosis. So whenever there is a pyelonephrosis or pyelonephritis, even without seeing the urine routine microscopic pus cell, on sonography they are having pyelonephritis. So what is your views on this?
So I fully agree with you, sir. And having a history of pyelonephritis becomes a relative contraindication for the usage of SGLT2. Because you would not like to risk, because it can lead to urosepsis and even death, we have seen. So it is not just with SGLT2, it is as a population also, diabetic people, especially females, are more susceptible to pyelonephritis. SGLT2, whether it increases the risk or not, the clinical trials have not shown that it increases the risk. The risk is comparable to the placebo. But yes, in practice, we avoid SGLT2 if the patient has pyelonephritis.
Almost 80 or 90% of patients, they were female. That is definite. Even they are gone up to creatinine level up to 5 with a single episode of pyelonephritis. Then it comes down to 2 or 2.5, then it's stabilized. But second attack and third, it is a huge number of patients they are readmitting. And most of the time, the bacteria are resistant to almost most of the routine antibiotic except the teicoplanin or the tigecycline or like that. Thank you so much.
In euglycemic ketoacidosis because of SGLT2 inhibitor, we have heard Western data. What is your experience about it in India?
Well, euglycemic ketosis can happen, especially if the SGLT2 inhibitors are continued in presence of severe sepsis or if the patient is hospitalized for some other reason. Otherwise, in the routine outdoor practice, euglycemic ketosis is not as common as it is previously, as it was previously believed. Having said that, in a patient who needs hospitalization, you need to stop SGLT2. In a patient who is dehydrated or is having acute sepsis, you need to stop SGLT2.
Thank you so much. And now we'll finish this session. Thank you so much, chairperson, moderator, and panelist for this session. And now we'll move on to the next session. And for chairing the session, I'll invite Dr. Arvind Minj, Dr. Jian Badlani, Dr. Jayesh Pavra, Dr. Kamlesh Patania, Dr. Piyush Shastri, Dr. Tejas Padodra, Dr. Akriti Agrawal. Please join on the rest. And to moderate this session, I will invite Dr. Himanshu Mehta, Dr. Jagdish Chaudhary, Dr. A.L.R. Agarwal, Dr. Pankaj Bhatt, Dr. Rai Shamet Patel, and as a panelist, Dr. Dhiren Shah and Dr. Paras Doshi. I welcome you all on the dais. So, the first topic would be newer anti-obesity medicines, what physicians should know, by Dr. Rikin Shah. Dr. Rikin Shah, please. Yeah, thank
Yes, very good afternoon. It's last session before your tea. This is the hottest topic of last year, anti-obesity medicines. Most of the people have heard, many have used on patients and many have used on their self also. So we'll discuss in three parts. I don't have any financial interest in this topic. So obesity is a global health priority now because around 880 million adults suffering from obesity worldwide, 86 million adolescents and 71 million children. Total compounding to around 1 billion people suffering from obesity worldwide out of the 8 billion population of our current world. So it's a, by definition, abnormal and excessive body fat accumulation that impairs health and increases risk of multiple health complications. We know more than 230 complications are there which can arise from the obesity, from type 2 DM, hypertension, coronary heart disease to multiple cancers to n number of other complications. So this is the world obesity map, more darker areas suggesting of more prevalence of obesity, that is particular in developed countries, in USA, Europe, but now developing countries are also, there is a steeply increased rates of obesity, that is in lighter green or darker green color. So now we see the picture of India, around 254 million adults suffering from the obesity and 351 million suffering from central obesity that we called belly fat. So India, it is also steeply rising, and around 25% global burden of obesity is currently in India. This is the next 10-year future projections. So obesity rate is going to rise by 100% by 10 years from 1 billion people to 2 billion people. And all over 1 out of 4 people in world would have suffering from obesity. So that's why we need a solution for this. Let's start with one question. How many of you have used anti-obesity medicine or any medicine that can cause weight loss before 10 or 15 years? Metformin is not an anti-obesity medicine, it is weight neutral now. So it's not counted. So B, no. I think only 15% people have used anti-obesity medicines. I was not also using before 10 years. This will change after some time. When we discuss about the newer anti-obesity medicines, which are the older anti-obesity medicines? These are the older one, phentermine, orlistat, phentermine topiramate, naltrexone, bupropion that we were using just before 5 to 10 years. But there was a single problem. All weight loss they causing was a single digit, 5%, 3%, 8%, 9%. None of the molecule can increase weight reduction to or 10 or more than 10%. And all have a different side effects. Mostly there is a increased CV risk and they are not approved for long-term use. So there is a bigger pharmacological gap. In diet, lifestyle, all the older medicines only causing weight reduction from 3%, 5%, 8% to 9%. Second option was bariatric surgery causing 25 to 35% weight reduction. So what to do for in-between patients? So there is a GLP-1 evolution. It is more than 100 years research. So now we are standing here with these wonderful molecules. From 1902, William and Ernest started first gut hormone that has endocrinological benefits. From 1964, incretin effect was first coined. 1980, first it was termed as GLP-1 and GLP-2 analogs. And 2005 is the first big divide year in our history when first GLP-1 molecule was US FDA approved. That was exenatide, but still it was a weaker anti-obesity molecule. Then there is a sequential approval of GLP-1 molecules, 2010 liraglutide, 14 dulaglutide, 2017 is the launch of semaglutide, that is the first game changer in obesity medicine. Then 2019 oral semaglutide, 22 tirzepatide and 23 tirzepatide for obesity approval. So lots of scientists, science and different pharma company has invested billions of rupees and years to invest to research these molecules. So now this pharmacological gap is filled with newer anti-obesity medicines which can cause weight reduction from 15, 20, even more than 20%, almost reaching up to the bariatric surgery mark. Now they are also in guideline. This year, first time has their GLP-1 RA are the hero of the guideline because they are the first one should be prescribed to decrease the risk of heart, decrease the risk of kidney in all ASCVD risk reduction. It has replaced now metformin in a guideline. You can use GLP-1 RA as a first drug to your patient in whom you want diabetes control, in whom you want weight reduction, in whom you want to decrease risk of heart and kidney. So GLP-1 RA works by different mechanisms, starting from the decreasing gut motility to increase glucose uptake by muscles, decrease gastric emptying, adipose tissue, increase lipolysis, increase insulin secretions, increase diuresis, cardioprotection, neuroprotection, and also decreases fatty liver, and it is now approved for that. So now question 2, let's come to the newer medicines. How many of you have used semaglutide or tirzepatide in your clinical practice? Either on yourself or on your patients, please vote. Oh, that's wonderful, the 60%. So from 15% using anti-obesity medicine to reaching to the 65% mark. So that is the biggest increase in using these molecules. That's why, because these molecules are now wonderful and they are highly efficacious in weight loss. So now let's clear the confusion of GLP and RA, because many doctors are not even frequently using, so they are confusing between Ozempic, Wegovy, which are different band, which are different molecules. So this is a complete all list of available GLP-1 analogs. Exenatide, as we discussed, approved in 2005, weight reduction around 3%, liraglutide, weight reduction around 4 to 6%, dulaglutide, weight reduction around 3%, and semaglutide around 10 to 15% weight reduction. That is a game changer molecule. There is a different form of semaglutide starting from the Ozempic, approved for type 2 DM. Ribelsus, that is oral semaglutide, approved for type 2 DM. Wegovy, approved in 2021, first molecule for approval for obesity. Poviztra is a co-branding launched last year. It's the same injectable semaglutide once a week, approved for both type 2 DM and obesity. Then last comes oral Wegovy, that is a oral semaglutide 25 mg, approved just last month by US FDA. It will be available in market in next 1 to 3 months. So all causing injectable and now newer oral semaglutide causing weight reduction from 15 to 16%. Now we want more, just GLP-1 is not enough. So now there is a GLP and GIP, both combination is there. GIP is a different hormone. It's also a gut hormone, works many in the same way, but it increases glucagon and somatostatin secretion. It increases adipose tissue blood flow and increases lipolysis, and also it decreases bone resorption. So these are the added benefits of GIP on top of the GLP-1 analog. So when we combine this dual analog GLP and GIP, that 20% mark is now broken. This molecule can cause weight reduction up to 22.5%. That is almost reaching the mark of bariatric surgery, that is 25%. With 5 mg, around 16% weight reduction. With tirzepatide 10 mg, around 21%. And tirzepatide 15 mg, around 22.5% weight reduction. Many patients are losing even more than 30% in selected patients. This is a complete network of available and future GLP-1 analog, because all the anti-obesity molecule currently here, or many are in phase 3 trial, many are just going to approve, all will be on based of either GLP-1 only. So tirzepatide is already approved, semaglutide is already there. Future important molecules is retatrutide, bottom down. It is a GLP, GIP and glucagon. It is a triple analog, and it is causing, it is just reaching the mark of the bariatric surgery weight reduction. Other important molecule, orforglipron, this is the oral semaglutide. It is just approved. Another important molecule is cagrisema. That is also going to be approved in next year. I will discuss some practical tips of this using these molecules. As we discussed, these molecules are really wonderful, really efficacious. In last 10 years, we have seen use these molecules. But these are limited common side effects like GI side effects, nausea, vomiting, diarrhea, constipation. These all side effects are generally mild to moderate and they are going to resolve with time and with symptomatic medicines only. Hypoglycemia, as just last topic it was discussed, in type 2 DM when you are using sulfonylurea or insulin, you have to reduce the dose of the concomitant medicines to reduce the risk of hypoglycemia. Hair loss we see in a few patients, but it is also a transient and going to resolve with time. There is a few precautions you should use while prescribing these medicines. For renal and liver impairment, mild and moderate impairment, there is no issue. But precaution and experience is limited in severe renal impairment, particularly in stage 4 and stage 5 CKD when eGFR is less than 30. In severe hepatic impairment when Child-Pugh score is C. Pediatric population, it is not approved in less than 10 and 12 years of age. Few molecules are approved for more than 10 and more than 12 years of age. Elderly, more than 85 years, you should use this molecule precautiously. Acute pancreatitis, if develops, you should stop this semaglutide or tirzepatide. Gallstones may require surgery in future with or without this medicine. Diabetic retinopathy, you need to closely monitor these patients for this. There is a 3 contraindication for these molecules. First and foremost is thyroid tumors. Any personal or family history of thyroid C tumors or multiple endocrine neoplasia, you should not use these medications. It is absolute contraindication for these medicines. Pregnancy and breastfeeding women, you should not use this GLP-1 RA. So this is the almost summary of these benefits of these molecules. Apart from the diabetes control and weight reduction, these molecules have multiple other benefits like reduction in the CV risk, they are approved for that, reduction in cholesterol, improvement in beta cell function. Many patients are reaching up to the mark of diabetes remission, blood pressure reduction, visceral fat reduction, benefits in OSA, fatty liver, ONE, and also decreased inflammatory markers. So now this is the last question. How many of you are using or wants to use these drugs now after seeing all these benefits? Just what? So almost 90% mark, that is wonderful. As doctors must be aware of these potential benefits of these molecules, and that is done. So from 15% to 65% to 90%. So these molecules are really wonderful. We are usually using this molecule in a huge amount of these patients, and they are just like magic molecules, because this last 10 to 15 years has been the divide year in obesity practice. Before 10 to 15 years we don't have any molecule, and now we have all the molecules. And picture तो अभी बाकी है, क्योंकि बहुत सारे molecules तो अभी आने वाले हैं. And this is my last summary. Can you repeat the slides? नहीं आएगा? Okay, sure. Okay, thank you.
I would invite Dr. Urmil Shah for his next topic.
How and why clinicians should get involved in the clinical trial, research trial. I think this is very important topic.
Good afternoon.
So I think Urmil we will highlight why research is important.
Good afternoon, everyone. જીરિયાટ્રિકનો લેક્ચર સાંભળ્યા પછી લાગ્યું કે જીરિયાટ્રિકનો બહુ મોટો સ્કોપ છે, ઓબેસિટીનું પછી સાંભળીને લાગ્યું ઓબેસિટીનો બહુ મોટો સ્કોપ છે. હવે રિસર્ચ બી એક એવું જ ફિલ્ડ છે જે દરેક ફિઝિશિયને કદાચ થોડું બાય એન્ડ લાર્જ પોતાની લાઈફમાં એડોપ્ટ કરવું જોઈએ. ઇટ ઇઝ ડેફિનેટલી ગોઈંગ ટુ બી બેનિફિશિયલ ટુ ઓલ ઓફ અસ. ફર્સ્ટ ઓફ ઓલ લેટ મી આસ્ક હાઉ મેની ઓફ યુ આર directly or indirectly involved in the clinical trial till now? So there are few people who are involved, but I really wish that after listening to lecture, you all will agree that more and more physicians should be involved in the clinical trials. I do not have any financial disclosure. Why one should, physician or a medical person should be involved in a clinical trial? We all know the history of medical war crimes, okay? This is what has happened in the past. This is one of the example. 1937, 71 people died, 34 children died because of some molecule that was sulfonamide, and which has got all sorts of problems. Similarly, during the World War II Nazi experiments, we all are aware, mustard gas experience, poison experience, high altitude. These are the done where people have done the trials, have not thinking about the patients. That is what has happened. Similarly, this is a very interesting thing which has happened. Syphilis, medicine was invented as a treatment of syphilis in 1947, but this trial was continued, okay, for about 30, 40 years, just to say the natural history of syphilis, okay. So though the treatment was available, that time treatment was not started in this patient, just to say that how the syphilis people without any treatment are having some sort of a complication. This is all we know, Canadian tragedy, where a simple cold, insomnia or cough molecule has caused congenital abnormalities, and so many people have died. I don't know, but we all should know this guy. He's James Lind. 1747, he basically started a clinical trial, and that is how we call him as a father of clinical trial, because he just divide the patient into control subjects and the person with active treatment, okay, and that is what we are doing in the present trial. So definitely, what he did in the patient who is having scurvy, they give citrus fruits to this patient, and just to observe that how much benefit is there. And that is basically have proved, and this is how the newer trials where control subject versus active treatment concept are started. And that is the reason in 20th May we celebrate that day as a clinical trial day. When we are involved in the trial, there are three, four things which are very important, like CRO, then IRB or ethical committee, investigator, and a sponsor. These are the four things which are important. Investigator is basically the person who carries the trial at that particular center. There may be a principal investigator, there may be a co-investigator. That is what we normally have. There is an ethical committee or an institutional board review committee that basically takes care how the trials are going on. Is it in a right way, looking into the inclusion criteria, how the patients are being followed up. There is no harm to the patient. That is what is the basically job of IRB. A sponsor is it can be an individual person or a company or institution, and basically what it does, it initiates and manage, and financial party takes care of the basically the financial part of the whole trial. And CRO is basically the people who are sort of a pharmacy people or a paramedical people who takes care of maintaining whole the data so that the trials results we can be achieved in a very nice way. This is what we should be aware. JCP guideline has basically made to make the trials which is ethical, which is good and not harming the patient, and ultimately we can give an advantage to the patient. That is the reason why the JCP guideline has been made. Some of the important principle of ICH JCP guideline is similar to the Declaration of Helsinki, where persons should not getting harm, okay, if they are subjected for the trials. Risk and inconvenience should be weighted against the anticipated benefit. Rights and safety and well-being of trial subjects are very important, and that should be taken part, or that should be the priority. We should have all clinical and non-clinical information before starting the trial, okay, because there are so many things before starting the trial we should be aware, and we should implement when we are designing a trial. And it should look scientifically sound and should have a clear and detailed protocol. IRB is very important. This ethics committee approval is basically must before starting any trial. Education, training, and experience is very important for any trial. Like some of the trials have specific tests to be done, so the staff should be aware that how this test is to be done. We should give a free hand to the subject or a person or a patient to give informed consent. That is basically very important. All the documentation should be recorded, handled, and stored in a very nice way, so that we can get some good data of that. Confidentiality of the report also is very important. And investigational products, it may be injection or it may be tablets, should be manufactured, handled, and stored in a proper way. Okay, so it should not cause any harm to the patient. Good clinical practice is basically designed to have a good standard trial with the good design, conduct, performance, monitoring, auditing, recording, analysis, and reporting. This is basically the GCP principle, and we all should be aware. Our purpose is to have a good data which is recorded in a very creditable and accurate manner, and right integrity and confidentiality of the patient or the trial subject is always preserved or protected. When a trial is involved, everyone will look in a different way, okay? It may be a media person, it may be a coordinator, it may be a IRB or a FDA. They all will think, but as a physician, our key role is to have a well-being of the patient. It is basically our job, and that basically needs to be maintained when we start a clinical trial. Why we should be involved? Because physicians are important. It's a central role. It basically carries a bridge between patient care and scientific innovations. Basically, we are also involved in ethical, clinical, and scientific integrity. Our medical knowledge is always there, which is important for any design of the study. We have to identify suitable candidate or a suitable patients, okay? That is a medical person's job. We have to interpret the outcome carefully, okay? Because that is the ultimate purpose of doing basically that study. The risk assessment benefit or ratio also should be kept in mind when we are involving the patient. Whether to continue in the trial or withdraw in the trial is the decision of a clinician, okay? And that as a medical person, we can take the decision very nicely. And if the patient develops any medical emergency, we have to take care of that patient. This is basically an era of evidence-based medicine. Whatever Rikin has told, obesity medicine, patients have undergone the trial, and that is the reason why they are coming in the market. So someone has done the research, so the next generation or the next people are getting benefit out of it. We as a physician should be involved in the trial so that new and new molecules are coming in the market, and that can ultimately benefit our patients. It will make us ourselves differentiating from other branch of medicine, okay? Because they basically don't have trial. That is what we are doing in a very, very scientific way. PCSK9 inhibitor in a primary prevention. Tomorrow I'm going to present this data. Anti-obesity medicine. PPH management is primary pulmonary hypertension is a very malignant course, okay? LPA, there was no treatment available till now. But nowadays, after getting the trials, we have some molecules which are basically very useful. India, believe me, is going to be a hub of trial. Nowadays, we have good data collection system, and we can maintain the data very nicely. Financial gain also is there. If you are enrolled in the clinical, you may get a trial fee also. It will come in the publication. It will make your CV definitely better. You may get more referred patient, okay, once you're in the trial, because everyone knows that he is interested in obesity trial. He is interested in primary pulmonary hypertension trial. Knowledge about the disease also is going to increase. And detailed diagnosis and management also many times change, because when we enroll the patient in the study, we have to investigate the patient much thoroughly. And many times the diagnosis may differ, and it will ultimately benefit the patient. Safety of the patient needs to be always taken into account. Informed consent is very must. We have to monitor the adverse effect very properly. Patient rights and well-being is our job to protect. We have to follow the protocol very strictly. We have to train the study team, okay, that is very important, and we have to comply with the GCP guideline. We also have to have a liaison with the ethics committee. Sometimes you may get a DCGI audit or you may get a FDA audit, so you have to have all the data very much ready. We have to get regulatory approval also. We have to maintain the essential documents and ensure the clinical assessment very nicely. All data should be verified by the clinician. CRC sponsored it a big time, okay? The person who is enrolled in the trial, we have to give some time, extra time to all this thing, and definitely it will ultimately improve the safety and efficiency of quality of the trial. How to comply with the protocol is most important thing. Whenever you are involved in the study, make sure that protocol, whatever the inclusion criteria is there, they are fulfilled, okay? There is nothing like you should deviate yourself from the protocol. If you want to deviate, it should be with the IRB or the ethics committee permission, otherwise we should not be doing. When you are taking the consent, we have to give a very informed consent to most of the patient, and definitely adequate opportunity and time should be given when the patients are giving consent. And we have to explain them in their own language, okay? It should not just come just like that. Verbally, we have to tell the patient, if the patient is not educated, you have to have an independent person who is educated, and we have to do in that patient. This is how we normally do. Some of the important things about trial is very important. Patient recruitment, retention is probably the most important thing, okay? That is the big problem nowadays, because if some new drug has to come in the market, they will say that we have to have data, otherwise DCGI will not give the permission. So you have to be basically involved in the trial. It is an extremely time-consuming and very expensive thing. Recruitment of abnormal subject, keeping timeline in the mind is very, very important. And basically, ultimately, why the patient should be involved in the clinical trial. Some of the patients are willing. Oh, I'm definitely going to help. That is one. Second thing is, some of the therapy, there is no therapy available, like primary pulmonary hypertension, LPA, there is no medicine available for that. It will definitely improve the patient medical care because patients are being frequently followed up. Some of the patients do because of some financial problem or maybe because of some health insurance. We should have a data ready at the before starting of the trial. We can take the database. It could be, we can involve the patient by call center or standees in the hospital. That these are the trial which is going on. Definitely we can take the more and more patients included in the trial. Recruitment strategy should be carried very easy, very fast, because inclusion criteria are very fixed. Okay, many times we think that there are so many patients of PPH, but when it comes to the inclusion criteria, they are basically very less. Patient recruitment is definitely very important. At the same time, dropout also should not be there. Okay, so once patients are involved, if the patient is being followed up for 2 years, and if you are having some follow-up loss, it is basically the purpose of the study is not going to be served. So when you include the patient, you have to make sure that this patient ultimately goes to the whole of the study. And there are so many ways to involve the patient or to continuously for the study so that they are basically continued. We have to continuously motivate the patient that whatever you are doing is good. It is definitely going to help the other subject, and definitely we should be helpful. Personal attention definitely helps. Staff, hospital staff also is very important in all this thing. So lastly, I would just like to conclude, physicians are indispensable in the research study. Their role, safety, ethics committee, and scientific rigor is very important. And strong physician involvement definitely make the trial more result-oriented. Thank you very much.
Thank you, Gurmal Bhai. Now we'll invite Dr. Harshil Mehta, our ER physician, guideline for the medical practitioners on the death certificate, which is very important. I think writing a death certificate also is a very important part of our clinical practice.
True.
So Dr. Harshil Mehta, please.
Good evening, everyone. Since morning you are treating a lot of patients, but if patient dies, unfortunately, then what we do? And that is what here is my talk, how to give a death certificate. See, as a clinician, we try to focus on diagnosis and management of the patients, but if patient dies, then it doesn't stop our responsibility. Our responsibility continues till we give death certificate. And death certificate, on the first glance, we feel that it is just administration, but it is not an administration. It sits on the intersection of your clinical judgment, ethical practice, legal liabilities, and most importantly, public health awareness. So I don't have any financial disclosure. So give me an opinion on this case. How would you give death certificate to this patient? So you have a patient of 60 years who had strangulated femoral hernia, and patient had a lot of complaints. Patient went for the surgery and release of hernia and recession of the intestine, and end-to-end anamnestis was done. On 5th of January, after 2 days, patient developed peritonitis and patient died. Then you have 4 options to give death certificate. Now, these are the 4 options. What would you consider as the most immediate cause of death for this patient? You have 10 seconds. Oh, no clear-cut decision. Okay, fine. That's why the talk is here, and it's been always pleasure to be on the dais of JIC against this August gathering. So my talk is completely based on this manual. This is a physician's manual that is being published by Ministry of Home Affairs. Has anybody gone through this manual? One. So this manual is there since long time, and it is completely based on this manual. So it is not just statistics, but it lays the foundation of vital parameters like public health programs, health planning and management for the government, and a lot of research programs on prevention of certain diseases. So this act, Registration of Birth and Deaths Act 1969, mandates us, the physicians, to give cause of death without charging a single penny. And when we give death certificate, it goes to registrars, then chief registrars, and then to government, and then they finalize and give data to government for research and various activities. But the confidentiality provision is always there. So Indian law protects physicians against the disclosure of any cause of death to the families. So it is not going to families, but it will stay with the government only, and that is why we, the physicians, are protected to be truthful, to be accurate, to be depth, and to avoid any feminism. So that is why it is important for the scientific integrity. This is the cause of death that we give since years. If we divide this cause of death certificate, then it is the first part, that is the demography. Then the most important crux of the death certificate is the cause of death that we give. Then the manner of death, then the signature, and lastly, the final part that we give to patient's relatives to get the death certificate from the local authority. Now there is a mistake, or I would say an error in this death certificate. If someone can pick up, then well and good. But I feel there is a mistake. So if we talk about the first part, then it includes the name and demographic details of the patients. Make sure you don't use any abbreviations while giving this kind of death certificates, because it is not acceptable. Second part comes the causal sequence. So it has two parts, part 1 and part 2. So part 1 is saying the immediate cause of death, and second is antecedent that contributes to the immediate cause, and part 2 is other contributing factors. So if we talk about death, then it is the final outcome. But what leads to it is the immediate cause leads to death. Then comes the antecedent cause that leads to the immediate cause, and then ultimately death. And final part is underlying cause. So if you are in doubt that what should I give the death certificate, then ask a question to yourself. Ask that if this condition would not have happened, then the death should have occurred when it did, and you will get the immediate cause of death. It could be disease, it could be injury, or it could be any relevant diagnosis. Make sure you don't use symptoms. The most important thing is do not mention acute cardiorespiratory arrest as an immediate cause of death, because it is a mode of death, not the cause of death. So most of us writes the acute cardiorespiratory arrest as the cause of death, but it is not. And it is mentioned in that physician manual published by the government of India. So second thing, use specific conditions. Even you can use the death because of some kind of injuries, because of road traffic accidents. And the part 1A is mandatory to fill up. You can keep part 1B and C blank, that's all right, but you have to fill the part 1A. Antecedent cause that contributes to the immediate cause. And in part 2, could be substance use or smoking or environmental factors or pregnancy, could be anything that is the underlying cause behind the death. Duration is very important because it is increases the credibility of your clinical judgment. So you have to mention whether it is minutes, whether time, whether hours, whether years, but you have to mention the duration before the immediate cause of death. In case of accidents, again, you can write as a road traffic accident because these forms are filled in the government website, and they also give an option for such kind of road traffic accidents. So that is the manner of death: natural accident, suicide, homicide, or pending investigations. Females, it is very important again to look for the maternal mortality, why it is happening, where it is happening. So it is important to fill this parameter also. So ensure the completeness, avoid symptoms only. So don't write chest pain, but you have to write myocardial infarction.
5 minutes
Specific
remaining.
infection type, if you have found out during your diagnosis, then please mention. Include disease progression, whether it is acute, subacute, or chronic. And if any organs are affected, then also you can write in your diagnosis. So why it is important to give accurate death certificate? Because with every accurate death certificate, you strengthens your health public system. And any incorrect death certificate would distort the reality completely. So make sure whenever you give death certificate, it has to be accurate. For the global health monitoring, to see the trends within your local area, for the research priorities, to develop any health policy programs, and for all these, acute death data is required. So that case, when we saw first, so the cause of death should be like this. Acute peritonitis because of perforation of small intestine and strangulated femoral hernia. All right, there is no acute cardiorespiratory arrest in cause of death. You have a case too, an injury patient. Patient had injuries, but ultimately he suffered azotemia, general arteriosclerosis, and arteritic heart disease and pulmonary emphysema. He developed bronchopneumonia and died after a month maybe. So the cause of death should be like this. Bronchopneumonia since 1 day, fracture of left ischium and ileum since 1 day, and atherosclerotic heart disease and coronary sclerosis since time. There are a few examples I would elaborate that what should not be the cause of death like this. So this is an incorrect certificate. Instead of, the certificate should be like this. All right. Another example. Diabetes, gangrene foot, carcinoma pancreas, and chronic bronchitis. That is incorrect. Now, how should we give this? It should be like this. And chronic bronchitis is not contributing to death as an immediate or antecedent cause. That's why it will go to part C. Another example. Retention of urine with hypertrophy of prostate with uremia, cataract, ischemic heart disease. It's incorrect. It should be like this. Uremia because of retention of urine with hypertrophy of prostate, and cataract and ischemic heart disease is not contributing directly to the death of the patient. So it should be in part C. Now we'll see a few examples. So it's a very long, so I'll skip it. Now it's so 75-year-old female, 15-year history of NIDDM, 13-year history of mild hypertension, thiazide diuretics and multiple medicines. She was found disoriented in the home and brought to the hospital. BP was on lower side. Laboratory test suggestive of hyperglycemia, hyperosmolality, azotemia, mild ketosis without acidosis, diagnosis of hyperosmolar non-ketotic coma. Within 72 hours, patient's condition resolved. But patient remained anuric and progressive azotemia, and attempts were made for renal dialysis and finally died. So the diagnosis, cause of death should be like this. Acute renal failure because of non-ketotic coma. Now I'll give you a few exercises for you. So this is an exercise for you. A 68-year-old male was admitted to the hospital with progressive right lower quadrant pain of several weeks duration. On physical examination, patient had an enlarged liver span. Routine laboratory tests within normal limits. CT showed the numerous masses within lobes of liver. A needle biopsy was done, which is suggestive of carcinoma, and chemotherapy was started. 3 months later, patient developed diminished liver function and deep venous thrombosis, and patient died in the hospital because of pulmonary embolism. What should be the immediate cause of death? Please give me your opinion. Great. You see now the clarity of the cause of death, right? Another example, very fast. A man, 63-year, has been treated with malignant hypertension, developed hypertensive heart disease with severe LV dysfunction and chronic renal failure. While seriously ill, patient developed acute appendicitis and appendix was ruptured. Appendicectomy was done, discharged in stable conditions. Heart condition deteriorated and patient died 2 weeks later. Your cause of death as immediate cause of death. Please give me your opinion. Yes, again clarity in the cause of death, right? So this is how you should give cause of death, right? So it will help you for the policy makers to prevent certain diseases by doing research, and future lives will be saved. It will take only 5 minutes to give cause of death, but it will have impact for decades. And that is why how you document death determines how future lives will be saved. And that is the thing I need to convey, and thank you very much for listening.
Thank you, Dr. Arshil Mehta, for the excellent talk. Now I will invite Dr. Akriti Agarwal. She has come all the way from Gurgaon, Moringo's hospital. She will speak on genetics at clinical door, when to order genetic tests, and when to refer to genetic counselor, and use of pharmacogenomics. Dr. Akriti, please.
Thank you, Dr. Gyan. Thank you everyone for being so patient. I'll be just very quick to introduce the new kid on the block that's been talked about in hospital setups very recently, that how do we bring in genetics at your clinic door, when to refer to a genetic counselor and order genetic tests. Disclosure, I have no disclosure to share. Why should every physician care about genetics? Show of hands, has any of you in your daily routine practice regularly see genetic reports or refer to a counselor? 1, 2, 3, very few in the room. Understood. So, but it's no longer a future medicine. It's actually today's clinical tool, which actually brings in a lot of clarity, be it in diagnosis, treatment selection, drug dosing or toxicity, and even disease prevention to a certain extent. And physicians are the first gatekeepers to genetic care. Just like you refer to any other streamlined field, genetics is also one of them. There are 3 key questions that every clinician should ask. Should I refer this patient to a counselor? Should I order this genetic test now? And can pharmacogenomics improve drug safety or efficacy here? A lot of physicians do have a lot of questions on, is it approved? Do we have the guidelines? Can we write it on the prescription? So on, and like the key, questions are endless. When one should refer to a counselor? There are a couple of signs when you see an early onset disease like cancer occurring before the age of 50. Strong family history, that is if you see in more than 2 generations of the family on either side. Multiple affected relative across generations. Rare, unexplained or atypical presentations which are not seen or read usually. And a lot of anxiety comes in with patients when you talk about genetics. A lot of confusion comes and they worry about outcomes of testing. Nowadays, insurance companies have started reimbursing certain tests, but earlier that was also a concern that a lot of patients were scared to even get it written on the prescription because they won't get the claims. Here comes the role of a genetic counselor. They identify families at risk, investigate the problem present in the family, interpret information about the disorder, because not everything is very straightforward. There are a lot of atypical signs and symptoms which don't link together well. Analyze the inheritance patterns and recurrence risk, and review available options for the family, whether who needs to be tested, how the cascade screening needs to be done, because we cannot test all the family members of the affected or high-risk individuals together. Red flags that you should never miss. There are 5 words that I would like as a rule of thumb for you to know. Early, rare, familial, recurrent, or unexplained. When you see any of these 5 or more than 1 or 2, you should think about genetics. One thing I would like to mention here is that anytime that you see this, a referral of a pre-test counseling, whether you do it yourself or refer to a genetic counselor, is very, very important to clarify what the patient is getting into. When should you offer genetic testing? When clear clinical indications exist, result changes clinical management. Testing is guideline driven. Nowadays, especially in cancer, NCCN guidelines, in most of the cancer types, they specify which test to be done at what stage, whether it's a relapsed or a refractory case, whether it should be done upfront, or whether it should be done if the patient is failed or has acquired mutations. Pre-test counseling has to be done. Couple of examples are targeted single gene tests, but now we are shifting more from the targeted single gene tests to a more advanced panel, which is next generation sequencing, which captures multiple genes, even the whole genome, all at once, which is also cost effective. When not to order, when you're confused, avoid standalone testing when family history is unclear. Especially like in Delhi NCR, we see a lot of medical tourism and people from Middle East or Muslim countries, they come in. When there is a lot of consanguinity also, the pedigree becomes really, really confusing or unclear or complex. Predictive testing is asymptomatic. Variants may cause anxiety without actionability. And when patients expect a yes or a no. So a lot of time patients come into the clinic and they be like, we got the test done long before, but nothing came in the report. A lot of times they feel that the test was useless. But if I was at that place, I would say that it's not useless. At least you're able to understand that you don't have the mutations or variants which will affect your treatment or have resistance mutations. A lot of times we don't get answers straightforward, it will change the treatment, but we do get answers that you might be resistant to a particular treatment, and that is where a role of genetic counselor is critical. Pharmacogenomics, that affects every prescription, but yes, the guidelines are very, very, ambiguous right now. What it answers is that, is this the right drug and dose for a patient? It impacts the drug efficacy, adverse drug reactions, treatment failures, and even hospital-acquired infections due to long stays. High-yield pharmacogenomics that physicians may use for anticoagulants, antidepressants, pain medications, oncology, cardiology, and transplant medications. Recently, in October only in 2025, FDA approved that DPYD gene testing is mandatory unless immediate treatment is required for capecitabine drug, which is an oral chemotherapy. So these guidelines have started pouring in, and I'm sure that they will help patients to improve the toxicity and get the maximum benefit that they can. When one should think about pharmacogenomics, when a drug has narrow therapeutic index, unexpected toxicity, poor response despite adherence, long-term or lifelong therapy planned, or multiple drugs, polypharmacy, which has been done. A lot of times patients do get acquired mutations also, and pharmacogenomics is a once-in-a-lifetime test. What one can do is they go back to the lab and they ask whether new drugs have been added to the list, can you please reanalyze our result? So when a combination therapy needs to be given, this test becomes really, really useful. How all of us can work together, that when a physician identifies red flags, initiates referral,
5 minutes remaining,
integrates results into care, and the genetic counselor comes in for risk assessment, test selection, interpretation, and cascade testing. Lab does the accurate testing and quality interpretation. This is how we can improve outcomes put together as a team, as a multidisciplinary board. I would just like to put out a common scenario here, which most of you would have seen in your clinics. Patient of a 42-year-old complains of, she's a newly diagnosed case of breast cancer, whose mother has had a history of ovarian cancer at 48 and got diseased. On antidepressants with poor response, and just like standard of care, her treatment plan was surgery plus chemotherapy. Now, how genetics come into picture? For the first thing is that because she's aged less than 50, she should be referred for counseling, first degree relative with ovarian cancer. This meets the criteria for hereditary cancer referral. What the GC adds here is proper risk assessment, pre-test counseling, right test selection. Whether she has kids, what she plans for her daughter, if she has one, what she plans for her son. If we miss the referral here, we miss the family, we miss preventing the disease as much as we can. Point number 2 that comes here is testing the germline variants. Germline variants which are flowing through by birth. And it identifies a pathogenic BRCA variant. Clinical impact here changes the surgical decision because for BRCA positive variants, bilateral mastectomy and risk-reducing saplingo-oophorectomy is recommended. It is approved. It influences chemotherapy choice. A lot of BRCA variants are platinum-sensitive patients and triggers cascade testing for siblings and children. The test doesn't change the treatment here, it changes prevention. So here also it is very, very important. And the third point is actually introducing pharmacogenomics to such a patient, because during the treatment, patient will develop severe toxicity due to standard chemotherapy, and pharmacogenomics will show drug metabolism variants. How it will help is in dose adjustment, alternate drug, prevents treatment interruption, improves tolerance. This wasn't a drug failure, it was a genetic mismatch. Take-home message that I would like to give to all of you is genetics begins at your clinic door. Refer early, don't wait for certainty. Order tests that change management. Use pharmacogenomics to reduce harm and improve outcomes. Genetic counselor is your clinical partner, not a referral burden. So please make use of this as much as you can to solve and help your patient get better clarity of what kind of disease they are fighting for. Thank you.
2 minutes remaining.
Thank you, Dr. Akruti. Now I'd like to call Dr. Hemant Menghani, who will speak on approach to the patient with acute leukemia, past, present, and what is the future.
Good afternoon, everyone. So my talk today is a big topic, leukemia. And there are many types of leukemias. The treatment is different. So my main focus to cover today is what was the past, where we were in leukemia, where we are in leukemia, and what is the future ahead for us. And when I say this, I like to give a very light example because when leukemia word comes, everyone gets afraid. So the light example is everyone follows cricket, है ना? तो आज से 10-15 साल पहले 150 या 200 का भी टारगेट मिलता था वनडे मैच में क्रिकेट में इंडिया को, तो भी हम श्योर नहीं थे कि हम जीत सकेंगे. वी यूज्ड टू सचिन तेंदुलकर है तो हम शायद जीत जाए, नहीं तो नहीं जीतेंगे. सो दैट वाज पास्ट. क्योंकि ल्यूकीमिया में भी हमारे पास पास्ट में वी हैड ओनली 1-2 मेडिकेशंस एंड वी वर टू ट्रीट मेजॉरिटी ऑफ दिस डिजीज विद 1 or 2 medications. So we were not able to do it. Then came a present where वनडे में 300 का स्कोर है, वी थिंक अब हो जाएगा. वी हैव मेनी प्लेयर्स, वी कैन डू इट एंड वी कैन मेक द स्कोर. फ्यूचर ऐसा है और अभी करंट में भी ऐसा है कि 350 प्लस स्कोर भी है. वी विल स्टिल बी एबल टू चेज दिस बिकॉज व्हाट प्लेयर्स वी हैव, व्हाट ड्रग्स वी हैव. So leukemia में this translates into what all medications, what all treatment options we have. So I will briefly focus on all the treatment options. Some of this will look like I'm rushing through the slides because there's so much to cover, but broad points will be discussed. So I don't have any financial disclosures. We all know leukemia is blood cancer, and obviously blood forming cells, hematopoietic system is involved. It can happen in both children and adults. Primarily when the word leukemia is said, it relates to WBC, though they are leukemias which affect platelets and hemoglobin, but we are talking about white cell counts. And it is the 10th most prevalent cancer, mostly seen in adults, but there are certain types of leukemias which are seen in children as well. In India, about 9.5% of all cancers in men and about 6 to 7% of all cancers in women. Myeloid variant tends to predominate in India, but lymphoid is the one in the Western countries, especially the CLL variant predominates in the Western countries. So first we need to divide what kind of leukemia it is. These are the two broad main categories: lymphoid, lymphocytic, or myeloid. This needs to be differentiated. And there is another way of differentiating which is called acute or chronic. Acute are the leukemias which grow very fast, so they need to be treated very fast also. Intensive chemotherapy is required. Chronic leukemias grow slowly, so the treatment can be less intensive. It can many a times be outpatient. So combining all those two criteria, we have 4 major classes of leukemia: acute lymphocytic leukemia, acute myeloid leukemia, chronic lymphocytic leukemia, and chronic myeloid leukemia. So with that, we start the first case. A 15-year-old male. He had fever for about 2 months and throat pain for 10 days. On examination, had pallor, lymphadenopathy, and splenomegaly. And the initial labs that were done because of the history presentation, hemoglobin was 5.5, a white cell count quite elevated at 58,000, and a platelet count of 30,000. And the differential showed about 40% as abnormal lymphocytes or abnormal cells. They were not able to tell what it is. So what would we do next? So you can, if you can vote for the question. So I don't know. It's pretty easy though. So, interesting. The answer I was looking for, all of these things should be done in about 3 to 4 hours. All of these things. Okay. So, I would say the fifth answer, all of the above. You need to do all of them. But if you really need to pick one, I would say the answer would be 1A. A would be the one that if you really want to push for one. But the answer I was looking for is 5, all of the above. But it should be done very quickly. All of them are urgent. So, a diagnosis was made based on all the things that were done of a ALL, childhood acute lymphoblastic leukemia. Currently, how do we treat it? We give a multi-agent chemotherapy regimen. And how did we came to that? Decades and decades of work. The first 50s to 70s where we found that what cancer agents can be used. Started with 6-MP in Dana-Farber and certain other medications that started to be used for leukemias, childhood leukemias. All children were dying. At the same time, from 70s to 90s, we started combining agents, multi-agent chemotherapy. So we started combining and seeing that the results were better. From 80s, we developed a concept of risk stratification. We started risk stratifying this disease. These are low-risk diseases, these are intermediate-risk diseases, these are high-risk diseases. And from 90s up until now, we are refining our treatment regimens so that best outcomes can be achieved, less toxicities can be done. Because childhood leukemias, as I said, is the cancer with the best survival out there. One of the best survival outcomes in excess of 90%. So now we started treating with our multi-agent chemotherapy. I'm moving with the case and saying that there was a refractory disease or the patient relapsed. Then what are our options? So here now we came into an era in the last 20 years where we have a lot of monoclonal antibodies, inotuzumab, blinatumomab, and we are combining that with our conventional chemotherapy regimens. And we are able to achieve remission in even these diseases which are refractory diseases. So we had a refractory disease, the relapsed disease was put into remission. But now we know that at some point if we stop these medications, the disease, high chances of coming back. So another thing that we can use for many of these relapsed refractory patients is bone marrow transplant. This has developed in the last 20-25 years very rapidly. It used to be done before that also. There is a pre-transplant period of about 15 to 30 days. Then a 30-day stay in the hospital in which you engraft, and after engraftment, immune recovery and follow-up for about a year. So, where did BMT came from? From bombings of Hiroshima and Nagasaki. From there we learned that radiation, our body is very sensitive to radiation. And our bone marrow gets suppressed. We had a lot of aplastic patients through that. And then we started trying somebody else's stem cells. First few transplants were done, oral stem cells were given. Failed. But slowly then we learned how to give stem cells better. We started with autologous and now allogenic. We had matched siblings. Now we do all sort of transplants with very good success rates.
5 minutes remaining.
So, then we are now into the era, this is the future, of many leukemias being treated with chimeric antigen receptor therapy, CAR T-cell therapy. This has just entered in India in the last 1-2 years, but it is revolutionizing how we treat cancers. And especially currently for B-cell leukemias, it has really came up, and soon coming for multiple myelomas, which was discussed earlier today. So now we covered ALL. The same way there is a chronic leukemia. Here, about 20 years back, we used to treat with fludarabine-based chemotherapy regimens. So patients used to get admitted and treated. Now, no CLL patient needs to get admitted. Either you don't require therapy, there are only specific criteria for therapy, and those can be treated outpatient with ibrutinib-based therapy. Ibrutinib is a TKI inhibitors, Bruton kinase inhibitors, and you can treat them with ibrutinib as an outpatient with long-term survival. So this is all the drugs that we have for ALL and CLL. The second case now, a newly diagnosed 26-year-old male who was already diagnosed very recently with AML, he comes for consultation. And what is the best statement regarding the standard of care? Will the patient require chemotherapy, and response-based treatment modification will be done? Patient will mostly need stem cell transplant if he needs long-term remission or cure. Most cases of AML relapse and recur and do not survive. The fourth option, treatment of AML is patient-centric and individualized based on risk stratification with molecular subtypes, and then can be treated with chemo, targeted immunotherapy, and stem cell transplant based on risk stratification and response. And survival depends on all of these. Again, an easy one. So see, 100%, but what most people tell is answer C. When the patient comes to us, answer C is given to them by most of the people. It's easy that we are saying 100% here, but when they come, everybody is told that most of the AML patients relapse or recur and they do not survive. So AML, from mid-70s, we have 7+3 regimen, cytarabine and daunorubicin. And we had allogenic transplants in early 80s. For 20 years, we didn't have any advancements. And then since 2000s, we have all sort of new medications, targeted medications, transplants, modification of transplants, all of them are coming in. So right now, the main differentiation is the patient eligible for intensive chemotherapy or not? If the patient is eligible for intensive chemotherapy, based on their molecular profile, you give them intensive chemotherapy. If they respond and the risk is low, you can continue that. If the response and the risk is high, you can proceed for transplant. If the patients are not eligible for intensive chemotherapy, you give them low dose therapy with maintaining their quality of life. Now, acute myeloid leukemia, same way chronic myeloid leukemia. It's a very, very common disease. Everyone must have seen in their relatives, in their extended family, societies, neighborhood, a patient who has CML. Highly, highly treatable. It is now managed more like a chronic disease and not like a cancer. And mostly outpatient-based therapy with excellent long-term outcomes. First, we used to, in 1960s, we found out that, Philadelphia chromosome 922 translocation. We first used to transplant all of them. All these patients require transplant. And now we have come that nobody even needs to get admitted in the hospital. All of them are treated with tyrosine kinase inhibitors, the first generation being imatinib, and now dasatinib, nilotinib, even for refractory cases, asciminib, ponatinib, all these medications are available. So with that, I will give few take-home messages that all leukemias are highly curable in the present era. What we need is a proper diagnosis and a risk stratification. If you have a chronic leukemia, either a CLL or a CML, they are treated on outpatient basis. You don't even need to get admitted. Many of them don't even need treatment, especially in CLL. Acute leukemias, they do require intensive chemotherapy or targeted or immunotherapy. And in cases who are refractory or have relapsed, bone marrow transplant has revolutionized the treatment of high-risk cases. And now moving forward, already our center is doing CAR T-cell therapy, and moving forward, this is becoming the standard of care for how we treat leukemia, and it will soon come to all solid organ cancers. So many solid organ cancers are also now being targeted with CAR T-cell therapies. So leukemia care is rapidly evolving and keeps changing every few years. So a treatment at a specialized center and a physician gives remarkable outcomes. Thank you.
Thank you, sir, for the nice presentation over leukemia. For the last talk, I would like to invite Dr. Narendra Barar, sir, for management of advanced Parkinsonism. Please, sir.
Yeah, at the outset, I just want to thank the organizing team for providing me this opportunity. So, in 12 minutes, it's difficult to cover all the options, but I've tried my best to give the basic idea, like how to identify certain things and what are they at least available right now, even in Gujarat right now. So at least you can offer that thing to your patient. How to change next. It's slide. How to change?
EV team, please help.
જાતે જ થશે કે નથી થશે ના ઓકે અહીંયાથી ઓકે okay so sorry so what's defined advanced Parkinson disease? So we are not here to discuss about Parkinson disease because my topic is to talk about the advanced Parkinsonism. So in Parkinson, for initial years, patient have stable symptoms, and as the disease progress, most of the patient develop motor complication. So we call it dyskinesia. So they have some off period where they are not able to do certain thing, and suddenly they have on period. So it's like switch on, switch off kind of phase come. And if they receive more dopamine, they have motor fluctuation. So we call motor fluctuation of that particular stage. That is the advanced Parkinson stage. Sometimes the overstimulation or the extra effect of dopamine, we call it dyskinesia. Increasing axial symptoms, need for frequent dose adjustment or the rescue therapies, significant non-motor symptoms which is impacting your quality of life, and troublesome focal and dystonia, or sometimes fully dependent stage for the activity of daily living. So what are the options we have? So for the motor complication, the first step is always you have to rationalize the drugs. Second, device, there are certain device-aided continuous dopaminergic therapies are also available. And the third option is neuromodulation. So the other name for deep brain stimulation is the neuromodulation. And other than that options, we have to adjust certain drugs for certain non-motor symptoms. Botulinum injection is also helpful for certain type of dystonia which is associated with advanced Parkinson. Then rehabilitation and multidisciplinary care, and the last point which is also important, palliative and supportive care. So here you have to discuss about the end of life care discussion. Yeah, so for optimization, there are multiple options. So now the beyond 50, the levodopa is the standard of care. So if any patient have Parkinson's symptoms which is started after 50, levodopa is the standard of care. So now people don't use the dopamine agonist as a first line therapy. In some early onset cases, I say below 35 or 30, you can still use dopamine agonist as a first line of treatment. Otherwise, levodopa is the standard of care. So as the disease progresses, patient requirement of levodopa is increased. So here where you have to add other drugs to optimize the effect. So the other drugs which are available are COMT inhibitors, MAO-B inhibitors, dopamine agonist, amantadine. So, but the problem with all these drugs is always come with some issues. So, if you add more dopaminergic or the adjunctive drugs, there is a risk of cognitive decline, behavior issues, hallucination, and all the dopaminergic drugs have some effect on BP. So, the BP fluctuation and the orthostatic hypotension is very disabling in certain patients. So, orthostatic hypotension is when patient change the position from supine to sitting, there is a dramatic fall in the BP, which is more than 20 in systolic and more than 10 is diastolic, which is considered as orthostatic hypotension. So, after optimizing drugs, the other option is the device-aided continuous dopaminergic therapy. So the basic concept of management of advanced Parkinsonism is you have to continuously deliver the dopamine. So few options are available, but unfortunately it is not available in India right now. I am just highlighting here. So first is that levodopa carbidopa intestinal gel, which is called deodopa, which is directly dopamine is here directly delivered in the jejunum, and it is best for the advanced stage. It creates a smooth plasma level, so patient get less disabling off time. And the limitation is tube-related complication cost because it's very costly, and caregiver dependence because every time you have to refill the gel and everything. Other option is continuous apomorphine infusion. So here also the same. It can be delivered by a subcutaneous pump. So same like a insulin pump. But it is only when the DBS is the advanced treatment in the form of deep brain stimulation is contraindicated. Same, it is improve off time and some dyskinesia. The limitation is it causes nodule, the injection site nodule. It is very disabling. You can see here, this is how they apply the pump, and here you can see the nodule. So it is very difficult to manage. And the other issue with continuous apomorphine are the hallucination, cost, and poor pharma support. So at present, only one company is available, and because of the poor pharma support, sometimes it is very difficult to put patient on the continuous apomorphine infusion. And then there is a new molecule in the market, phospholevodopa carbidopa. It is famous by a Instagram video. So it is available in the US market, not available in India. But again, same, the mechanism is the same. You have to continuously deliver dopamine by subcutaneous route. It is minimally invasive, same way like apomorphine we give. And the problem is also same, infusion site reaction, nodule and pain, and require proper training for pump handling because it is also very expensive. And unfortunately, we don't have the long-term data, and it does not improve the non-motor symptoms. So here the main player we call is deep brain stimulation or the neuromodulation surgery for the Parkinson. So here we put a implant, a pulse generator or battery in the chest, and from a wire we connect directly to the electrode, and electrode is placed directly in the brain. So this is the electrode, how it looks, and in cut section, and these are the electrode. So now, because of the advancement of the technology, initially we have like 4 contacts, and all 4 contacts were a ring contact. Now they have developed segmented contacts. Though the advantage of segmented contacts is we literally steering the current. So if I don't want to deliver the current on the lateral side, I can literally block the lateral contact, so current directly goes to the medially. So we can clearly, easily stimulate at the required area, and that's why we can minimize the side effect and we can prolong the effect of this therapy. And deep brain stimulation is, I think it is helping in all type of advanced Parkinson disuse. So here is a severe wearing off. So look at the patient stage in off period. He required support and everything, difficulty, and 7 or 8 years of story requiring 6-7 tablets in a day and the effect lasting for 2 to 3 hours. Every 2 hours he has to take dopamine. And this is after DBS. So this is for severe wearing off. Here patient has a very bad off period, required frequent dopamine. Then also he is not able to maintain activity of daily living independently. So this is after DBS, deep brain stimulation. Then there is a disabling tremor. A, B, C, D, आखी जोर थी बोलो. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T, U. And he is the same patient after DBS. ABCD bolo जोर थी. No tremor at all. So in 3 month time, even dopamine doses are also reduced, and you can see there is no slowness. He is faster than me even in doing that movement. Then very severe freezing of gait. So she is not able to lift the leg. Very bad freezing. But this is in the off freezing. And this is after DBS.
Remaining.
In the evening only, once we started the system. And the last indication, as I mentioned, dyskinesia. So this is called dyskinesia, rapid fluid movement. So I'm just trying to distract her so we can have a good idea about the how. So see the dyskinesia. અત્યારે તમને ઓવરઓલ કેવું લાગે છે આ ગોળીનો ડોઝ લીધા પછી આમ એનર્જી આવી શરીરમાં એનર્જી એવી પણ થાકી જાય હલવાનું વધે so she said I'm feeling tired because of continuous movement બાકી શરીરમાં એનર્જી and here is the same lady તમારો after DBS. This is 4 years after DBS. This is a lady in the pink. So this video is recorded by her daughter-in-law, and she said with me to say that, doctor, this is what your patient is doing right now. So we have never thought that avan 11 years of Parkinson he can do like this. And ek celebration rakhu to if surgery work for me, I do this celebration. Yes, then we come to certain non-motor symptoms. This is like brief slide, so at least people should have idea what drugs can be given. Depression, anxiety, use SSRI, SNRI, which is better. Psychosis, now there is a new drug, pimavanserin, is very helpful. Avoid the risperidone and olanzapine because they 100% worsen the Parkinson. Cognitive impairment for Parkinson, you have to use rivastigmine because rivastigmine is a better evidence. Avoid anticholinergic because it's worsen your gait and urinary issues. Some patients have fatigue, so sometimes even chronic, even though the HB is normal, if you check the ferritin, they all have a low ferritin. If ferritin is less than 75, just giving a simple IV iron is also helpful in fatigue. Autonomic dysfunction is tricky, but yeah, orthostatic hypotension, fludrocortisone and midodrine is commonly used in our setup. Other than that, pyridostigmine is also very helpful. Urinary urgency, mirabegrone is good because it's a less anticholinergic effect. Constipation is also one of the problem in the advanced stage, so certain laxity or gut motility optimization and sometimes help of the gastroenterologist is also helpful. Sleep, RBD, REM behavior disorder where patient make noise or voices or some involuntary movement in the sleep. It is called RBD, even hitting the partner. So they don't know about that. And usually they don't reveal this history to you. So it is better to ask them directly, like, is he or she has any issues in sleep in terms of making some noises or hitting the partner or talking in the sleep or having some sleep hallucination? Because it's a pathognomic feature for the Parkinsonism. It is not describe any other condition. Excessive daytime sleepiness is usually associated with dopamine agonist, so you have to just adjust the doses of dopamine agonist if one of your patient is complaining about the daytime sleepiness. And sleep apnea, sometimes because of the other comorbidity, some patient may have sleep apnea, so using of CPAP is also advisable in advanced stage. Then comes the stage of rehabilitation and multidisciplinary care. So as the disease progresses, we cannot do surgery in all patients, and unfortunately some patients are not affording for this most advanced treatment option. So in that cases, the multidisciplinary team approach, including a physiotherapist, a good speech therapist, occupational therapist, and a dietitian, it is very, very good and have a good collaboration. Then it gives a good quality of life to the patient, and it is always cost effective. palliative and supportive care. So when as the disease advances and patient is become dependent for activity, all activity of daily living, your goal should be shifted from routine treatment to the comfort, dignity and caregiver support, simplify your regimens, treat pain, dyspnea and anxiety aggressively, and start the discussion of end of life discussion, because it's very important. You have to timely sensitize the relative about the irreversible disease trajectory and inform that about avoiding the non-beneficial life-sustaining intervention like mechanical ventilation, dialysis, and thereby it is our duty to provide them comfort and focused care, and patients should have a death with dignity, because sometimes just prolonging the care without this discussion is very painful for certain patients. And then the botulinum is also helpful for certain patient. Here there's a young Parkinson patient. He has a difficulty in opening eyes. We call his eyelid opening apraxia. He's not able to open the eyes. See. Yeah, it's very difficult. Here. After Botox. So it is also helpful. If you are not able to open the eyes, it's very disabling. So same after the... Other than that, Botox can be also useful and is a treatment of choice for various cervical dystonia, oromandibular dystonia, or even the abnormal posturing of the advanced stage of Parkinsonism. So our ultimate aim is to provide them the options which are there to make their life comfortable. And with that I will end. I am always grateful to my colleagues and teacher for their love, support and teaching. This is my Hinduja family and this is my Queen Square where I did my fellowship in movement disorder. And this is my last slide. So me and Dr. Chirag started our functional neuroscience department at SIMS, Gujarat first. And in last year, I'm happy to share that Dr. Mitesh has also joined. So we have done 18 neuromodulation DBS surgery, which is the highest in the Gujarat. No, not any other hospital is doing it. Other than that, there are other procedures we also have done. So team work is always helpful for the growth of the institute. Thank you.
Thank you, Dr. Narendra Bhai, for the excellent talk. Now I would like to call all the speakers on dais so that we can have a question and answer session. Dr. Rikin is here. Dr. Megnani, Dr. Onmil, Dr. Harshil, Dr. Narendra Bhai, you can also join. So, yes.
So, what is the cost of a DBS surgery at SIMS Hospital?
In weight loss drug.
What is the cost of the surgery?
You can come here, no?
So there are two types of device available for the DBS. So one is the rechargeable and one is non-rechargeable. So rechargeable where you have to just put a wireless charger on your shoulder and it is the same like your iPhone. It got recharged over the period. And the cost for that is around 25 lakhs because the battery life is here is around 25 years. So it is a variable because both the device we use commonly, Medtronic and Boston, is exported, it is not made in India, so there are some variation in the price. And the another device is non-rechargeable, where the total life of that IPG is around 7 years. So there the costing is around 17 to 18 lakhs.
Sir, yes. In a weight loss drug, Ozempic and tirzepatide, they reported about 5 lakhs people suffering from mental illness in Australia before 2 days. What is your opinion?
Sir, actually, this medicine works on food addiction because many people, particularly adolescents, have so much sugar addiction. So it's same like alcohol and tobacco addiction. If you remove a substance, problem is going to there. So this medicine should be given under prescription and under observation of specialists only. Because if we don't experience any side effect like pancreatitis, any GB stone or any suicidal tendency or any eye complications in our patients, because you always have to screen patients carefully in which patients to give or not give. Every time detailed counseling is required, for side effects monitoring is required, and repeated reports is also required. So always give under monitoring. If you, because many countries there are compounding pharmacies there, because many times semaglutide has been under short-term supply. So many other pharmacy companies are also producing, and these are going on a completely black market. So it is without supervision many people are taking. So patient might have some risk factors and they are taking this medicine without supervision, then there is a problem.
I would like to make two comments on that death certification thing. One, many of my contemporary and senior physicians still certify deaths on their letterhead itself. So the government has made it mandatory to use this MCCD, that is medical certification of cause of death, for issuing. That's what I am routinely encountering. Second, any physician can certify death only when the patient has been seen by the doctor, treating doctor, in last 14 days because of which the patient has died. That is in that example where the patient had undergone appendectomy and then died because of congestive cardiac failure. Ideally, the surgeon would not be able to certify death, only the treating physician for that failure would be able to. Having said that, one question for Dr. Rikisha. One of the questions that you have already answered about depression. One more thing is about side effect about sarcopenia, especially with the use of tirzepatide. So what is your take on that?
You have to give high protein diet, along with you can give nutritional supplements available in the market, and always do body composition analysis on every visit, and also resistance exercises. So if you do a complete teamwork in these patients, then this patient does not develop sarcopenia.
And Dr. Again, one question. Yeah, Dr. Badlani.
Yes, sir.
How you decide where to use SEMA or where to use tirzepatide?
Very good question. Because every time this answer of this question has been different, because every time pricing are different.
Companies are different. When it's company sponsored, the answers are different.
Because pricing has been changed for many medicines. Before, if you say before 1 year, we have only Rybelsus was available. After that, injectable SEMA came. After that, tirzepatide came. So many times tirzepatide is currently a costly molecule, or many patients are on that. But if patient is not affording the price of tirzepatide, you can use semaglutide because it is cheaper compared to tirzepatide. But in weight loss, obviously tirzepatide is superior.
But don't you think cardiovascular benefits are better with SEMA?
Semaglutide is proven to reduce the risk of ASCVD, reduce the risk of MASH, and it is approved in fatty liver. So, and for tirzepatide studies are already going on, and they are also positive. It is already one study has came for tirzepatide against dulaglutide.
Thank you all the speakers, and this is time to conclude the session. Thank you very much.
Hello. Before we separate for the tea, 5:30 is the time for town hall session in the same hall. 5:30, I think it's 4:30, 4:35. Maybe so we have 30, 40 minutes for tea break. Bladder, it's 5. So we have got 25 minutes for bladder break and snacks and tea. 5:30 we will be here. And then after that, 7:30 onwards, we have got satellite symposia at Hyatt Regency Hotel on Ashram Road, not too far from here. It's near. Thank you.
એક કલાક ચાલશે બદલી નાખને લોચો પડશે બદલી નાખે ને કાલે નહીં બદલ્યું સવારના સેશનમાં નહીં બદલું લંચ પછી બદલી નાખવાના કેટલા પત્તા છે પાછળની સ્લાઇડ કરજો ને ના ના આગળ આગળ ના ના છે જ 1 કલાકનું 6:30 પત્તા હા લે મારે જોવું પડશે મેં એક પત્તું લાવ્યો એક પત્તું હશે પત્તા લાવે ને તારા 10 માઇક 5 માઇક છે 10 એ થયા
10 to 20
14 થયા સમજી લે અને 2 કોલરમાં 14 થયા તારે
2 પેજ લાગવાના બધામાં તો
ના નવા આપ્યા મેં
2 પેજ લાગવાના બધામાં
14 સેલ તો થઈ ગયા તારા એક સાથે અને 14 ને આવી જાય અત્યારે 8 બદલે જ બીજા પડ્યા કેટલા 20 50 લાવ્યા રાજુભાઈ મંગાવેલું કરે કાલે જઈને લઈ જઈશ યાર તો મંગાઈ લે રાજુ કહી દે ને ઘરે નહીં પાવ થઈ ગયા બદલાઈ ગયા ને લે આ સેલ લઈ લીધા પેલા ઓલા અહીંયા ભલે રહે હું છેલ્લે લઈ લઈશ લે અંદર ક્રેકમાં નાખી દો ને હા ક્રેકમાં નાખી દો
JIC. JIC. Hello. Hello. Hello.
ખરાબ દેખાય ને બ્લેન્ક રાખીને બ્લેન્ક રાખો ખરાબ દેખાય શું આગળ બેસે બીજું કેવું બેસાડો બદલતા હું કેવું કરવાનું પેનલ સામસામે બેસે એક માઇક લઈ લઉં છું ટીવી બંધ કરતો
અમારું કશું નહીં ચાલે
Hello.
Good evening, everybody. Those in the back, come in the front. Everybody, come. This is more like interactive session we'll be having. So it'll be question, answers, interactions. There's no time limit. So make sure everybody sits in the first 5 rows only, 4 or 5 rows. Even closer, closer. Uba thi jao. First 4 or 5 rows. Because this is a small batch, it's interactive. We'll have as many of us here, and like always, I'll start on time. The other faculty may come in, but closer. Pachal bandas karavi deshu. Except photographer or cameraman. Just come closer. So this session, Professor Lucas, you can come upstairs. Yeah. We have started at 8:30 in the morning, so a lot of people are exhausted. This is something we have been doing this as a more casual meet to avoid long questions. So at least we have here 3 international, and I'm cross-national, US and India. So we have Professor Lucas, he's from Italy. He is a national, international expert on obesity, which means usage of the classic 2-3 drugs which we are using, semaglutide, tirzepatide. Vipul, come over. So any of the town hall faculty, they can come over there. Come over here. We have Dr. Neil Mehta, who can talk about anything in life, from meditation, Alzheimer's, sleep, how to live a good life. He is Vice Dean of Lerner School of Medicine, right? Apurva Patel is an interventionalist. You have seen him for the last few years, and a structural interventionalist also. We have Vipul Kapoor from us, interventionalist. So what I'll do is, this is a pure question-answer session, so that a lot of people in the morning session or in the upcoming sessions have questions, we can talk, controversial. So I'll start with Professor Lucas to come up here, or we have mics, hand mics. So let's have hand mics. And, I would probably like them to sit there, unless you want to sit here, because then many of the audience, or the audience can shift there, and we can have. So, no audience on the last rows. Audience, come in the front. Come in the front. So I want to make sure everybody is awake after a long day. Only photographers in those rows. Agar aa jao, boss. Everybody has to be awake. And then after here, we'll drive the herd to Hyatt for more session. Good. Front. So, Professor Lucas, we have subcutaneous semaglutide, tirzepatide, both available in India, reasonably discounted price. The question I have, and I think, how many of you have used those drugs? Wegovy, Mounjaro, quite a few. I'll come directly to the question. The question I have is, what is the role of protein intake, managing exercise, and collateral support when you take these drugs? You get my question? These are weight-losing drugs. Fantastic drugs, improves heart, improves kidney, improves everything. But there has been a lot of reports of weight loss, protein loss. So how should we as a doctor recommend our patients in terms of dietary balance, not for weight reduction balance, but for supplement? Should we also use any vitamin supplements? Just basic idea. Thank you, Dr. Professor Lucas.
Can I add a point?
And Dr. Apurva Patel.
To extend that question, now when you're using it for primary obesity reduction, at what BMI, when you achieve a certain BMI, at whatever stage it will be, let's say 8 months, 12 months, or 16 months, when do you stop that drug? What do you recommend to make sure there is no relapse? And if you have to continue the drugs, how long would you say that it is safe to continue? So because there will be a point in time, you'll reach a BMI of 23 or 25. Then what do you do?
Thank you. Thank you for the question, and thank you for the invitation to the Congress, of course. The first question is related to the first question is related to the.
Can you hear?
Can you hear me?
Okay, fine.
Okay, thank you. So the first question is related to the quality of weight loss using this medication, as well as when we use other methods for weight loss like bariatric metabolic surgery. So when we have a very important weight loss, we need to take into account that at least a part of this weight loss can be fat-free mass or muscle mass loss, and this is not beneficial. So we need to try to protect as much as we can the muscle mass during weight loss, and we have two different methodologies at the moment. The most important one is physical exercise, but we are not talking about aerobic exercises. We are talking resistant training, because if you want to protect the muscle and to increase muscle mass and strength during weight loss, you need to refer to resistant training and not aerobic. And the second one is maintain an adequate amount of protein. This can be done by diet or even with supplements. But remember, if you give protein without doing exercise, the human body in energy restriction will use the protein for producing energy, not for building muscle. So the two things need to be put together. When the people reach an adequate amount of weight loss, the second problem is maintenance. Your question suggests that at one point we should stop. But I am not sure that we should stop, because if obesity is a chronic disease, as we believe, what is the reason why we should stop medication? When you treat the people with hypertension and you reach a very good value of blood pressure, you don't stop the antihypertensive, because you expect a rise in blood pressure. When you treat a people with type 2 diabetes and you reach a very good level of glycated hemoglobin, you don't stop hypoglycemic drugs, because you expect a rise in glucose levels. And for obesity, it's pretty the same, in my opinion. So of course, we need probably to adapt the dosage, because the dose of the drugs that we need for maintaining is not the same that we need for losing weight. And this is probably the future of these obesity management medications, because at the moment we have several randomized controlled trials oriented to weight loss, but we have very few randomized controlled trials oriented to weight maintenance. This is my
So the message again is, to be clear, that to avoid protein loss or to maintain proteins, you have to do exercise, resistant exercise, weight lifts, stretching, bending, but mainly weights in different way. Not aerobic, not cardiovascular, number one. Number two, supplemental protein is important, but with exercise. Number three, it is very likely this will be a lifelong therapy. It is not something, because obesity is a chronic disease. We still don't know the ideal dosing, but it will be down-titrated dose to maintain. So these are the three important takeaway messages. Dr. Urmil has a question, comment.
No. So I just want to continue whether to continue the this anti-obesity medicine. It needs to be continued long, because if you stop it, there are so many studies which have shown that again the weight goes back to the normal, maybe within 12 months to 15 months. That is a recent trial which has been published. Not only that, the HbA1c which has been corrected, the blood pressure which has been corrected by reducing the obesity also goes high. So ultimately, whatever advantage of reduction of obesity as far as metabolic parameters are concerned, again goes back. So it's not only weight. Hypertension also will reappear. The diabetes also will reappear. So practically, we need to continue for a longer time.
Agree.
Dr. Neil Mehta has a comment too.
Again, one or two couple of points. So is there a role of dose revision? Once certain BMI is achieved and somebody is, say, for example, a little more motivated to do exercise and diet, so is there a role of reducing the dose? Number one. And number two, there are certain serious, very rare adverse effects, say, for example, non-ischemic, this optic issue, maybe pancreatitis to some people. So do you upfront convey this and communicate this with the patient? And if not, then if some such thing happens, how do we take as a medical fraternity?
Of course, one of the advantage in obesity management that when patients lose weight, the physiology of the people change. It's much more able to do physical activity than before. And we can use as much as possible the increase in physical activity in order to reduce and maybe in some patients to stop. But in the real practice and in the evidence that we have, much of the people, when they stop the drug, they tend to regain because obesity is a chronic disease. And we have biological mechanisms in place that favor weight regain after weight loss. Any drug has side effects. We use these same drugs for people with type 2 diabetes from here and then here, and we know the side effects. We know the story of the pancreatitis, very reduced in number in the last period. In the SELECT trial, the longer trial that we have with semaglutide, 4-year trial, cardiovascular outcome trial, no differences in the rate of pancreatitis in between the placebo and the treated group. We have these very rare side effects, non-ischemic optic neuropathy, 1,000 for 1 people for 50,000 patients in the general populations, extremely rare, very difficult to be detected by the trial. We need to speak with the patients. We need to have a patient fully informed and to balance the risk-benefit as we did for any other drugs and any other diseases.
I was just going to make a point. There is a ligand system called activin. I don't know if people have heard about it, but there is a lot of research going on about using monoclonal antibodies to block that to prevent the loss of lean muscle mass. That's pretty much all I know. I don't know if you've done work on that, but right.
So it starts with a Z. It's an active trial right now. They're looking at 20% weight loss without losing muscle mass.
There are several molecules of this type under evaluation now. They are still in the initial phase of study. Only one starting now, phase 3. But we will see in the future. It seems to be promised, but again, we need to look at the side effects. Now we know that there is an efficacy from phase 2, but we need to wait the phase 3 in order to understand better the risk-benefit balance.
I'll tell you, last 5 years, 7 years has been the most exciting in cardiovascular medicine. Both intervention with TAVIs, various devices, but also in medical side, heart failure, explosive medication leading to phenomenal survival benefit, diabetes medicine, and I think the obesity treatment, along with the diabetes support and the trials showing cardiac survival, cardiovascular events, is a phenomenal, don't you agree? Last 5, 7, 10 years. There was a 10 years in between or 20 years, there was almost plateauing, nothing new was coming, and suddenly it's coming. Questions from the audience now. Dr. Javeri, yes, you can loudly and I'll repeat the question, or you can get the mic. Either come closer, I'll repeat the question, or get a mic extra.
His question is, what is your experience on suicidal tendency with weight loss medication?
certain report. 2 days back, CME India reported a 5 lakhs people in Australia, they develop suicidal tendency and a mental disturbance. This is a report from CME India. What is your comment?
We had the same concern in Europe 1 year ago. There was a report from Iceland of some cases of suicidal ideation with GLP-1 in general. Most of them they use GLP-1 for type 2 diabetes, not for obesity. The European Medical Association started with a evaluation, post-marketing evaluation, and they closed saying no substantial differences in between patients treated with the GLP-1 and not people not treated with GLP-1 about suicidal ideation. This does not mean that some people could have some side effects at the psychiatric level for the weight loss per se. Because, of course.
See, I mean, adding a point to that, mental impairment may be ranging from whatever some fuzzy symptoms to this suicidal tendency. See, when such news come, they said that maybe X number of people had this tendency. Now, they were taking, say, for example, GLP-1 or tirzepatide. Now, is it purely because of those medicines or there are other reasons? Because those 5,000 people were also using mobile on a daily basis. Nobody blamed mobile. Those 5,000 people were on WhatsApp for 2 hours a day. They were on screen for 10 hours a day. Nobody blamed using screen for 10 hours a day causes suicide. It's only a medicine which generally, as a society, like to blame at. So this is an observation that this number of people had some mental impairment, and then by accident, they were taking this drug, so they just put it to the drugs. People want a medicine or something to be blamed. That is the nature of general people. But there are so many confounders. So we have to look at confounders. So such things are just a caution, should not deviate us from using the science which has got evidence for so many serious diseases.
On the flip side, I would like to say this. Australia has a population of 20 million, out of which 500,000 people are suicidal. That's 2.5%. I think they need a serious introspection into their cultural, social, psychological support. There is seriously something wrong out there.
So to counter your point as a part of this discussion, so in the United States, this medication controlled by insurance right now is primarily given to 60, 70-year-old patients, mainly with diabetes and now recently with obesity, right? So like first of all, we talked about protein, like malnutrition, weight loss, FFM being less. So these people have not majority of these people have not exercised for 60, 70 years, right? So behavioral changes are not going to happen right away. And your risk for musculoskeletal injury increases when you start exercising at this age. So that is a concern. No, there is a concern for mental status disturbances. There is a concern. We have seen that. Whether I can say that whether it is really affected by this medication, the answer is no. But referrings are even our practice and our health network. There are 40 to 50 cardiologists, lots of primary care doctors. There are two concerns that come up. One is worsening depression, whether that is related to whatever scenario, can't say. And the second is nutritional anemia, because just people don't eat, so your hemoglobin tends to go down. That is something like in the United States, a lot of things is fortified. Folic acid is in bread, iron is in some flour, so things are fortified. So people normally don't have nutritional anemia. But now you tend to see it, like hemoglobin running at 10.5, now comes at 8.5. So these are the two concerns that would come out from the community, worsening depression and that. Whether it's related to the medicine or something else, can't say. But it's a concern, and that is people just keep on talking about it to the patient to make sure nothing bad is happening.
Yeah, that's the thing. That's the question. Any other question? Open up. Dr. Shukla?
The major problem for the youngster and young adolescent is there is an overexposure to social media. They are always on the screen. And I have noticed that people who are on the screen, they are overeaters. They just ask for the online food, pizza, burger, Coke, And they will not, as you said, they don't do any exercise, any outdoor activity. They are usually in their room or
But
surroundings.
Dr. Shukla, but I'll tell you also, there's a huge younger generation who are into gym more than we were ever, who exercise a lot, who are learned. So the incidence of social media, lazy couch potatoes, I personally think are less than our age. I think so. That is my bias. I've seen my children, they're active. Dr. Ashok Jain is agreeing. But that is a point. Next question. Yes. Also introduce your name every time there's a question so we know where you are from. You are?
Hello sir, I'm Dr. Durgesh Modi. Just to add on to your point, as you said that past 5-7 years have been tremendous for cardiometabolic health. I also believe that given the discoveries in past 2-3 years in dementia field, given that there are now medication for treatment and a test for without CSF or PET scan, next 5-7 years may be game changing for dementia. I wanted to ask questions to Dr. Neil Mehta.
Dementia.
On dementia. So, first I would like to know what is your real world experience with drugs like lecanemab and others. Second, are there any, so there are online I read research on non-invasive blood testing for dementia, mainly retinal scan based. Are they showing any promise? And thirdly, you mentioned about lithium. Are there any ongoing trials on lithium for dementia? Thank you, sir.
Great questions. I don't know if I'm able to answer all of them. First of all, personal experience. So I kind of didn't really say it, but hopefully reading between the lines, I said it's incredibly expensive, has minimal clinical benefit. It has amyloid benefit, but not clinical benefit, has serious risks, not very common, but common enough to be needing MRIs multiple times. So have I seen a patient who I have told, start this is a great medicine? Zero. Now, have I seen patients who are on it? Yes. So insurance is a big rate limiting step in the US. So a few people will go to our cognitive health center and either be able to afford it or get insurance to pay for it. And luckily, none of those have suffered ARIA, the amyloid-related imaging abnormalities. And I have talked to them. When they come back, I said, are you aware of the pros and cons? And you can imagine, these are people with cognitive impairment. This is a difficult conversation. So usually it's the family member who made the decision that, yes, we'll do it. Britain, the NICE guidelines, when one of these came out, said it is not approved for use in Europe, in UK. So I would say that's a long answer saying no personal experience of starting, personal experience of patients taking it, handful, none of them had complications, too early to say if it made any difference, right? And now I have cognitive impairment, so I forgot the rest of your question. So lithium, so it's incredible study. You are a researcher, go and look that up. It's one group of, one research lab that has done over 10 years of work to get to this point. Just that journey will help you as you are getting into epidemiology, and you were telling me. So they are starting clinical trials, very early stage. You know how that goes. They have to figure out which chemical. In the mice, it was lithium orotate. Make sure that that is the right chemical and salt in humans. Dose, so phase 1, phase 2. So it'll take 5, 7, 8 years before we start seeing anything, because as you know, impact of this is going to take a while to figure out. I don't know, hopefully that answers your questions. Thanks.
So, third question was about retinal-based imaging for screening of dementia.
Yeah, so I think I heard of that study. I don't know enough about it to speak intelligently. A lot of machine learning studies are going on right now. Bhavin in the morning was talking about sleep. Just the last week, there was a study that all the PSGs, polysomnograms, in one center of 600 or 65,000 patients were analyzed by machine learning, and they found it can be correlated with 131 different conditions at a very high level of association. So these are the types of studies that are coming out, but I don't have enough details about the one you mentioned. Something to look into. There will be many other tools, but if you looked at the study I mentioned about p-tau and amyloid, beta amyloid, very good high-level sensitivity, specificity with specific cut points. It's non-invasive. The only thing is cost. And in India, that's always somehow people figure out how to make it cheaper. So look forward to coming here and getting that tested someday.
Dr. Suresh Jain.
Dr. Suresh Jain, Mandsaur. Sir, this is just to know anybody's experience of non-invasive glucometer. Nowadays, we are seeing over the internet that they are available. Their credibility, correctness, and whether have been used.
Non-invasive, Dr. Rikin
Just
Shah,
like SpO2.
our diabetologist and obesity champion.
Many products are available online. Still, we have not found so much accurate device. CGM is a good device. It's not non-invasive, but otherwise many rings are there, many watches are there, but still they have failed for accuracy.
Just like finger test, SpO2, like there are on the internet, they are available.
So not accurate.
Maybe after 2 or 5 years.
I have a question. 2-3 people asked me a question, so I'm passing on to Dr. Apurva Patel. We had a talk briefly by me on AI. Are all of you MD physicians, more or less, correct? Raise your hands still, all of you. So the question I had is, what should you do that sooner or later, as patients get into AI, how would you have to adapt? Am I right? Dr. Apurva, we have talked back and forth over a while about how AI will change. Not as much some of the procedural doctors or high-end tertiary doctors, but basic physicians who do clinical practice. It can be a dramatic change. And how can you overtake or that? So we had a nice discussion earlier. So instead of me talking about it, I'll have him talk. Dr. Apurva, and anybody in the group can mention what they want to have. Dr. Lucas too also, the experience of AI, how it's overtaking lot of our knowledge and our experience. पहला आपने कहता था मेरे experience से ये है. अभी आपका experience is the most micro experience against an AI which is searching through maybe 1 billion database. Our teachers used to say, in my opinion. So the whole world knows now your opinion is kahoot. It's useless. I'll be honest. It's totally useless. It has no sense to say that to you, and you have already experienced your children. You can't tell them, my children, my opinion will say, get lost. Go ahead.
Yes. Okay. So there was this recent podcast from Microsoft. Microsoft is investing heavily into medical AI. Microsoft is investing heavily into medical AI, and there was this recent podcast that I was listening to, and that left into a series of discussions after that. So if you follow any GM, New England Journal of Medicine, they have this case of the month, which is like the most complicated case ever, right? So they piled up all the cases. They had a group of expert doctors who could talk within each other, and they would ask questions, and any GM would provide them with the details. So they were put up against artificial intelligence. AI got 80-something percentage right. Let's call it 84, 86% of the cases right. The cost per testing, like they did all the costing, the average was $8,000 for the AI. When it came to the group of experts who could... Yes. So when it came to the group of doctors, what do you think? How many percentage times did they get it right? 20-something.
Less than AI, I was asking, you already said, I was going to ask, how many thought 60% doctors will be correct, 50%? Go ahead.
So 24, 26% got it right. The cost that the doctors utilized was much less, 3,000 something dollars. So AI does come with a cost, but it comes with accuracy. So like one of the other examples, like, you know, for example, back in the days, there was no ultrasound in the OB's office, right? Everything was palpation, etc. Nowadays, you go to an obstetrician office and there is no ultrasound, the woman is going to turn around and walk away. Same thing, like these guys are not going to see your patient without an echocardiogram. Like, would you refer your patient to SIMS if SIMS says, I'm not going to do an echocardiogram on your patient? That's not happening. The same thing is going to come to AI. Like how does AI help it, right? Like the vision is, for example, 70 to 80% of our problems are simple. I'm a cardiologist, I'm going to talk from that level. Example, you have one person who has a hemoglobin A1C anywhere from 6.5 to 7. You have a blood pressure anywhere from 140 to 160. You have a hemoglobin of 9.1. Your MCV is something, your iron level is something. Our human mentality, I'm not blaming any doctor, but majority of the time runs on autopilot mode. You start on 20 of pravastatin, random example. You start off 500 of metformin, you start on 25 of losartan, and Ram Bharosa, it keeps on going on. This is how AI can help you, right? AI will look at all the charts and tell you, by the way, your blood pressure has been running 146 for the past 3 readings. Do you want to increase your losartan 200? It can tell you. You don't even have to think about it. Like, we don't have to take it to our ego, but it will tell you. It will say that your hemoglobin A1C is running 6.5, 6.7. By the way, the guidelines have changed. GLP-1 are level 1. Do you want to switch your metformin to something else? Your pravastatin, now you are 45 years, now you are 50. Your ASCVD score just went from 3% to 7%, whatever, because of the age. I'm just giving a random thing. Do you want to switch your pravastatin to rosuvastatin, which is a higher risk or a much more intense intensity? This is where AI is going to come into place. It is going to supplement you. The human touch of a doctor will always stay there, right? How you behave with your patient, how you treat your patient. But AI will supplement you, just make you a better physician to take care of your patient. That's where AI is. That's where I look to use AI in the practice.
Let me ask, while Dr. Neil, before he answers, how many of you in active consultation, in presence of a patient, are opening your mobile and checking with AI? How many of you? So I'm happy, I'm doing it. So there's nothing to be ashamed of. What he's saying is that you may start using AI on a regular basis. Dr. Neil, please.
Yeah, so two points. The Microsoft study was incredibly well done. So they didn't just have the question put to AI, they actually had a sequential approach. So if you see a GP and you have a question, you say, okay, I'll send it to endocrine. So they had bots trained like specialists, and it was used in the way humans do. The caveat there, which is buried deep in the fine print, is the humans in the control group were not allowed to look at any resource available to them. They had to respond only with what they knew. Now, does any of you ever practice when you don't know something, you can't look it up, right? So I asked the guy who ran the study, I'd met him at a conference, as to why they did this, and they said, we have to put limits, because if we allow humans to look at whatever resource, then there is no single control group. It's a very heterogeneous group. And this is the first step of the study. So keep that in mind. There is still a little bit of hope. Maybe a few months before ChatGPT is better than you. The second thing, and this is hot off the press, in the US, OpenAI, which is the author of ChatGPT, they released, and it's being rolled out, what is called ChatGPT Health. So right now, if you are a human and you want to put your clinical data, your patient data in ChatGPT, I would never do it, because it's used to train the model. If you release some information in there, I would have done a huge HIPAA violation. But this is for patients. It will be secure. It is linked to their electronic health record. They will connect to their record and then be able to ask ChatGPT questions about their own health based on the data in their electronic health records. Now that patient, when he comes to you, will be smarter than you are. So what Apurva just said, it is already almost here. So your world is going to change dramatically. And so listen to the next few AI sessions.
Professor Lucas, I have a question. You mentioned that the maintenance dose of some of these drugs for chronic obesity is not known. Would you anticipate without trials, based on massive data, can AI come with presumptive data in this kind of patients in obesity, that what do you think, based on the statistics, could be a reasonably, and if so, can that extrapolation models start to be used in a lot of diseases? Just a question. I mean, you may say, I don't know, because we don't know. But
No, we
as
don't.
people started questioning AI to see from the global database what can be the presumption? Both Dr. Neil and Professor Lucas.
It depends from which data we have. So AI respond according to the data that we have. If we have data based on maintaining the same dose in the trial, the AI will not help us. So probably we need to move now from the randomized clinical trial phase of these drugs to the real world data, and this real world data can be used by artificial intelligence.
Yeah.
Otherwise, we will have the same answer that we have now.
Right.
No data.
Yeah, no, this is a great question. You're thinking ahead. The challenge is the good thing about a randomized clinical trial is you have figured out who you want to participate, and you have a very systematic way of collecting data. Post-marketing surveillance is one of the messiest way to do research. VARIS, which is the vaccination thing, when you have a problem, you report something. When you don't have a problem, you don't. Everyone thinks vaccines are bad, right? So we need a very systematic way where people, after the study is over, will input into some database what their doses and what their matrix are. When they come to see me, every week they are changing what they are doing. They are splitting the dosing, they are microdosing, then 2 weeks later they change something else. So the data is going to be so messy, Keyur. But if we can figure that out, yes, then we have the data. AI or not, we'll be able to figure out what works.
I would like to add, sir, one thing. In my clinical practice, these Wegovy, Ozempic, and tirzepatide has come just less than 1 year. We have molecules, but Rybelsus we have since more than 3 years. So we have so many patients are on maintenance doses of Rybelsus, off-label using for obesity also.
Rybelsus, semaglutide, oral.
14 mg Rybelsus. So many patients are twice a week or on a thrice a week Rybelsus, 14 mg. And they are maintaining very much weight. They are very much comfortable. Their appetite is already controlled, and they are very happy with this weight. Soon we start to taper the dose. Their weight becomes on maintenance dose. Patient is on Rybelsus 14 mg daily. Weight loss is continue. And after the goal weight is achieved, we make it twice or thrice a week, and then weight is absolutely maintained over the years also.
Otherwise,
one thing more, when we are reducing the frequency of doses, then cost is reduces. The patient has no problem in continuing the medicine. The one major problem for this continuation of medicine is only cost, apart from the long-term data. So when this semaglutide is going to be off patent, then many patients will be on long-term semaglutide. Because when SGLT come, when gliptin come, we are also thinking when they were patented drugs, 60 to 80 rupees a tablet, then we are thinking patient will not going to take for the years. So semaglutide is also for the years for patients, but when cost will come to their own pace.
May I take the chance of changing the topic to something else?
Yes, change of topic.
Okay, so I'm going to ask a question for you guys. There are 2 questions. Question 1 is for everybody, primarily the EP guys. Like you see on social media and on regular media, a whole lot of sudden cardiac deaths being reported. What is your guys' opinion? Do you think it's happening much more frequently, or is it much more frequently reported? That is one. The second thing is, what do you recommend as a part of screening? Like, who are these people who are much more prone to sudden cardiac death, which are primary arrhythmogenic, or what are those? They are not heart attack, because all non-medico friends, they ask me, why is somebody getting a heart attack at 20 years old? It is very difficult to explain to them that ACS is different than sudden cardiac death. So what is your approach been and what are your thoughts on this?
Hiren first.
So I think not only reporting has increased, probably the numbers have all, we don't have hardcore data for it, but probably the numbers have also increased in the last 5 years. And in a younger age, obviously, because we don't have data from India, but we have data from Western countries that only 1/3 of the patients die because of coronary artery disease causing heart attack and lead to sudden cardiac arrest. Rest 2/3 are actually non-heart attack cause of sudden cardiac arrest. And so the reasons should be contemporary reasons only. There may not be a very new reason, but contemporary reason in form of cardiomyopathies like hypertrophic cardiomyopathy, channelopathies, and probably post-COVID, because data have shown that COVID virus is getting attached to the myocardium as equally as pulmonary. So we have seen a lot of cardiac MRIs nowadays. We are getting, I mean, we don't expect to have, but we get some late gadolinium enhancement, and that patient has presented to us because of PVCs and all. Now, maybe because that patients are not having lethal issues, that's why they are getting detected, and some of the patients may be having significant myocardial involvement post-COVID and having fibrosis, and they're dying because of ventricular arrhythmias, and they're not getting picked up probably. So that is one possibility. But post-COVID, I think COVID virus, here in India, the vaccine was given a huge culprit, but I think COVID virus itself was probably causing more issues in myocardium rather than vaccine. So that's what, and yes, for the detection of, for the restratification or for getting early detection before they goes into sudden cardiac death, so battery of investigations are obviously required, which should be including ECG to rule out channelopathies, where structurally heart may be normal by echo, and obviously echo for looking for structural heart disease. So both are important, ECG for electrical disease, echo for structural heart disease. So once we rule out these two, then third remaining is a subtle coronary artery disease, which we don't know when they have not yet presented to us. So for them, we have to subject them to treadmill test, and further maybe CT coronary angio or CT coronary calcium at least for a younger age.
AI again to read the EKG.
Yeah. But yeah. I have tried to upload many times ECG on basically ChatGPT to just confirm my diagnosis and to look for what ChatGPT is telling. 50% of the time ChatGPT tells something different. Because I think in ECG they have still not yet got that specificity. So, so for using ECG interpretation, ChatGPT, I will suggest that you should have your own mind to be used, because 50% of the time it is incorrect, 50% of the time it is correct also.
Dr. Ajay, you have comment on?
Just 1 second. So, after COVID, have you, like in the Western countries, have you seen the rising trend of sudden cardiac death in the younger population? Like in India, which is very much, this thing is very famous after the COVID waves, and everybody is linking the things with the COVID and the vaccine. So is it the same trend in the Western country as well?
So two trends have come up after COVID. So regarding your sudden cardiac death, the absolute numbers are never high, but like palpitations, PVCs, that went up, level of myocarditis, or I would say subclinical myocarditis. They never came with heart failure, but they would have PVCs, and then you would say an LGE on that thing. So that has increased because of the COVID. But I wouldn't say there has been an absolute increased number of sudden cardiac death, right? But at the same time, we have been consistently seeing reductions in ACS, which was actually my second question as well, is in United States across the board in the past decade, slowly we have seen a 30 to 35% decrease in ACS. The overall population in the West tends to be much more elder compared to India when it comes to ACS. And it was felt is because of early detection, nuclear stress test, statins, people used to get stents left, right, and center, whatever you want to call it. But there was a reduction in STEMIs, mainly STEMIs, primary MI, by 35%. Have you guys seen the same?
No. See, I mean,
because in India it's much more younger people who are
Yeah.
getting primary MI compared to the American population, where the average age is 55 and above. Here I don't know the exact data.
so like, see,
partly
coming to point
that
of
question is partly answered by that also, because Indians as such, young coronary artery disease in young Indians, extremely prevalent, and that is why the sudden cardiac death, it is getting reported faster and quicker and widely because of social media. So it's probably been there, maybe it's marginally higher, but we still have a lot of coronary artery disease in the young. So we are going to
So,
see
I mean,
it.
I mean,
and a
putting
lot of
it-
myopathies being identified nowadays.
Still, I would say that, see, if you look to the data, Inter-Heart trial by Salim Yusuf, which we all know, that 9 modifiable risk factors are responsible for 90% of first heart attack. To me, it stands true even today. Unfortunately, the trend of India and Indians in last 15 years, as far as those 9 risk factors is concerned, has been extremely dangerous. So now we as an Indians are showing exponential results of all those 9 risk factors, which we are doing extremely messed up. Where air pollution has added now, so unless we Indians, I'm very sure, see, COVID would have some role, vaccine might have some role, but still 90% of the heart attacks happening to young will be because of all those 9 risk factors which are going higher and higher. Stress, emotional disintegrity, inequanimity, ultra-processed food, extremely chaotic lifestyle, poor social relationship, disrupted family system, smoking, substance abuse. I have data from police department that at least 50% hostelites in Ahmedabad do consume drugs other than tobacco and alcohol from police department. So these are all things which are increasing heart attack in India. I'm very sure that 99% blame should go to all those existing risk factors. You can find out 1, 2, or 3 extra percentage, but doesn't work much.
Can I counter that thing with one more point? All these things got worse in America, but the heart attack went down by 35%.
Sure. See,
Smoking
because
rates increased, stress increased, social life there
because
is not
preventive treatment has gone tremendously up in US. See, unfortunately in India, we have physicians sitting here, a person who has got diabetes for 15 years, who smokes 10 cigarettes, who has 3 heart attacks, he is on 10 to 20 milligram dose of atorvastatin. That's it. 90% of the patients do not get lipid profile done, either because they don't get it done or as doctors we don't get it done. So we have preventive strategies for secondary and primary extremely deficient, extremely seriously lacking. The day if maybe say 60 crore Indians will start taking statin, scenario will change. But I'm very sure it's because of extremely deficient prevention practices, that's why, and very chaotic lifestyle overall.
You have iron fortified flour, we need statin fortified milk.
You have comments, Satyagupta?
I think there are data that we Indians are more prone for coronary. That is known, no problem.
South
But
Asians.
the thing is that the last many years, the lifestyle changes, as Anish bhai said, has significantly changed. And I have interviewed so many families where there was sudden cardiac death. And if you closely ask them, 90% of the people, they have some kind of symptoms. They just ignore those symptoms. So I think this is very important that if you are younger, but you have a strong family history of coronary artery disease, you should get investigated, at least CT angiography or whatever non-invasive. And if you have quite a few of symptoms, at least you should get non-invasive investigations done. And most of the time you will find that family member that later on they will say that he was having some problem for past few days and whatever. And now the stress factor is also very high in India. And I have seen quite a good relation with the stress with the coronary artery disease or sudden cardiac death. So there are so many things which are changing in India. So I think we are more prone for coronary artery disease, but we should be careful about our symptoms. As soon as somebody in the family have the symptoms, at least they should get the check by the doctor. Just example I'll give. Yesterday I did one angioplasty. One patient came, he said to me that, sir, 1 month before I came with my brother, and मैंने आपको बोला था मेरे को भी कभी-कभी ऐसा दर्द होता है. तो then I said, मैंने आपको बोला था कि आप इको TMT करवा लीजिए. तो आपने सब क्या जरूरत है अभी, ये तो ऐसा ही होता रहता है. And then that guy has MI in the Jodhpur, and then he was angiography was done, and he came to me for the angioplasty. It was a casual conversation, and I just asked him to get a ECG, echocardiography, TMT done, but he didn't go for that. And he just casually asked me, if I would have said, no, you should do it, then he would say, no, I am making like just out of some different interest, I am telling you. So like, no, people are very casual in it. They don't bother about the investigation. I think so.
I have a question and a controversial poll. You know PPI. How many of you used to read about Billroth surgeries, gastrectomies? All of us, okay? Eradicated. So the question I have in a poll, with drugs like inclisiran, twice yearly, 100% once a yearly dose will come, where without obvious side effects over a decade of research in thousands of patients, where LDL becomes 10 and 15, if given on a universal vaccination kind of program, starting at the age of 20s, 30s, yearly injection, twice yearly injection, forget the cost part. How many of you think that CAD can be eradicated in 20, 30 years?
Yeah.
Substantially reduced.
Substantial reduction. So this disease, the medical armamentarian, I believe, Dr. Lucas, you have any comment there? You have inclisiran available in Italy?
Is it feasible?
It is available?
Is it feasible, not available? It's available, but
In his word, he says if it's possible.
If it is feasible, if it's there.
Yeah.
So a lot of us believe that coronary disease over a decade or 2 decades or 3 decades, I'm not sure, I'll be 95 plus, so will be Milan, my colleague. But we have talked about it, Milan bhai. Give your comment. I like Milan's philosophical comments.
I have been telling this since last 30 years
I
in
know.
my old lectures that keep your LDL less than India's normal LDL should be 70, and if you have got any risk factor, positive family
55.
history, or you have history of tobacco use or diabetes or atherosclerotic cardiovascular disease, your LDL should be less than 50. I'm telling since 30 years, and I'm doing that for myself also because I got very strong family.
So are we,
So what
most
I'm
of
trying to tell is, and I've been taking since it is available in India, so almost 30 years. You are also taking since 30 years.
I take inclisiran also.
No, now you are taking that. But it's not required because I am keeping my LDL less than 50 with simple rosuvastatin 20 and ezetimibe 10. I can go to 40 also to reach to 30, or I can add bempedoic acid also. These 3 drugs, if you take this medicine statin from beginning, since early childhood, or say in 20s, I told Lipid Association of India to do lipid profile when they enter the school at 5 years of age. They rejected, they tell guidelines says now 18 years.
Yeah.
But once you do 18 years and you try to keep your LDL low from beginning, then
Yes,
also
but
what
you
you are
have to
telling with
understand.
inclisiran, only
Yes.
thing that compliance becomes better. And
Yes.
in that way, people may take inclisiran rather than taking
So
statin
I'm
daily.
just taking a hypothetical question, I know.
No, you are right,
But
and another
eventually,
advantage-
a once a year injection, or maybe twice a year, on a societal, not suicidal, society prevention is very feasible. Yes, will it be available? I'll tell you, with the cost of generics, etc. Question.
I think, see, Keyur by just putting that point.
No, I
That's
know.
it. See, that's it.
So that is
Inclisiran
what we are
is a
talking.
vaccination. Inclisiran would be a vaccination. If it is once a year, like see, you take a vaccine for polio at the age of less than 1 year, you take DPT vaccine, you take all those names of vaccines you take before 6 years. So why can't
Flu
a child
vaccine,
who is going
flu
to die,
vaccine once
see,
a year.
child is not going to die because of those illnesses in today's world. They are going to die because of acute MI. So you need a vaccine of inclisiran or whatever once a year by the age of 10, 12, 15.
Right.
That's it.
So even there, so we say adherence is a problem for daily, so we give it every 6 months. You all saw the CRISPR in GPTL study. Lifelong, once. Not targeting the
Yes, we know that.
LDL receptor
So-
pathway.
so-
This is
yeah,
lipoprotein lipase pathway. Once, lifetime done.
It is going to be eradicated one day. In my lifetime, Professor Lucas's lifetime, we don't know. But with the CRISPR coming in, it's a new medication, single dose, gone. Now, how much it affects memory, dementia, time will decide. One more question, jumping totally to Dr. Apurva and Milan Chugh. Aortic stenosis, how many of you are aware of TAVI, TAVR? Almost everyone. After the age of 65, and I know Apurva will be talking tomorrow, or Parth is talking, I'm not sure who, but Apurva and then Milan Bhai, after the age of 65-ish, practically unless you have very significant CAD requiring operation, can we presume now that aortic stenosis is a repairable, curable by TAVI? Period. Forget the economic again. Again, economic is an issue, but otherwise, TAVI is the first choice in replacing significant aortic stenosis, whether it's mild, intermediate, or high risk. Apurva and Milan, both of you. Milan Bhai and the team, we have done the highest TAVI in Gujarat, and the first one to start. And Apurva is an exclusive structural TAVI specialist.
You're right. I mean, if TAVI is a good option, and we now always tell patients, especially we do in up to 65 years of age as per the guideline for India. Basically, it is a good option if patient is fit for surgery and patient is fit for TAVI. TAVI may be preferable because clinical outcome is exactly same, risk is same, and it is very easy procedure like angioplasty versus bypass. Only thing that you have to be sure about it, that is decided by patient's root anatomy and aortic valve anatomy with the surrounding structure. So what is the basic test which is required is CT aortogram, by which we see about the distribution of calcium, its relation with the conduction system. We see root anatomy, annulus size, the distance with the coronary arteries, and aortopathy and other anomalies, and how much is the pathway right up to the femoral artery. So if CT aortogram shows that it is a good case for the TAVI, then TAVI is preferable to surgery. There is no doubt as far as results are concerned. It is equally good outcome. Cost is an issue in India because everybody pays from their pocket, and cost difference is almost 4 times. Apurva,
Dr. Apurva, and one more caveat. How young will you go knowing that repeat TAVI is feasible, not difficult, and becoming cost effective? So 65 is a rough cut age, but we have had, myself and Milan, patients in 50s saying, I don't want open heart surgery, and we are kind of forcefully convincing them to have a surgical valve. But if patient comes in agreeing that maybe he's ready to go for 2 more TAVIs in his lifetime, 3 more. So both.
So the entire thought process comes down to a philosophical endpoint, like what is the lifespan of the patient, right? So if you go by the average, an American lifespan is 84 to 87 years, right? What is the Indian lifespan? Data says it's 74 years. So you want to reach to that average value with one reintervention. Right now we have lots of data up to 7-10 years from bioprosthetic surgical valves and bioprosthetic TAVI valves. They have a class effect. Class effect meaning that if you get a porcine, a good porcine, and a good bovine pericardium, all valves do not perform the same, but all the 3 TAVI valves have been performing okay, and some of the surgical valves have been performing okay in a similar way, meaning the valve deterioration more or less is the same. You cannot compare with metallic valves. Like if you're young, if you're 45 years old, you have to live another 30-40 years, the answer is a metallic valve. But if the surgeon says that I'm going to put in a bioprosthetic valve in this particular individual, then TAVI and SAVI both are going to fare the same. If a TAVI is going to fail, the surgical valve is also going to fail. So there is no improvement one way or the other. As Milan Bhai said, we have gone away from risk and we have gone to pure anatomy. Meaning, in America, the cutoff age is 65. The primary reason why guidelines say 65 is because that's how the patients were enrolled. We do not have, only 3% people in all the trials were below 60 years of age. So I cannot answer for that, and that's why it'll never come into the guidelines. And it is basically how it is divided is more than 80 years, whatever may be the anatomy, the answer is TAVR. There is no surgical option there. Below 80 and more than 65, it's the anatomy. If the anatomy is good, you can offer TAVR, the answer is TAVR. If you think that the TAVR is not a good option, the answer is surgery. Then it comes down to whether you need CABG or where you need a double valve, right? Like the main thing is, patient needs a mitral valve repair and patient needs an aortic valve replacement. We should go double valve. Let me ask a question to the group. AVR, MVR, what is the average risk? Risk, surgical risk.
3 to 5%.
3 to 5%.
Yeah.
That is intermediate risk of the bat. There is no low risk double valve. And that is what STS will tell you. That is what Euroscore is going to tell you. When you look at the post data, it goes to 6 to 8%, which technically takes you to the higher risk. The reason why double valve was given to surgery is because there was no percutaneous option for the mitra. Now when you have good defined surgical option like percutaneous options, that's when it comes down to cost at the end. But yes, whether you can do a mitral clip, is the anatomy feasible that I can offer a good mitral clip? Yes. Can I offer a good TAVR? Yes. Then both are two low risk procedures separately where your risk of mortality is less than 1%. Your morbidity is way lower than open heart surgery. And your long-term prognosis is there, it's the same. Then your risk profile just changes. So you also have to understand why double valve comes in the guideline is because there was no other option. That's why it's in the guideline there as a first line therapy. So this will change eventually in the next guideline that is going to come up.
So how many maximum TAVR in one patient, 1 to 3 times?
So far in my personal experience, we have done valve in valve, like 3 up to 3, because these people are like 90 years old, still want to live. So that is an option. So just any valve you put in is going to last 10 to 15 years. Okay? And then you just have to figure out that. So now we have lots of AI softwares as well. There is a software called DASI, where you can simulate, you can put in a valve and see what is going to happen. Because the main thing when you come for the second time is coronary protection. You just don't want to shut off the coronary with the leaflet. So you can put in a valve and see, can I do a second valve in its place or not? And if the second valve, that AI software will help you decide that. If that is possible, you can go with the TAVR and then do TAVR followed by TAVR. The other option is, let's say it's not a good option, like you put a TAVR valve and everything is just going to be blocked off. Then you can talk about, do you just want to enlarge the root, implant the coronary higher and put a surgical valve, and then the patient comes in 10 years and gets a TAVR valve in valve afterwards. So right now, CT scan first, and then depending on the anatomy you decide. That's where heart team comes into play. The world is changing, like, a decade.
Maybe 60, 65 go for TAVR. Maybe 75 go for TAVR. That's how people have started.
45 Saver, you and I both know, 5 years that valve is done. Irrespective of whatever brand you put in, like 45 is metallic valve off the bat, unless the person has some kind of field work or something and say, I'm not going to take Coumadin, that's a different story. But 45 years old, whatever valve you're going to put in 5-7 years at the most.
In India, most of the time 55 is the cut point for metallic. Up to 55 we use metallic valve. After
Mike.
tissue valve. It's just about not only 45, up to 55. Most of the surgeons in India put metallic valve. Any biological valve will last for 10 years, not more than that. So whatever surgeons or company says that our valve will last for 20 years, no. Biological valves fail.
I think just one idea. I think to our surgeon, we can tell whatever AVR you do at the young age, do with the tissue valve and change the coronary attachment is slightly upside. So in the future they can go 2 times, 3 times TAVI, whatever. So I think this will come in the future.
It also depends on the surgeon itself. Because when you start doing aortic valve plus root plus reimplantation of the coronaries, that 3% risk is now going severely high. It also depends on the surgeon. So for example, in America, the average number of pure AVRs done by one surgeon, do you want to guess? How many AVRs are done by a surgeon? Average number, meaning 50% people are doing that.
Per year? Per year?
Per year. AVR per year per surgeon.
24 per year.
Lower.
Less than 24.
4.
Really, eh?
4 AVRs per year.
Anyhow,
I don't know the thing in India, a cardiothoracic surgeon, what is the average number of AVRs done by a cardiothoracic surgeon? So then we have to come to the discussion of the experience that when you are telling me that you should not do a TAVI because the patient has CABG, like needs CABG plus AVR, meaning it's a high-risk patient, and then it's done by maybe an average surgeon where the risk is even going to be higher versus a percutaneous option could be offered by an experienced center. So it all comes down to that level of discussion.
I think we have to close this session. Very exciting, very innovative. We have to reach Hyatt Regency. You know the address, 7:30. I'll just end with a couple of AI. We asked them, how about CRISPR technology and LPA, little a reduction? The new drug, Percaselan, is available. Will be available in India in a couple of years. We are part of the Horizon trial, right, Urmil? We are one of the larger group. It says CAD will not be eradicated, but it could become a rare, delayed, far less lethal disease, in many ways parallel smallpox. Single cause, single pathogen, CAD, chronic systemic disease, not a single target illness, but with a mass reduction of safely LDL and LPA can make this a very rare manageable disease. So good luck. No more cath labs. None of us interventionists sitting here becoming clinicians, maybe looking into obesity eradication and other branches. Thank you very much. See you tonight. Thanks.
What James Bond said, somebody has to pull the trigger. Those who are doing procedures, somebody has to do the procedure.
Like we can go back to.
So all of you are coming to Hyatt, right? Not tired yet? Good. Ready for more.